Подтверждая
Good morning, dear guests.
I will be speaking in Uzbek, and we have simultaneous translation. I'm very glad to see you here at the 20th anniversary of Oncologists of Uzbekistan. And we have conducted number of congresses related to different diseases, different specializations in the medicine, and it's the first time when we are conducting this kind of big conference for oncologists and radiologists. And we are planning to discuss many priority issues, and during 5-6 years we had revolutionary changes in our country. First of all, under the leadership of our head, which is paying a lot of attention to development of the medical sector. And for example, before we had only 5 equipment available for these purposes, and now can we compare for the chemical therapy, for other treatments, these all medical available available in amongst the immune histological treatment for almost 95%. And I can say that currently in each branch of our hospital we have immune histology treatment equipment and screening, and I think it's a huge achievement. And it's achievement of our oncologists, of our doctors who were specifying what we need. It's the achievement of our team, and we have new equipment. We have a new center for oncology, which is almost finished and ready. And today's event, first of all, is dedicated to the breast cancer and the cervical cancer screening, because our oncologist has put a lot of efforts in improving this sphere. Starting from 2012 for the cervical cancer, and starting from 2016, breast gland cancer is the most important. And we have a huge experience for the cervical cancer. We have number of centers in Pakistan and Chirchik, and we have starting from 2021 we have a breast cancer screening, intensive screening I would say, and therefore today's event is mainly dedicated to these main 2 topics. Today's event, and tomorrow we will discuss some other aspects too, of course. And regarding the nosology, this conference has invited the leading specialists from different parts of the world. We have leading specialists, professors here with us, and we have asked them several times that we need the expertise, we need their master classes, and they are all now with us. And with your permission, I would like to greet Stephen Connor. Stephen Connor, are you here with us? So please, yeah, could you stand up so the others can see you? So the executive director of the World Alliance of the Hospice and the Palliative Care. You can take your seat at the panel stage. Mr. Harkar, Danish Harkar. I think the entire Republic knows you. Merlis Publics, you are well known here. Our specialists know you very well. It's almost 10 years we are working together on the screening, within the screening programs for breast and cervical cancer. Philip Davis, Jesper Bande. Philip Davis from the UN Population Fund. Jesper Bande, he is a very famous person. He is a senior researcher in the molecular pathology, in particular for the screening of the cervical cancer. Fatih Aygar, I think you all know him. And the number of guests. Ilya Alkov, are you here? International Association
зарубежных стран
of HPV combating, and we have other representatives of screening and the treatment departments today and tomorrow. Bartabasu, Karvon, Benival, they will join us later, and Safu, she will also join us online mode. She couldn't come to Uzbekistan, unfortunately, and by the end of my welcoming speech, I would like to greet you all and congratulate you with the start of our Congress work, and wish you successful conference. Thank you.
кейінгі сөз сразу рұқсатıyla
And the next law I would like to give to the Association of the Uzbek Oncologists Chairman Abdulwahid Valiyevich Hadjayev.
Assalamu alaikum.
Good morning, dear participants of the conference. Today it's a pleasure for me to contribute in the opening of this conference and welcome you all. I wish you good health, all the success. This conference is dedicated to such a urgent topics. The 20th anniversary topic is dedicated to the health of women, which is very important. You all know our mothers, sisters, and grandmothers, their health is very valuable for us. And this conference, if we tackle such issues, such types of cancer, cervical cancer, breast cancer, and I believe if we achieve good results, that will be valuable for all of us, because the speeches, the reports which will be presented at this conference, they will be, I believe, full of new approaches, new results on this topic. And I would like to welcome you all again, wish you all the success. To the speakers, to the presenters of this conference, I would like to wish all the best, and I believe that this conference will bring us lots of fruits, and especially will give an opportunity for our patients to cure. I believe that our conference will be very successful. Thank you very much. Then we would like to give the floor to the representatives of the regional World Health Organization, WHO, the main advocate of ours at the screening, Mary-Liz Corbex, please.
Thank you very much. Thank you, Yario. I'm very happy to be here. I must say that to come to Bukhara for me was really a very emotional experience, because I began to dream about Bukhara when I was 8, when I discovered photo of this wonderful city in a book that my parents had about, Islamic art around the world. And I fell in love with Ispahan and with Bukhara photo. So now I am in the photo. I'm so happy to be here. And I'm happy also to see all these great people who are fighting against cancer in this country. I have been working with you, maybe not since 10 years, because otherwise I will feel terribly old, but I think, let's say 7. Yes, I will not be long. Thanks for being here, and thanks for welcoming us and welcoming the collaboration with WHO.
Thank you very much, Mary-Liz. Thank you for such a nice introductory words.
By continuing our ceremonial part, we would like to present the Deputy Head of the Bukhara Region Ministry of Health, Dr. Abdul Hakov. As you know, the conference will not be able to be established without cooperation between the regional center and the Republican Center. So thank you very much for your contribution. Wish you all the success. Thank you, dear ladies and gentlemen. Today in Bukhara we have a very important event that we are organizing, and the topics dedicated to breast cancer and cervical cancer are very important, are very actual and very urgent. That's why we are organizing the conference on this topic. As Dr. Mirzaghalib Tilashay have mentioned, this is a very large conference, very huge conference. Some time ago there were construction works ongoing, and now we have opened our facility since recently, and in many topics of healthcare in Uzbekistan. I can see Dr. Isakov, who is a virology specialist, director of the Virology Institute. He's also present here. In the contemporary healthcare, cancer is one of the urgent topics. In the 2018, the president, while visiting Bukhara, in the Bukhara region has been supplied by mammograph equipment in all the districts, and this was a support to Bukhara region. And at that time, the minister at that time, Mr. Alisher Kayumov, worked overnight and has prepared those works in the breast cancer and Bukhara. This is a very important topic, and the president has ordered to develop breast cancer facilities. And among the CIS countries, in every region, one mammography at least was supplied at that time. What is important on the oncology topic, this is first of all prevention and then early detection and screening if we do them on the appropriate level, not only in Bukhara, but across the Uzbekistan, there will be a large step forward in oncology. Last summer in July in Tashkent, when I was visiting Tashkent with my professional issues, I have seen the construction of the Republican Center in the Tashkent Medical Institute. Indeed, this is a very, as it has been mentioned by Dr. Asilbek Envarovich, this is a mega project, and if we develop such mega projects, I believe that our population, our people will be grateful to us all. I welcome all the participants, international speakers in our ancient soil of Bukhara, and wish good success to the work of this conference. Dr. Ikhtior, thank you very much for your welcoming speech. Please take your seat in the panel. The development of any sector will not be able without international cooperation. And the next word in the online mode will be provided to our great friend from the United States of America, who is always for us, and she always achieves that Uzbekistan receives the best of the best. Sophia Michelson. Sophia, please, the word is yours. The floor is yours. Thank you very much. Thank you very much. I'm really touched that I have been invited to give a speech, and I'm touched that I had an opportunity to give floor at the opening speech. I started to work with Uzbekistan in 2015, and as Merrily said, I'm really in old age, I feel, but I'm happy with that. And I'm happy for people of Uzbekistan for that level and for such a real great efforts that have been made within recent years, of which I will be covering in my presentation later. I am really happy to participate in this conference, and I will later explain why. Thank you very much. Thank you very much for being there and for your efforts that you do within all these long years and productive years. Thank you.
Спасибо.
Thank you very much, Sophia. We are loving and missing you here, and hope you will be able to come to the opening of the center. And the next law is given to the Executive Director of the World Alliance of the Hospice and the Palliative Support Assistance. It's my second mentor, Stephen Robert Connor.
It's a real pleasure to be in Bukhara, and I've worked a lot in Central Asia, but never had the pleasure of coming to Uzbekistan. It's been really an important country that we feel we want to support in provision of oncology services. My organization is an alliance of hospice and palliative care institutions around the world, 103 countries, including Uzbekistan. We have to think of palliative care as one of the pillars, one of the four main pillars of oncology care. Of course, prevention, early detection and screening, treatment, but also palliative care. Cervical cancer has the highest incidence of serious health-related suffering of all the cancers. And unfortunately, many of the patients are diagnosed later rather than sooner. So it's really important that we build this from the beginning. Uzbekistan has an opportunity to become a leader in Central Asia in the development of oncology services. And with now the 20th anniversary, there's a turning of the corner in provision of services to people throughout the country. I look forward to speaking and to spending time with all of you, and be assured that we are with our colleagues all the way as you develop services. Thank you very much.
Thank you very much, Dr. Connor, for a warm introductory words. И последнее слово.
The last greeting word is given to the very important person for the oncological sector of Uzbekistan when we were starting in 2017 under the leadership of Nigmatovich. We didn't know what to do first at the first stage, and that time our friend, our partner at the world arena, Mr. Bernard Carr, helped us, and with his support we were able to improve our diagnosis and treatment protocol standards. And of course we have learned a lot from you, Dr. Denish, and I would like to give a floor to director of the Sarvadoya Clinic, Dr. Dinesh Pendrakarkar. Good morning. It's a big honor to be here amongst you. I know all of you, and I'm very proud to be amongst you. Uzbekistan has achieved a lot in development of the oncological services, and I myself am sure that you do not estimate the real achievements in your countries, because the results, the outcomes are serious. For example, in the sphere of screening of the breast cancer, Bukhara has finalized the screening of 200,000 women during 2 years. And I would like to thank all oncologists of Uzbekistan, Dr. Tereshakov and the others who conducted this program. And despite the COVID year, this is a really good result. And currently we have the similar program on the cervical cancer screening in Urgench. And I am sure that these two programs can improve the position of Uzbekistan in the rating, in the world rating. And I think that Uzbekistan can serve as a model, as a best practice for the Central Asian region. With these limited opportunities, Uzbekistan was able to achieve these serious results. Once again, I would like to congratulate you with these achievements, and I would like to thank you for the invitation. Thank you very much, Dr. Dinish. And according to the WHO, 44% of oncological diseases can be prevented. And amongst those oncological diseases, there is a virus associated diseases such as cervical, liver cancer. And we would like to thank the academician of the Academy of Science of Uzbekistan for accepting our invitation, and I hope that our cooperation between our centers will be strengthened. Irkin Isakovich, the floor is yours. Thank you very much, Mirza Galip Nigmatovich, for the invitation. And when I'm giving the lecture to the students, I'm always asking, do they have a vaccination against the cancer? Some of them do reply and some of them do not. But we have the vaccine, almost vaccine, against the hepatitis B. And we have started the vaccination against the HPV, and I think we will be able to combat this disease too. And I think that only with the initiative and support of our president in 2017 we have started a big program for the screening of the hepatitis B and C, we have developed number of screening centers, and I can say that for the last years we were able to conduct screening for millions of population for these B and C hepatitis, and we have very few programs, maybe like about 10 or more of similar programs, and we were able to implement this program screening for alpha fetoprotein and the screening on for liver cancer. And our institute is responsible for virology, technology, improvement and introduction of innovation in this field. That's why we are participating in the screening of HPV virus in Tashkent and Dijon and Samarkand. As you know, this is very interesting sphere of medicine, because all my entire life I was doing working in the different sphere, but this field was very difficult, was very interesting for me, and I would like to greet you all in this conference. And 20 years anniversary is a significant result, and conducting this kind of conference requires a huge effort.
Спасибо вам огромное за приветственное слово. Но далее мы плавно переходим.
Thank you very much. Now we are moving to the plenary sessions, and in our plenary sessions we will have different speakers. I'm participating in different conferences, and the first report is the most interesting one. Usually it covers all achievements, gaps, and things need to be improved, and we would like to give a floor to the director of the Center of the Radiology and the Oncology. He will be talking about the difficulties and success of oncologists in Uzbekistan in the breast and cervical cancer. Thank you very much.
Dear colleagues, my presentation will be in Russian. I would like to demonstrate our achievements, what we have achieved yesterday and the day before yesterday. We have thoroughly discussed about the gaps, about the challenges, and they also admitted that they had some challenges with the cancer program. Dear colleagues, from your permission, I will outline first of all the figures. In Uzbekistan, in the Republic, we have the indicator of 73, the intensity of incidence, but we have a lot of specialists from outside the country who know the figures very much. 73 means this is the average indicator. 143 is in Tashkent. Why is 73? Because we have a large population of young people, and in other countries they have less young people, more older people. That's why in Russia it is 260. In Europe, 400. In the US, 362. The incidence of diseases. These are our numbers of incidence. The structure of oncology. I would like to draw your attention among men. First of all, the stomach cancer and colorectal cancer, and in women this is more breast cancer, cervical cancer, and ovarian cancer. I would like to draw your attention that among within the 7-8 years, we have growth of the first-time detected patients. This is good because specialists understand. As you know, we are working and traveling since the year 2017 to the field examinations. We have lectures. We have 14 groups who on the schedule travel to regions on Friday, Wednesday, on Monday, Wednesday, Friday, and one group on Tuesday, Thursday, Saturday. Another group, surgical operations, lectures, contemporary methods of X-ray therapy and other types of therapies are implemented, and certainly screening. I would like to mention that only at the expense of professional examination, by 20-30% the early detection has increased among patients, and this is first of all the work of oncology specialists. The number of patients registered, now it is 665. Now it is more than 28-30,000 patients. New patients have been registered. I need to say that this is important because diagnosis has improved all across the country, and the status of healthcare is absolutely different from what it had 5 years ago. This is the implementation of new methods that allowed us to detect patients who passed away because of different pathologies. This is the stages 3 and 4 in the country is almost 15% all across the country, which is not bad, and the stage of the advanced stage is 41%. This is not bad. In Japan, in the US, it is 68 and 72%, and I think in 10 years we will achieve, if our progress will be maintained, an intensive survivability is 40%. I'm sorry. So it is 5-year survivability, 40, and mortality in average. I'm sorry, I have different slides on the right slide and the right-hand side and left-hand side. The mortality 38 in average across the country. I can tell that Tashkent is the indicator. The real number is 52. We always take Tashkent as baseline. 1 year mortality 15. This is quite low, but these are the numbers for our epidemiologists from abroad. I would like to say that it should be 23, 24 in reality, but we have 15. We have several times reviewed these numbers. I myself studied the details. So the annual mortality, the highest 21 in Tashkent. As I said, we take Tashkent as the baseline. Oncological incidence is 7.8%. The highest is cardiovascular diseases. What I want to say that in the last years, 4 presidential decrees and cabinet of ministers decrees have been approved, and with this we have achieved a progress in oncology, early detection and treatment. After the 2017 decisions, we have developed the network of oncology service. We discussed that in the Ministry of Health with transferring to the Republican Center, and we have 15 branches, and we have a vertical structure with the treatment, with standards, and so on. And I believe that this is a good progress. One of the most progressive thing to convert dispensaries to the Republican centers. As to the beds, we have increased by 128 beds, but we need to increase the number of beds. Within the 30 years, we have decreased the number of beds, and still we have to increase the number of beds, not by 300 or 400. You can calculate how much if we increase the beds in the regions. So we have 4 projects for projects, reconstruction of the centers. The capital rehabilitation has been done in 3 branches. 3 branches have been fully reconstructed and newly constructed. As you know, in our branches, the brachytherapy, X-ray therapy equipment has been installed, and so on. A lot of equipment has been provided on the $38 million. The second stage is which is going on now, which will be completed by 80 million US dollars. This is the project of the modernization of oncological facilities, linear accelerators, brachytherapy facilities, angiographers, MRIs, MSCT and MRIs, as I said, will be installed in the branches. The third stage, this is a new oncology center, as you can see it on the picture. The treatment building has been established, and the basement is being constructed now. And I believe by June we can start the commissioning. This is the largest oncology center in Central Asia, which can accommodate 780 patients at the Tashkent Medical Institute premise, with the nuclear medicine center. Not 16, but 17 operational center. One will be emergency center. And the fourth project for the years 2025, 2030, this has been signed, and it is under development. The president ordered that the fourth project will be established, the Uzbek-Korean project, for the 150 millions at the Parkent Street, next to the Korean cluster. There will be oncology clinic constructed for the 265 beds with $150 million, and this will be the 4th level clinic. But this is a plans for the year 2025-2030. As to the medicines, by 90% supplies have improved, and palliative care. 8 years ago, we did not have any palliative care. In all the branches, we have opened the palliative care departments, opened in all branches. Radiotherapy has been re-equipped, and the hospices. You know, in Fergana, Urgench, and in Samarkand, there are hospices. The only thing is Tashkent, despite it is a large city, they still cannot construct yet the hospice there, at least a small one. I always say, despite Tashkent is a large city, since 2018 they cannot complete the hospice in Tashkent, and they construct those 50-story buildings in Tashkent. The foundations is there in Durganch, in Samarkand, in Fergana. The hospices are operating, and in Fergana it is under construction to be commissioned soon. international cooperation, I would like to mention that we have a lot of MOUs signed with such a leading clinics from France, England, India, US, Russia, Turkey, 22 MOUs, and within the last 4 years, 236 young specialists from our center and more than 150 oncologists from the Republic attended capacity building trainings covered by the government, covering per diem travel and accommodation from 1 month to 3 months, and one member of staff visited Korea for 6 months, and low invasive technology laparoscopic operations, not only appendectomy, radical gastrectomy is done, extirpation of estrophagus, gemmectomy, resection of nephrectomy. Nephrectomy is done at the level of hysterectomy, prostatectomy, cystectomy. All these laparoscopic operations can be done, and we are proud of the fact that within 4 or 5 years, such a giant leap. Before we could not do, we ourselves didn't want to do such operations, but now we are implementing these operations. On the second tranche of the project, in all the branches, the contemporary laparoscopic equipment will be installed. Now we have only 5 branches. The work done in the branches, certainly not a lot of work has been done. I can describe that work in detail. Many operations, more than 60,000 patients have been covered. Lectures have been supplied. Lectures not only for the healthcare providers, to the nurses and the cleaners, midwives, and when the what is cancer, when to refer to doctors, so that we can have early detection of cancer, colorectal cancer, as to the esophagus cancer. We have started this this initiative since 2016. And I need to say that in 2018-2019 we have started the international experience and pilot project in Bukhara, which has been initiated by the visit of the president, who approved equipment of 13 stationary and 2 mobile mammograph offices. And since the year 2021, I remember the date, on the March 21, the mammo screening is done for women, and very successfully. After the studying of these outcomes, that was a pilot region. In all the regions, the mammographic equipment is purchased, and mammography screening is done in all the regions. Only 32 pieces of equipment of mammography screening, 16 stationary and 16 mobile, are operating, and it is planning to purchase 195 units of mammography equipment. As I said, this has been initiated by the president of the country in April 2019. And responding to the question what mammology specialists need, we said that the mammology equipment is needed, and this is the equipment that can prevent the breast cancer, and as a result, mammography facilities equipment has been purchased in Bukhara. This is the mammography equipment in Bukhara.
Впервые началось, да, и за полгода было...
For the first time, we have started this in 2021, May 2022. Total 327 women were identified with the breast cancer, and they were successfully treated. And regarding equipment, I can say that we have a tomosynthesis and the reserve energy supply system. And in our Center for Oncology, we have reading centers. All data is being gone in a centralized mode to our center, and these second and third readings are being conducted for each center. It's a big achievement, and this reading center was introduced in other provinces too. In our republic, second and third mammographical reading is being conducted by our center. And what are advantages is one, centralized unified database, centralized expert double, triple reading with the use of artificial intelligence, and so that was very helpful. And beside this, in each cabinet we have, as you can see, good equipment, not only for the mammography. We have the ultrasonic screening, mammology, laboratory stuff, and so on. And this is the integration based on the GPS. Each vehicle is equipped with GPS. We can conduct monitoring, control where they went, for how many days, and we have a call center 24/7 available. The dispatchers are replying to all questions and requests. Not only doctors are calling us, but the population. And regarding the algorithm of the mama screening, first is screening. The oncological branch is conducted biopsy screening analysis, and if it is positive, then we are conducting radical treatment. If it is excluded, then annually the patient conducts mammographical screening. The results for Uzbekistan, as you can see, 308 308,000 women, more than 308 women were counted in Bukhara for the mammographical screening. Per month, there is 1,400, and by year is 626 new cases were identified in Bukhara, about 1,000 in Bukhara, and in the Republic I can say that the total number is 1,500 or 2,000 cases, and about 600 in Bukhara were identified, and they were all successfully treated. These figures for entire Republic, 68%, it's a first and second stage of the cancer, and those patients can be successfully treated and recovered. Of course, it depending on the stage. This is mainly for Bukhara. Mainly it's 68%, it's first and second stage. Histological structure includes different invasive carcinoma, last year in December we were in the US Congress presenting the result of experiments conducted based on the mama screening results at the World Forum, and we have made our presentation very successfully, presenting our huge experience of conducting our mammography screening, and it's a big work has been conducted, I would say. And we have, of course, a lot of problems. And yesterday and today we have discussed this with our problems. Of course, they can be solved. They are similar with other countries, and that's easy to solve. So to solve them here, because we have a vertical system of management. We have hakimiyats, mahalas, like district level administration, and the mammography screening is being easier to organize compared to other countries. And what are the results? For the first time, we have introduced this mobile and stationary mammography rooms and equipment. We have trained specialists. We have introduced information system database, digital archives, and so on. And we have identified some organizational problems to conduct these procedures. And besides the procurement of equipment, we need to focus on the administration. Regarding the screening of the cervical cancer, we can say that
Мы занимаем.
it's a problem, and we are working on it starting from 2011-12. We are participating in different world congress forums, and at least once per year, but then in average it's like 2-3 times when we are participating in the specific cervical cancer screening. And of course, we are widely introducing these screening problems for the cervical cancer screening in our country. This is the trend of development starting from 2011. About 960 patients are being identified, and about like more than half of them have they are fatal cases. And of course it depends on the stage at which we identify these diagnoses. And if we wider introduce this screening program, we can prevent 85% of this cervical cancer. The 90% of this cervical cancer is being contributed by the HPV development, by the HPV virus, and we need to combat HPV virus too. And through combating the HPV, we can decrease the cervical cancer rate in our country, as it was done in other countries. And Uzbekistan is included in 6 countries conducting joint programs under the WHO preventing and screening of cervical cancer starting from 2016, such as Morocco, Myanmar, Mongolia, Uzbekistan, Bolivia, Tanzania, and our staff is actively participating in the work of these activities by WHO. And the plan of actions, we are working with the World Health Organization, and we would like to thank our experts.
К нам в Узбекистан, это ее не первый визит.
We would like to thank Merely Scopes for contributing to development of the plan of treatment and protocols. And we had a pilot cytological screening program within the global joint program of UN for preventing the cervical cancer. And in 2019, we had a significant achievement in our republic. We have initiated the vaccination against the HPV for girls of 9-14 years, and we have almost covered 99% of girls of this age. And when we were presenting these data abroad, people were saying that it's impossible to achieve this 99% coverage. But I would like to say that we have a small country, and of course it's much more easy to organize this kind of vaccination campaigns, and we have this vertical structure, like we have Mahala district level self governing institutions helping us to increase this coverage. And also we are planning in 2022-2026 expand these pilot programs for DNA testing, and in 2025 we are planning to launch the national program for the screening of cervical cancer. This is the data for HPV for this first vaccination campaign for girls from 9 to 14 years. We had a very good result. It's a primary preventive measures for preventing HPV, and we have initiated in October 2019, and you can see the trend, the dynamic of this vaccination rate in October, November, and this is of course due to the increasing awareness. We have conducted many interviews, propaganda campaigns, and increasing awareness on the importance of this HPV vaccination against the HPV to combat the cervical cancer. And of course the other medical institutions are helping us in increasing awareness, and thanks to them we have successfully conducted these campaigns. What other measures has been done? We have conducted different kind of increasing awareness campaigns, interviews, visiting schools, flyers, brochures have been published. A huge work has been done, and as a result we have a good rate of vaccination. And what are the challenges? We can say that these poor linkages of the gynecologists, of the primary care, and the gynecologists and oncologists, lack of capacity of local specialists, measures requiring regulation regular project monitoring. And what are achievements? The coverage of 98% of women in Karakalpakstan and 95% in Chirchik, and 95% in Karakalpakstan and 99% in Chirchik colposcopy. And under the leadership of the Ministry of Health and the other medical institutes, we are conducting joint activities and drafting the future programs. And starting from 2025, we are planning to start the cervical cancer screening program. And of course the screening is the advanced field. In this field is a screening register of the cancer cases. The register development is ongoing, and of course the another problem is the hospices. We are planning to launch them in Fergana in Tashkent, and transplantology can be also the other advanced direction for development. Thank you very much, and if you have questions, I will try to answer them. Thank you very much, Mirdina Matovic. I would like to make a couple organizational announcements. At 10 we will have the new researchers competition in Samarkand meeting, and downstairs during lunchtime we will have a bus for to reach the venue of lunch, like lunch venue. That's all. Now I would like to give a floor to the next speaker. Dr. Abdulganievich.
Слово представляется
Sophie Michelson. The floor is given to Eurasian Alliance for Combating the Cancer, America. Dr. Sophia Michelson will make her presentation remotely. We can't hear you. Please unmute your microphone. We can't hear you. Please unmute your microphone.
Извиняюсь за техническая заминка.
We would like to apologize. We have some technical issues.
Thank you. Do you hear me? Okay, excellent. American Eurasian Cancer Alliance is a strategic collaboration in cancer control with mission to pool intellectual and scientific resources of all member institutions to further research and discovery in cancer prevention, treatment strategies, and, of course, quality care. Next slide, please. American Eurasian Cancer Alliance had started its initiatives in 2001. Started it originally with Russian Federation. In 2015, actually 2014, the decision was made to enhance the presence of American Eurasian Cancer Alliance in Eurasian perimeter. The question was where to enhance it first. I was a big proponent and I was a big advocate of Central Asia to start with. There were lots of what's called competitive territories, but I have insisted that the cooperation in global cancer control will move into Central Asian perimeter. Why? Because I could not hear that there was some land near China or south of Russia. I wanted presence and I wanted the identities of all countries in a global arena, particularly Uzbekistan. So when the decision was made where to unite the Central Asian countries, Kazakhstan, Kyrgyzstan, Tajikistan, Turkmenistan, and Uzbekistan, I have personally was big proponent of placing Cancer Control Leadership Forum in Tashkent. And that was made based on many decisions, but to me, I was able to prove that Uzbekistan, being progressive and being motivated, being a very peaceful nation, and yet oriented towards and focused on progress, was the ideal location. And I'm very happy that I was right. American Eurasian Cancer Alliance worked with National Cancer Institute and all global organizations, WHO, UICC, IARC, during that forum, that united leadership of Uzbekistan cancer control programs, as well as all neighboring countries. There were many programs and resolutions that come out of it. Uzbekistan gained visibility, in a way, different weight in certain perimeter, in a certain composition of it, and gain visibility. After 2015 Cancer Leadership Forum, based on declarations and resolutions that were accepted, several programs have been initiated. Next slide, please. So the Alliance's major focus is in strengthening research, strengthening education, and strengthening policy programs, sometimes all together or by preference to each country in each individual direction. Next slide, please. The coordination of American Eurasian Cancer Alliance is presently out of Johns Hopkins School of Medicine, Johns Hopkins University, which is one of the best, 5 best comprehensive cancer centers in the United States. Strategic alliance partner is Atrium Health. In fact, representatives from Atrium Health breast cancer control programs will be delivering a lecture in your breast section. This conference founding member is Fox Chase Cancer Center. However, based on the program, American Eurasian Cancer Alliance unites efforts from many institutions and, what's extremely important, also from many international societies. For example, my dear friend and colleague, Nargiza Zahirova, a liaison of American Eurasian Cancer Alliance in gynecological cancers, works very productively with international gynecological cancer societies. And we have been developing several programs optimizing the efforts of joint cooperation with them. Right now, I have in a beautiful podium in the Presidium, friend and partner, Dr. Stephen Connor, who is working with who's a Worldwide Hospice Palliative Care Alliance, working with American Eurasian Cancer Alliance on palliative care programs in Central Asia and Eurasia. So we bring partners per priorities, not per specific law or order. Next slide, please. So American Eurasian Cancer Alliance has been focused on several areas. Right now, we work in Central Asia, light touch on Caucasus, Central and Eastern Europe. I have a very large program unfolding right now in Ukraine, and Balkan Peninsula. Next slide, please. For strengthening global cancer research, first of all, I would like to thank Mirza Gleb Nigmatovich Teleshakov for his vision. We have a long-standing friendship, and actually this beautiful plate was presented to me at the ESMO platform, where I formed, based on Cancer Leadership Forum in 2015, where I opened in ESMO and ASCO platforms presentations on progress of Central Asian leaders for national cancer control plans. So that was a beautiful picture, was taken during that specific presentation, where each country on the platforms that never had anything to do with Central Asian perimeter pretty much, finally heard the voice of Central Asian leaders, particularly Uzbekistan, on progress in national cancer control planning. My major focus right now for all the partners is to strengthen cancer surveillance programs, support implementation of Central Asian
поддерживать центральноазиатские исследовательские программы в этой области, в гинекологической онкологии и в урологическом онкологии, раке молочной железы, также программа детского рака. Также мы создаем и строим программы по работе с партнерами. Несколько исследований очень продуктивными. Действительно, в Узбекистане была очень большая работа по исследованиям в области
wonderful results, and I know the study will perhaps publish soon. Next slide, please. The result of all science is peer-reviewed publication. From my standpoint, it's a wonderful gauging element, and I'm very happy that Uzbekistan have been very proactively publishing in wonderful peer-reviewed journals, highly respected and highly appreciated contribution from Uzbekistan researchers. I'm looking forward to be working with new facility, new platforms that will be in a new cancer center that is opening up. I cannot wait to enhance research programmatic support that will actually also contribute to science worldwide. Next slide, please. Promoting research, education, and training, that has been past 20 years my very big priority and partners' priority. We conduct fellowships in American and European institutions in all specialties. In fact, you have a beautiful, you have a great moderator of the this Congress, Dr. Yahu. Right after Cancer Leadership Forum, one of the first educational programs was with his participation in palliative and hospice care. Just as an example, I know that we are right now having a great success in opening a virtual tumor board in gynecologic oncology. Looking forward to be following up with this similar format in palliative care. So from my standpoint, education can be both in person and virtual, as long as it enhances the training, enhances the know-how. I also try to optimize global platforms of ASTRO, ASGO, ASMO, absolutely anything that is within a reach to build sessions with Central Asian and Uzbekistan participation for educational purposes that will actually contribute, and usually do contribute, to the expansion of the research programs. Next slide, please. Supporting innovation and policy programs. I know Mirza Leknivach had mentioned phenomenal progress in HPV vaccination, and that certainly resulted in lots of policy. I'm very, very thankful for global organizations to support such a great initiatives with Uzbekistan. From our standpoint, we do absolutely partners of American Eurasian Cancer Alliance, collaborators and stakeholders do absolutely everything possible in usually per country priority to bring as much progress in policy as we can. And I know that we will be working hopefully soon with Uzbekistan on palliative care policy work jointly with Dr. Connor, and Dr. Zahirova and I will be working in gynecological care to the best of our capacity. Next slide, please. This is present Uzbekistan priority. This is a wonderful picture from 2015. The forum was very unique because they were very much what I call it first things for the first time that were done in Central Asia in general, in Uzbekistan in particular. One of them in 2015, we have incorporated very robust palliative care session. In fact, Dr. Eric Krakauer, who was leading the palliative care session for the forum, right after that session on a floor of Tashkent Hospital, was invited by WHO to be their expert in Moscow, I believe. Two directions presently that American Eurasian Cancer Alliance is involved in Uzbekistan. One is palliative care, and another one is gynecologic oncology. I am immensely thankful to Dr. Zahirova for a tireless effort to elevate gynecologic oncology in the country. Monumental effort has been done not only in cervical cancer, but throughout the whole gynecologic perimeter. And we are looking forward to expand existing gynecologic oncology programs. We are looking forward to work in trophoblastic disease. We are right now engaging all the partners in the societies in Europe, in United States, to be working in that direction. Definitely a lot to be said for virtual education process that we have started, and I would like to expand and continue. Would like to organize practical courses both in Uzbekistan and on US platforms. And next slide. The next slide is a difficult slide for me to present. I, all of a sudden, a few months ago, from Executive Director of American Eurasian Cancer Alliance, become also patient number 10/1967. We are numbered in United States for privacy. And to make life a little bit even more exciting, the number is indication of your birthday. So every time you are called with a number, the reality sinks in that actually 67 gets further and further from the existing months or a year. Without any joke. From being a ovarian cancer patient, for all this time being a ovarian cancer patient, it actually brought me even more perspective on importance of cancer control programs that I was doing for so many years, and importance of the cancer fight. In fact, as they say, there is no experience that is a bad one. Like there is no bad publicity, there is no bad experience. I would say that I am in a way thankful for this particular experience of mine. Why? Because it gave me an absolute unique insight into how and what needs to be done to enhance cancer control programmatic support, how to be more effective, how to be more productive, and how to prioritize. Certainly, I know that the priority of preference is cervical cancer, but I will continue working throughout the whole spectrum of gynecological programs, with particular focus also on ovarian cancer awareness, advocacy programs, hopefully screening, and hopefully prevention. It's a deadly and very asymptomatic disease that needs to be paid attention to. I would say the following. I know that only Allah knows how much we have left on this earth. We don't know. But what I do know for sure, 100% confident, that one day I play away from my carcinoma will be directed towards your efforts to enhance your power to fight cancer on behalf of your patients. That I know 100%. So you can rely on American Eurasian Cancer Alliance partnership, on me personally. And I want to thank you all for everything you do. In fact, I'm extremely happy to know that you have one devoted gynecologic oncologist, Dr. Zahirova, who is my personal advisor and my personal physician, whose recommendations and opinion is 100% congruent with top leaders in gynecological care that, of course, on my team. Thank you so much. I only wish I'm with you. The only reason I'm not is because I have consequences in neuropathy and as a maintenance therapy, and cannot travel that far. But I hope by next year I will be able to. Good luck with the Congress.
Safia, thank you very much for such a great presentation. Just know that Uzbekistan is with you. We support and we cheer for you, and we love you very much. We really hope that you will get better soon. Thank you so much for your online talk. So the next presenter is our dear, lovely Mayor Liz. Initially, we planned to do the WHO global security, but on cervical cancer. But we found out that if you would give a talk on a commercial determinants of a program, that would be more useful for us, Mayor Liz. Thank you for agreeing to change the topic, and please, the floor is yours.
Okay. I see my presentation here, but it's not there, so I don't know. Okay. So thank you very much. Yes, on the program, it's about elimination, but it's kind of old story in WHO, and there was also already a lot of talk about this in Uzbekistan and even in this national conference. So I wanted today to speak to you about a very hot topic in the West, and that is coming to you because I see that your economy, your country is evolving very fast. So we felt we need to warn you about something we are very concerned about in Western Europe, which is commercial determinant of cancer. So I hope we did the translation a little fast on the right with ChatGPT, so some may not be very. So let's see if I can move this thing first to begin with. Okay, so commercial determinant of cancer, what does it mean? In fact, it's come from commercial determinant of health, which is not clearer, I agree. So here is the definition. It is the private sector activity that affects the health of population. So private sector, who is that? It's industry, like the alcohol industry, tobacco industry, but also the pharmaceutical industry. And it's also any medical service provider who is subject to financial intensive, anybody who use health to make money. The health, today I will speak to you along the whole cancer control continuum, from prevention, diagnosis, treatment, palliative care. And usually when we completely recognize that private sector, maybe not tobacco industry, but pharmaceutical industry, has a lot of positive effects on our work and health. But the idea here today is to raise awareness that all this positivity come with a dark side that you need to be aware of. Some tricks. So who we are speaking about? Traditionally, when it was more about tobacco and alcohol, but the idea of commercial determinant is like some researchers have tried to understand how this tobacco and alcohol industry influence us, influence the governments, influence the people, influence the patient. And they began to realize that other industries do exactly the same. And that's the other one. The food industry, I put polluting industry here, but it's more like, the transport, the people who, the industry, which is like, the plane that took me here is very positive, but it also put gas oil in the air, which is not so positive. And the industry related to healthcare, which are pharmaceutical industry, which sell drugs, and all the medical device industry. So it's machine, the device you can put in body of patients, the lab device, the hospital consumable, everything that you work with that you have to buy. Very big positive aspect, but be careful about some negative aspects. And of course, the medical providers, for-profit practitioner, clinic, or hospitals. So there are two sides of commercial determinants. There are all this, tobacco, alcohol, and all the useful industry, but that increase risk of cancer, and that's the red part. And on the right, you have the industry that are involved in care. And, they produce, as I said, a lot of useful things. The screening test and machine, the diagnostic test, the surgery robot, the medicine, the radiotherapy device, and they help you, doctors, this is the big doctors who is fighting cancer, to fight cancer. But they are also, we realize by studying, not me, but a researcher, they are influencing everything along the cancer continuum. They influence marketing authorization of drugs. They lobby for their drugs to be reimbursed, even if there is not enough data to show that they are they are safe. They influence the reimbursement policy. They are all through doctors. They influence the reimbursement of medicine in my country, like Belgium, very much, for example. They influence clinical guidelines. Also through doctors, they influence medical use, and we will speak about it more lately, and even public research agenda. I will not enter into that, but you can ask me more questions about this if you want. So why WHO got interested in commercial determinants? Because our job is to advise Ministry of Health about what are the good policy, and also we try to improve the practice in countries based on scientific evidence and also cost effectiveness. You know, the money is never infinite in health, so you have to prioritize. But we see that the excellent recommendation and all what we say, you know, it doesn't get through very well. And more research showed us that one of the big force against what we try to have in country is in fact this commercial determinant. So how that works, we will see. These commercial determinants are very important in cancer because first, cancer is a frequent disease and it's a scary disease. So because it's frequent, it's a big market, and because it's scary, there is a lot of political will to fight cancer. Just want to say here that 1 Uzbek out of 8 will develop cancer. You can compare to 1 EU citizen out of 3. So, of course, the commercial actors, the big industry, they are more interested in Europe. So we are sensitized to this problem, but beware, they are coming to you. So beware. Because we got so concerned, we asked the best experts in the world to do some studies for you. And we published a series of 7 articles around all these aspects of commercial determinant in cancer. This is the Euro Health Journal. You have the link. If you get my slide later, you can go to check. And I will go through now, you know, along the cancer continuum to tell you mainly what is there. So first we have prevention, and I told you about tobacco, alcohol, processed food, also the tan and chemical industry. And in WHO we have what we call the best buys, this policy, which are, you know, we recommend for countries to implement, and that are not implemented because of this, of the lobbying and the influence of this industry. I will not go too much into details here. Researchers found out that they use mainly 5 types of techniques to influence and to lobby. And I want to tell you about these techniques because tobacco and alcohol are the frontliner, but we see more and more pharmaceutical industry and medical device and the people who sell you mammography using the same techniques. The first technique is the fear of bad impact on economy and employment. The fear of lawsuit if you question the industry economic freedom or the intellectual property. So that's about, you know, when for example, a country say, no, I don't want to have, I want to have the old insulin that was in my country, that was cheap. Why you sell me only expensive insulin? You have somebody who come to the government and say, you know, insulin is produced, this new insulin, which is very expensive, which is more expensive, is produced in your country. You have to realize we made some calculation. If you want not to buy this insulin in your country, this will put a lot of people unemployed. This kind of fear. Then they fund politicians, they fund media, sport, culture to gain support, to get a nice, positive image, which is called whitewashing. very important in cancer, they create or they fund front group organization, like patient organization in the West, who will end up to advocate very strongly for medication because they were a little brainwashed by industry that these medications are very useful, while in fact there are not so much data and that the health insurance don't want to reimburse this medication. There is a lot of fight in my country between the health insurance and the patient organization on some medication which are very expensive and don't make big difference. Next one. A big important one, which is the idea of creating doubt, creating a lot of alternative research. So you have multiple expert opinion. I mean, you don't need the industry to have a lot of multiple expert opinion, but this is important. There are a lot of very smart, very chic men and women who present them as experts, but who have funding from the industry and will promote, technologic solution. And that needs to raise a red flag. When somebody tells you technology is the solution, be very careful. And deflection, it's more for prevention, but it works also for doctors. It's the idea that, it's the consumer responsibility. They know what is good for health. They know that tobacco is bad, so they should not smoke. The doctors, they know the medicine. They know which medicine to use. Let's just, completely trust them. They are completely immune to marketing and lobbying of pharmaceutical industry. We can trust them. That's the narrative. But in fact, I will show you after that even if we want to be completely independent, we never are. So now I will focus more on this right part. As I told you, the researchers have now found that the researchers who were working on tobacco alcohol found the exact same strategy from pharmaceutical industry, and there are evidence that they influence all the ecosystem from research, market authorization, clinical guidelines, prescription practice. You have to know that now, which was not the case 30 years ago, companies disburse more on marketing and promotion toward you doctors than on research and development. I speak about big companies, even small companies, which are mainly based in US, in Europe, and so on. But that's the truth from my country that I want to bring to you. And what happened is that they lobby so well the FDA and the European Medicine Agency, which are giving the market authorization, like to put a medicine on the market, that there is decreasing threshold for the drugs. And for medical device, there was never a very high threshold. So, in fact, on the market, there are many medical devices that can be dangerous for patients. And there are also drugs which are less and less effective, as I will show you now. So this is the result of one study, but it's not the only one, about the last, since 95, they reviewed all the drugs that were approved by the European Medicine Agency. There was 131, and for different indications, more than something like 200 indications. And what they find out, like these drugs were put on the market rapidly, because now it needs to be rapid, because patients were lobbied to get rapidly the new drugs, except that when you are rapid, you don't do very good research. Good research takes, few years, not few months. And we have 41 of these new oncology drugs that have no or negative benefit, 23% that have minor benefit, and you see the green part, which are 23% with substantial benefit, and the really major benefit is 13%. And of course, this one are great achievement, great advancement. But be careful about all the other one that in fact, their aim is to replace all the drugs that are cheap. with new drugs that can be much more expensive. That's also, you know, the issue of the new way the market works. So beware about this. So now I just want to show you this, you know, this problem of raising price. You see on the right the median monthly cost of new cancer drug. This is in the US or in Western Europe, but you see that why people want you to use new drugs is because they gain the power to put higher price. And what we see is that country overspend on more and more on some low impact drugs which are expensive. And of course, when you spend so much on the cancer medicine, you don't spend your money elsewhere. We just helped Georgia with their medicine list. We reviewed the cancer drug they reimbursed, and we found out that there was a lot of medicine that were, you know, from this red-orange zone. Well, from the red zone, actually, we realized that it's 19% of their drug budget, which is $7.5 million for Georgia. So they were spent on useless drug. And 20% of their budget is spent on this kind of orange, you know, very minor benefit drugs. So I told you about market and promotion. I told you that they spend a lot of work on it. Just want to give you this nice, funny statistic. There are many studies like that. How much, you ask to a doctor, how much influence do your sales representative have on your prescribing? And for me, 61% say no, they have no impact. And 38% say yes, a little impact. And 1% say, yeah, they impact me a lot. And what do you think it is for the other doctors? And you see that it's very different. So for me, I'm good. All the others are wrong. But everybody say the same. So yes, in fact, the story is that we are more on the right than on the left, because this marketing and promotion, it's used our brain biased. It's used things we are not so much in control of. You know, this idea that experts know best, that peers know best, that people we like, we trust them, that we should help others who have helped us. So when somebody gives you, like a pharmaceutical company give you a gift or a free sample, there is something in your brain that creates positivity towards this free sample, toward this company, and you will trust what they say much more. It's not like, you know, it's not always like you decide, influence go hidden a little. I just want to inform you that we have the same problem with screening. We see a big infatuation in screening all over the world, which is due to companies promoting aggressively screening, aggressively the test, the machine. They use the same method the pharmaceutical use for drugs, like there are ghostwriters for publication which say, oh, you know, mammography, this new mammography machine detects breast cancer so much better because there is artificial intelligence in it, and I heard about that, except that when I asked to experts in artificial intelligence, they say it's not ready at all for mammography reading. There is nothing like good artificial intelligence for mammography reading these days. That's come from independent experts, not from the experts from the company. They are also funding NGOs, patient organizations to push for screening. And there is increase of privates in the private service, and of course, screening for private providers, it's a great market. In my country, 50% of the revenue of urologists come from proposing PSA tests to men. So of course, they are very pro PSA and prostate cancer screening. So the thing is that on the other side, the research shows, and there are more and more evidence against the idea of opportunistic screening, like you go to a private doctor and he proposes you a screening test. There are clear evidence that this doesn't work. There are much more evidence now on what we call screening that doesn't work at all, like thyroid cancer screening with ultrasound will not decrease thyroid cancer mortality. It will just increase the number of thyroid cancer that you find, that you will treat and you should have not treat. Like, for example, in Korea, they did thyroid cancer screening. They multiplied the frequency of thyroid cancer by 15, and the mortality did not decrease. In fact, there is a lot of thyroid cancer which are in people and will never kill them and will never develop further than that. This is something I will speak about this afternoon. This idea of, cancer that will never kill you, that are just there, and you can let them alone. There are also a lot of push for cancer screening at earlier age, even if it doesn't work, like it has been shown for mammography screening. It works very, very badly if the women are not menopaused. But we see, so there are more and more evidence against this bad practice, but there are more and more of this practice. So that's, again, the effect of commercial determinant. Then it even affects palliative care. Patients are treated until the last day of life, while they should have palliative care. This number of 20% of patients who receive chemotherapy in their last 2 weeks of life come from UK, I think, and they think that it's really too much. It doesn't make sense to have this, or to have surgery like in the last months of life. Like a colleague said, it's the best way to just kill your patient earlier. So, and there is marketing of this expensive analgesic, expensive opioid. They will tell you, oh, this new type of morphine, of opioid, it don't get people addicted. That's what they did in the US. They sell the opioids saying, it's a new one, it's completely different. People will not get addicted. And they say also, if it doesn't work anymore, you increase the dose. It was a lie, it was pure lie, and now the US has 500,000 people who died because of the lie of the pharmaceutical industry. And the bad effect is that, in addition, the people who really need these opioids, because of this backlash, they get less. So, I mean, the opioid crisis in the US is exactly that. It's the pharmaceutical company doing marketing out of ethics, and they are not the only one. So how we end up there, it's a whole economic lecture that I could not provide, but just to make you realize that in the part of the world where in the West, the government are getting poorer and poorer. That's the economic model we implement since the 80s. And the company are becoming, like you see, the private wealth on the top, and the wealth of the government, like Spain, UK, Japan. That's the government money, so tax plus even the assets, the buildings, all what they have, is now below zero because the debt are so bad. But the private sector gain more and more power. On the right, you have the 100 entities in the world that are the richest, so by revenue. Like the revenue is the tax of the government perceive, and the revenue of a company is the revenue of a company. And you see that United States, China, Japan, Germany are at the top. All the red ones are private company. So you have a private company like Apple or Volkswagen and so on, which are richer than the whole state of Norway or Switzerland. So just to give you the idea of the power balance and how we end up there. So solution is very it's an economic solution that we need to rethink the role of economy. It should serve the people. It should serve the health of people. It's not the people who should serve the economy. We are all the victim of a pathologic economical system that allow or even push now the corporation to cause harms. So that's very, high level, but there are solutions everybody can contribute to. So I just wanted you today to raise awareness about this commercial determinant, this negative aspect of the market that will come to you. Educate yourself about this. don't think you are immune to influence, to pharmaceutical company behavior. And I know, like, you will think, oh, you know, like, if they give me money to prescribe pharmaceutical medicine, I will not do it because that's, you know, corruption, and I don't do that. But there is something even beyond corruption. Rethink the interaction with the pharmaceutical industry and medical device industry. And you have to help your government to resist the lobbying. You have to not, you know, the doctors, you influence a lot of your government, so be careful about that. And don't hesitate also, especially in Central Asia, to discuss corruption openly. It doesn't help your country, it doesn't help the patient, so be also careful about that. So as I told you, there are a lot of information you can get. So the first one here is this journal. There is an excellent WHO publication for doctors, which is about understanding and responding to pharmaceutical promotion. And I think it exists in Russian. I will try to check with my colleague. And otherwise, there are a lot of, you know, books that have been written because, as I told you, it's a very hot subject, and it will come to you, so I hope this warning was useful. Thank you very much.
Спасибо огромное, Мерли, за ваш хороший презентацию.
Thank you very much for your beautiful presentation. Both in Europe and in our country we have similar issues. We can discuss these details later. And now, dear colleagues, the floor is given to Philip Davis. He's from UNFPA. His topic is entitled Recommendations on Effective Cervical Screening in Uzbekistan.
Well, very much for inviting me to give this presentation, and thank you for attending to listen to it. What I wanted to do was, so previously it was mentioned that there was a pilot study conducted in Uzbekistan, an HPV primary screening pilot study. And so what I wanted to do was to present recommendations for cervical screening in Uzbekistan based on the results of that pilot study. Okay? But first, what I'd like to do is, fortunately, one of the advantages of giving the presentation early is that you can present things that other presenters will present later, but you're the first. I'm sure this will come up later. Cervical cancer is the second most common cancer in Uzbekistan, both in terms of incidence and mortality. But very importantly, the number of cases and deaths have been steadily increasing in Uzbekistan for, well, since the beginning of this slide anyway, and they're projected to continue to increase. So, I mean, that's an interesting thing in itself. But looking at cancer prevention, so keep those cancer statistics in mind. We'll come back to those. Looking at cancer prevention in Uzbekistan, if we start with HPV vaccination, Uzbekistan has been extremely successful with their vaccination program, and it's achieved rates of almost 99%. And as was mentioned previously, most people outside Uzbekistan will say, well, that's impossible. Not necessarily so. And when we come to the data from the pilot study, we'll see that, again, they have recruitment rates that were very high. And I think one of the advantages Uzbekistan has is the structure of the healthcare system and the mahalas that are in place allow this to be achieved. Now, a couple of points about cervical cancer and HPV vaccination is that the majority of cervical cancers in Uzbekistan occur in women between the ages of 45 and 70 years. This is crude incidence stratified by age. And what this shows is that you have this big peak of cervical cancers, and it's in women over the age of 45. So if we're looking at the benefits of HPV vaccination, we're not going to even start to see those until the 9-year-old girls that are vaccinated now start to approach this age range. And then the full benefits of that vaccination program won't be seen for another 20 years until the majority of people in this age range have been vaccinated. So what that says is that cervical cancer screening is going to be the primary method for preventing cervical cancer for the foreseeable future. Now, if we look at cervical screening in Uzbekistan, the simple fact that the numbers of cancers are increasing shows that what's being done in terms of cervical screening is not working. Okay? So, I mean, that's just a fact. Now, there are two main reasons for this. There are a number of reasons, but the two main ones are that the main screening test in Uzbekistan is currently VIA, and the WHO now classifies VIA, as well as the PAP test, as low-performance screening tests, and recommends that the countries using these technologies transition to high-performance screening tests, such as DNA testing for HPV. But a second key reason is that Uzbekistan does not have the organizational mechanisms to effectively coordinate and quality assure the cervical screening process. And cervical screening programs won't work, and this is independent of the screening test. It doesn't matter what screening test you use. They will not work unless they are effectively coordinated and quality assured. Okay. Therefore, protecting women against cervical cancer for the next plus or minus 50 years, it's essential for Uzbekistan to implement an effective, organized, and quality assured cervical screening program that's based on HPV testing or another test that comes along with equal efficacy to the HPV test. So if you look at cervical screening in high-income countries, what we can see is that in high-income countries, the introduction of, again, effective, organized screening programs, in this case based on the PAP test, has produced substantial reductions in cervical cancer incidence mortality. So you can see the introduction on the left of each graph, and then incidence declines over time. Same with mortality, declines over time. So, but keep in mind, these are based on the PAP test, but these graphs go back to 1954. They cover the period from 1954 to about 2013. So this is pre-HPV. There wasn't HPV, was not an alternative in those days. The PAP test was it. So PAP test-based screening programs can work, but implementing a PAP test screening program that is effective requires a vast amount of money, an enormous amount of money, and also requires an enormous amount of time. What I've done here, now most of you can't see this because it's at the bottom. What I've done at the bottom of this graph is just noted that this is a 50-year period here. Okay? So it takes time to implement these programs. It takes time to train the people to run the programs. It takes time to implement and verify the systems to run those programs. It takes a long time, and it also takes a very large amount of money that go into those activities. And so without this large investment of money and time, PAP test screening doesn't work very well at all. And this has been demonstrated in many low and middle income countries that have tried to implement PAP test-based screening. And they just haven't produced the results that are shown here because they don't have the money, they don't have the time. Now, all the countries that I've shown on the previous slide, they had very successful PAP test screening programs, but they've all now switched to HPV testing or are in the process. This is just a selection of, this is not the total number of countries that have switched to HPV, this is just a selection of them. There's a lot of high-income countries that have now transitioned or are transitioning to HPV testing. And the main reasons for this is because HPV testing is more sensitive than the PAP test, so they'll be able to reduce cancer rates further. The HPV test allows the screening interval to be safely extended, and that reduces the costs. If you extend the screening interval from 3 to 6 years, each year you only have to screen half as many women. It's a very simple calculation. HPV testing is also easier to conduct and to quality control than cytology. Cervical cytology, the PAP test, is a highly subjective test. So getting it to work properly in the lab and also quality assurance for that test is very, very difficult to do, and it's also very expensive. And the last thing on this list is that in countries with high HPV vaccination rates, cervical cytology and VIA will not work very well at all. HPV testing really is the only test to use in a country that has high HPV vaccination rates. And Uzbekistan has the highest vaccination rate in the world. So when those women start to get into the screening age range, the cytology or VIA is just not going to work. You know, you really need to go with HPV testing, or as I say, another test that comes along in the meantime that has the same or better performance. And what about low and middle income countries then? It's a number of, it was mentioned previously that there's a lot of activity in the cervical cancer area. And a lot of low and middle income countries are implementing cervical screening programs. And these days, they're doing it with HPV testing. Here's a list of some. There's not all the countries, there's more. So there's some of the countries that have implemented cervical screening programs, and they're based on HPV testing. And again, the reasons that they've done this is because they've recognized that substantial reductions in cervical cancer rates cannot be achieved by VIA or PAP without the investment of very substantial amounts of money and also substantial amounts of time. The longer screening interval for HPV negative women will reduce the costs of the program. Okay? So other costs may be higher, such as the cost of the test versus the direct costs of cervical screening, but the overall cost of the program will be lower. HPV testing is far easier to implement. It's easier to conduct in the laboratory, and it's easier to quality control than cervical cytology or the PAP test, or VIA for that matter. And again, HPV testing is the only test that will be effective in populations that have high HPV vaccination rates. So, that said, let's move on to the pilot. Let's move on to the pilot. So, Presidential Decree number 2866 specified that a strategy needs to be prepared to inform the implementation of a national cervical screening program. So to produce the data for that strategy, the UNFPA, French Embassy, WHO, etc., conducted a pilot study evaluating HPV primary screening within the Uzbek healthcare system. I want to emphasize the point that the pilot examined the operation of the screening process when using HPV. It didn't examine the efficacy of the HPV test. The test that was used was a commercially validated test, been demonstrated its efficacy, but demonstrated in many other trials. So that didn't need to be done. But we needed to find out how it was going to work within the context of the Uzbek health system. So a total of 56,000 women, aged 30 to 35, were recruited in Chirchik and the Republic of Karakalpakstan. And they were screened with HPV from April 2021 to April 2022. Key results. All primary health care clinics achieved 99% coverage of their target population. Same as for vaccination. Mobilize the mahalas, the women will come in. So very, very high recruitment rates can be expected for a national screening program. The mahalas are everywhere. That part of the health system exists across Uzbekistan. That's the key, one of the key things for screening. If you don't get the women in, it's not going to work. Nowhere in the world has achieved that level of coverage. It demonstrated that HPV prevalence within a routine cervical screening population, which is the key point, within that population, so no bias, there was no bias in this. There was no selection bias. It was women who were due for cervical screening, almost 100% coverage. 7%, with 93% of women, so 93% of women will be HPV negative, and then can be rescreened in 5 to 10 years. Colposcopy triage of HPV positive women at the primary level can work, but further training is required to make it more effective. The mechanisms to coordinate the referral of HPV positive women between healthcare services at different levels, so primary to regional to tertiary, they're lacking. They're lacking, and the systems that are in place are not effective, so those need to be strengthened. The correlation of colposcopy and histology results at the regional level, so when women were referred to the regional level, they had colposcopy, a biopsy, histology. The correlation between those was very low. So that indicates that one or both of these services needs to be strengthened. And robust quality assurance program covering the entire screening process needs to be implemented. I mean, that does not exist, so that needs to be implemented. So recommendations for cervical screening in Uzbekistan. I mean, it's pretty much the same as the previous slide, right? But start with a regional program so you don't take on too much of a challenge at the beginning. I'd recommend one region, maybe two at the most. And then when that's operating, when you've worked out all the problems you're going to encounter, when that's operating, then expand it to other regions. And the first one or two regions can then serve as training centers for people in the other regions. Use HPV testing as the primary screening test. Implement cervical screening coordination offices, probably at the regional level, probably in the regional oncology centers. They can work with the region, collect data, and monitor, coordinate, and quality assure the screening process. And there needs to be an IT system, so a cervical screening registry. And no, this is not a cancer registry. This is an IT system to collect data from all the health services. So who was screened? What was their screening test result? Were they referred to colposcopy? Did they attend? What was the colposcopy result? All of that data then coordinated in one place where it can be tracked, monitored, and if something doesn't make sense, then somebody can intervene to correct the problem. Strengthen colposcopy capacities at the primary healthcare level to improve the triage of HPV-positive women, or figure out another mechanism to triage women. There's other things that are coming along. One of the next speakers will talk about risk-based management of HPV-positive women. Maybe that would be the solution. But there needs to be a more effective mechanism to triage women at the primary healthcare level. Evaluate the performance of colposcopy and gynecological histology services at the regional level, and then implement training programs as required to address that. Further training was done in Karakalpakstan, and improvements were seen, but there's other regions that need to be dealt with as well. And finally, implement a robust cervical screening quality assurance program that covers the whole process, plus each of the individual services within that process. Fortunately, last slide. So in conclusion, the increasing numbers of cervical cancer cases in Uzbekistan, together with a high mortality to incidence ratio, demonstrates that cervical screening currently conducted in Uzbekistan is not working. So thousands of women are developing and dying from a disease that is now almost entirely preventable. So Uzbekistan now has a unique opportunity to implement a highly effective HPV screening program that would prevent the vast majority of this disease and death. So Uzbekistan should capitalize on this opportunity and move forward with undertaking the actions noted previously, and also the actions that will be noted by other speakers at this Congress. That's it. Thank you very much for your attention.
Thank you, dear Philip, for such a presentation, for recommendations, for the work that you did during analysis. The next presentation is from Aziza Umarova, the head of the Agency of Implementation of Strategic Reforms under the President of Uzbekistan. The presentation is held actually of the information from the cancer program. Good morning to you all. In order to make it more comprehensive for the local specialists, I will be delivering in Russian language rather than English. It's a pleasure to be here because we have here non-doctors, but from my side, from my organization, I would like to make contribution to the analysis of data, to the account of data and impact of the data on the further decisions by the government in the oncology topic. It is important to understand from what positions we are starting from. What is impossible to measure is impossible to correct. That's why it is important to maximally identify any progress, any investment, a result, survivability, success of any governmental program. And it was a pleasure to hear. I absolutely agree with all the speakers. A lot of work has been done within 6 or 7 years. Oncology has progressed to achieve the next level. No one opposes that, but to look at the results objectively, we can increase the efficiency of the work that is done. I'm the specialist in the governance, and sometimes I studied in the Harvard University governance course, and I worked in the United Nations Development Program. Was one of the managers. Worked in the ESGU Amal. I volunteered there, but I know this program from the details, and I see how to link 3 fundamental pillar stones. These are the strategic planning, where we're moving, data analysis. That's what I want to talk today in my presentation, and state investments, because we need to admit that oncology sector is and still a remaining underfinanced topic. And if you want to implement a screening, early detection, diagnosis, treatment to be effective, we together with you need to identify the problems and to seek for financing from the state budget. The next slide that I want to present, we have used the data analytics tools on the Bukhara pilot, and I think this is my personal opinion, despite the skeptics on the breast cancer screening. This pilot reached the attention to this pilot because it has become obvious that mammography in each district, the numbers are underestimated, still is underestimated. In Russia, with the population of 140 million people, not so many women are diagnosed with breast cancer. 14,000 women must be detected. In Uzbekistan, we have also 690 cases, and multiply it by 3, and on the screen you can see what the dynamics changes in Bukhara, when indeed we have started to do mammography district-wise, and these are approved cases. Here we can see how the number of new cases, detected cases, the number of cases increased. If before very passively women were involved in the system, and then when there was a specific program, the number of women increased, and this is a signal that more women are in right hands, correctly. Tumors have been detected, and the women came to the healthcare system and received the treatment, the service that they needed, I hope. The next is the breakdown based on the data collected from Bukhara. This is a huge work of enthusiasts in the limited number which work in the in the Bukhara center. And my special thanks to Dr. Soskov. Without him, this program will not be possible. When we can see the data, these data is an oil. You can do Excel oil, Excel table, you can do infographics, you can make breakdown in the years, in the numbers, in the patterns. My task in the strategic analysis agency to make analysis. We developed in the potential modeling how many from the year 21-23 in the Bukhara we can expect the new cases of cancer. The data allows you to predict the numbers in 6 years, in 5 years, in 10 years, and we can see this this fork of upper confidence and lower confidence, and we can see that within this range the new cases will be within these new cases, and we can get the Ministry of Finance and Economy prepared of how much money to be indicated allocated to the next budget. And I will show next figures which are very concerning for me. Within the next 2 years we will not be a deviation in the numbers. Well, let's say Bukhara, within this system, due to this system, we have 58 identified cases in Bukhara, treated 18, untreated 3, and dead 2. How much we have? Who is good with mathematics? So much percent of the total number. 40% of the loss. Let's take Gishdavan district. Let's be consistent. 34 the total, 14 treated, untreated 2, 2 dead. What is this difference? 16. What is the percentage? And this is not the doctors to be blamed. The doctors are doing their work. Radiologists doing images. Ministry of Finance receives data and shall provide financing. There is no system in place, and that what has been said. There is no system which would refer the patient after diagnosis to the treatment point. That means, by identifying the progress which was made by the program initiated by the President, very good program, we need to understand what should be the next steps. We need to establish the system which would track, and indeed women are afraid for the follow-up screening. They are afraid to coming to the examination. There are many psychological factors, attitude in the families towards the diagnosis. When I'm presenting these numbers, I don't want to point to someone and don't see the mistakes or something related to the doctors. There's no system which refers and follows the patients to the treatment point. These are the data from the registry in the 2022. It is not that someone in polyclinic would not deal with figures. Let's take Bukhara district, not the city. 32 cases identified, 29 received, 1 has received treatment, and here we can see that this is a human factor, and there are effective people. We need not to blame someone, but to see successes that some people are having treatment. In the public governance, we still do not have positive measures of incentivizing rather than punishment. And in healthcare, we need to start with incentivizing those people who are concerning for the destiny of people, and those people must be an examples for others. These are the slides from the data from the year 2023. Gishdavan at 52 cases, treated 33, untreated 1, no dead. And what is the difference between 34 and 52? We don't know. Where are they? Maybe they did not reach the doctors, and they will be in the category in untreated, and maybe they are in the category of dead. We need to have cancer register, and my personal opinion, if you allow, cancer registry cannot be developed by local specialists. Other countries develop cancer registry for dozens of years. We need to start to doing cancer registry and to complete it. And can we go back to the couple of slides? We don't need this. This is on schools. If possible, could we go back to the slides? Another slide that we wanted to show you regarding vaccination, HPV vaccination. The data, once again, does not cover the whole country. This is just a selected data. This is the data provided by the polyclinics: Andijan, Navoi, Andijan 25, Navoi 13, Karakalstan 56, Surkhandarya 47, Tashkent city 11, and Tashkent region 11. And here we show in the share of the age for the girls 14, 18, and here we would like to show the quality of data. Certainly the figures we can see in average the number of percentage of girls who covered with vaccination, 22-23%. I don't see 90, and the second dose is larger than the first. Andijan is 14, and then the second is 24. Samarkand 42, 45. The first dose could be more than the second. Maybe the coverage is wrong, and then the next figures are just made up. I'm not a healthcare specialist. Maybe you do not have computer. Maybe some other objective reasons that impacted. But this is okay. But that means that we need to concentrate our efforts on establishing the system, which does not require efforts from the medium-level specialists in the polyclinic to introduce the numbers on timely manner, not to show low indications or high indications, so that not to be punished. If we can see the dynamics, if tomorrow is, today we have 20 and tomorrow is 23, that's okay. If it is 90 and tomorrow 93, we can make a lot of mistakes tomorrow on the HPV screening. That's what we wanted to show. Maybe someone has some questions why the Agency of Strategic Reforms in the structure of administration are dealing with the breast cancer and cervical cancer. We were established 1 year ago, and our task is to implement decision-making based on the data. We are working with the Ministry of Economic and Finance, with the preschool and secondary education. We are studied the infrastructure of schools, based on which we will establishing together with Ministry of Finance the investment program based on our data. Not the schools that Hakimiyat lists for the rehabilitation, but the schools that are really needs for the rehabilitation. In this sense, we are expected to be supporters with heads, with hands, with anything to support healthcare system in the new approach to develop the program of early detection and treatment of breast cancer and screening for the cervical cancer to allow the women to reach the treatment point. And we know that there is lack of financing. We are ready to be with you and to justify that financing must go completely on different formula and in different amounts. We are your supporters. We are not your critics. We are in one team with you. Apart from the public health care and schools, we have the issues of water and sanitation. There was a good presentation from WHO representative. In our work, we understood that there is a not unwell studied correlation between water quality, pesticides that are in the water and carcinogenic, and oncology. There is correlation between glyphosides, which are used in large amounts uncontrolled in agriculture, and non-Hodgkin's in lymphoma. There is correlation between those pesticides and herbicides that we use now and a lack of breast milk. Only 28 patients use breastfeeding. All these must be studied. Could you please open the last slide? Upon the order of the President, there's a comprehensive visualization data program has been established. On the first stage, we'll be tracking implementation of our social indicators, and in the future, this will be all parameters of strategy of Uzbekistan 2030. All these data that are collected will be used and provided to the authorities, and based on this instrument, there will be opportunity to synchronize activities of Ministry of Finance, Ministry of Health, Medical Service, Oncology Service, and to verify the data from the patients. And if we see any deviations, we can in a timely manner make corrective measures. And the next slide are thanks. I would like to mention from my side that on oncology many works has been done, and this is a contribution from the head of the Republican Oncology, all the team who for many years controlling this disease. In many countries this is a huge problem, and our task to be more accurate, more frank, because many similar issues are available in other countries, and when we admit the problem we can reach our final point. Thank you very much for a good presentation, a good report, and the data that you have outlined. These are all from Ministry of Health. Dear colleagues, we have certainly missed coffee break, but 3 or 4 reports are remaining. And the next, Jesper Bander, use of molecular technologies for effective and good controlled clinical cervical cancer. Jesper, floor is yours. Dear colleagues, we will moving to the lunch soon. We will be moving from here. Thank you, Jesper. Floor is yours.
Assalamu alaikum, and thanks to the organizers for inviting me to come here today. This is very exciting, and I have to say and admit that it's my first time in Uzbekistan. I'm going to talk to you a little bit about our experiences in cervical cancer screening in Denmark, but unfortunately I start on the wrong foot because Madame Kobek already said, don't trust anyone who will tell you that technology can solve issues. And I'm here today to tell you that at least in Denmark, we are using technology to solve issues. Fortunately, I'm from the public healthcare services, not from a company. Why is cervical cancer an issue? It's been talked about, so I will be very frank and very fast about it. I just want to say cervical cancer is a cancer type that hits women at a relatively young age. And because it's at a relatively young age, it's very often with stay-at-home kids and while you're in your active career working. So it hits society quite hard. But cervical cancer is caused by a virus infection. And that makes it a little bit troublesome to specifically detect and say this will give cancer, this is just an infection. Because we need to start thinking about cervical cancer as an infection that can cause cancer and not just an infection that will give cancer, because that is not the case. More than 90% of all adults will have or have had an HPV infection throughout their life. It doesn't mean that everybody gets cancer. What we do know, and this is slides that I have borrowed from my colleague at the National Cancer Institute in the US, Philip Castle, is that 40% of those women who have HPV-positive screening tests with normal cytology will actually clear the infection themselves. This is pivotal information when you are building a cervical screening program, because it means that not all women who has an HPV infection needs to go to colposcopy. We also know that once screening positive women have cleared the infection, the risk of cervical cancer is reduced markedly, almost to baseline. The problem about cervical cancer is that even though we have advanced technologies to detect, for instance, HPV infections, we have limited management options. When we have a positive sample, a negative sample, we know, especially using HPV technology, that the woman can safely go back to a long screening interval of up to 10 years. But if it's positive, it needs some sort of triage in order to deselect those women who are not at risk of cancer or disease in favor of focusing your efforts on those women who have a risk of disease. So the lowest risk strata can be safely sent back to some sort of surveillance, and that is always a discussion, country by country, region by region. What is the proper surveillance period? Is it going to be 12 months, 24 months? What is it? But if the woman is positive on the triage to a certain degree, of course she needs to be followed up in order to ascertain whether the disease is present, and that includes colposcopy plus biopsies. So we have a disease, we have technologies to detect the cause of the disease, but we have very limited management options. And when building a screening program, what we want is to have sensitivity, the ability to detect disease, but we also want to have specificity, which is the ability to not overmanage women. And if you have the wrong test, you can have a low sensitivity but a high specificity, meaning that you don't catch the women who actually have a risk of disease. But on the other hand, if you have an unvalidated assay, you might result in having a very high sensitivity but a very low specificity, meaning that you're going to overwhelm your gynecology services with women who need to have colposcopy, and there's no bonus in that. So built correctly, cervical screening programs will give you high sensitivity for detection. You focus your efforts on those women who needs it the most, but you send back all of those women who don't need any more follow-up. And in order to do that, technology comes in handy. Over the last 20-25 years, HPV technology and cytology together has been proven again and again in different settings across the world with different amendments of different technologies to give us very high-performing primary screening tools like HPV testing. We need validated tests, I'll come back to that. But we also need technology integration. We need to combine different technologies. And in this, I actually agree with our WHO representative. There is no one technology that is superior to everything else, no matter what the representatives might claim. We need to combine them, and we need to be smart about it. And then we have the triage challenge, because managing women with positive screening tests will eventually lead to one thing, and that is a colposcopy, biopsy-taking, pathology review. That means that we have high-performance assays, molecular assays, that are going to be verified by pathology, which in nature, and I do come from a pathology department, is a very subjective measure. And finally, we need to build programs that takes into account that in the very near future, we are going to see vaccinated and unvaccinated women both in the same cervical screening program. Build it so that it lasts. I want to talk a little bit about how to get the samples, because getting the samples is the starting point of all successful cancer prevention by screening. We have the clinician-collected samples, which you have on the top here. That is typically medias that can be used for both HPV testing and cytology if you need to do a triage of a positive HPV result. It's validated, it's been used for many years. You can do both, and it's analytical stable for transport for up to 32 weeks. The limitation is that it requires access to healthcare. The woman needs to go to a healthcare facility in order to have the sample collected by a clinician, a nurse, a midwife, or similar. And it requires a simultaneous pelvic exam. So it's relatively resource heavy. On the other hand, we have a new technology coming online now in very many countries, and that is self-collected samples, where the woman will receive a small brush, and then she can do a vaginal cervical sample herself, send it to the laboratory, and there it will be tested. This is very resource light in comparison to the clinician collected, and it's validated now broadly across the world. It requires no pelvic exam, but it can only be used for HPV analysis. So there are options. Most of all, we need reliable assays, because not all assays are created equal, and we need versatile and high throughput instrumentation in order to have a consistent quality across different laboratories using the same sort of tests in order to detect HPV. There is no point in building screening programs where one region will have a very high performance, but other regions have a low performance, quite simply because there hasn't been a consistency in the choice of technology. If you look towards the evolution of HPV tests since 2003, where we had the Digene hybrid capture 2 assay, that is today mainly used in Turkey, it was a yes-no assay. Is there HPV, yes or no? But something happened, and along the way of research, what we have experienced is, of course, that our knowledge about technology, our knowledge about HPV has expanded. And what we have learned is that HPV genotypes are not created equal. Some HPV genotypes will have a much higher risk of inducing precancerous lesions and cancer than other genotypes. More than 200 genotypes have been characterized in humans today. WHO IAC is classifying 12 of those as being oncogenic, but even between those 12, not all genotypes actually carry the same risk. And this is pivotal information when you're building a new cervical screening program, quite simply because you can use that information to your benefit in order to obtain good sensitivity and good specificity. Today, you have ability in different platforms that are validated to detect 16, 18 plus the rest, or you can do extended genotyping where you will have multiple individually reported high-risk genotypes. And in the near future, I'm quite certain we are going to see assays come out that will be high throughput, validated, and giving us individual results on all genotypes that might be in a sample. But be aware, because not all of the HPV tests on the market is actually a validated thing. And by validation, I mean assays, technologies that has been proven in a clinical context, that has been proven in terms of reproducibility, providing quality assurance and quality control. And this is data I have borrowed from Professor Poljak and Dr. Ostropink in Ljubljana, who are detailing the number of HPV tests in the world market. I believe more than 1,000 tests are currently in the world market, but we only have 2 handfuls who have obtained international validation. And almost 80% of all of these HPV tests do not have any sort of documentation. So when choosing technologies, choose wisely and go for those who actually have validated clinical performance. I want to take the last few minutes to talk a little bit about self-sampling, because self-sampling is something we're rolling out across Europe at a very high pace right now, because it's solving a number of structural and healthcare services related issues. By offering self-sampling, women can, as I said, take a test in the privacy of their own home, in a clinic or similar, and it's the most efficient way to raise participation in already existing screening programs, quite simply because women now can do the test at their own convenience, in discretion, as they see fit. It can be used with HPV testing, and you have multiple options. You don't have to do what we do in Denmark, in Sweden, in the Netherlands, in the US, or similar, Australia. You can choose what fits into your setting. You can distribute self-samples to women in clinics by giving them a test kit. Basically, it consists of these small brushes that should be fairly easy to use. And then the woman, after taking the sample, can just return it like this to the laboratory. There's a barcode on identifying her, so you scan it in, you can do the test, you have the identification. Clinics works quite well, very high coverage. You can distribute it through pharmacies. I know that France is going to do that very, very shortly. You can use the mail system. If you have a good postal system, you can send out these tests by regular mail because they have a very long stability in transport for up to 16 weeks, even at 40 degrees Celsius. We tested that both in Denmark and Australia. Or you can have it as an opt-in where you're inviting women and they can say, yes, thank you, I would like to have this. We have lots of evidence now, internationally, globally, within European Union frameworks, US frameworks, Australian, New Zealand frameworks, that self-sampling is equally good as a clinician's collected sample in detecting women with precancerous lesions. We also know that self-sampling works quite well with the HPV test. I'm not going to go into this. I'm just going to say this is some of the data we have been part in manufacturing and doing, setting up, where we are actually testing the yellow one, which is a cervical sample, and then we are measuring the amount of HPV in the sample, comparing it to a, at the same time, taken self-sample. And as you can see, the bar curves are similar. These data has just been included into the FDA approval, which was given in the US market for use of self-sampling 2 days ago. And we're quite proud to have participated in this process because the FDA are really not fun to work with. Finally, I just want to take to you how you can build an algorithm on self-sampling, because one thing is to have an algorithm on clinician-collected samples where the woman will come to the clinician, have advice, and have samples taken. But self-sampling requires that you have the ability to contact the woman and say, your test was positive, we need you to come back and have a clinician-collected sample taken, and on that, we will put forth the final diagnosis. But remember, the benefit is, with a prevalence of, for instance, 7 to 8% HPV, using a self-sample will still return 92% of the women to the next screening round without any further ado, and you can focus your attention on those 8% who actually need your attention. We shared all of this with, amongst other, the White House last year, and as I said, the FDA just approved it, so we are very happy to be part of that process. And if you look at self-sample in the global perspective, this is from an unpublished paper from a European WHO working group with participation also from Australasia, US, Canada, Mexico. You see all of the countries here that is taking up self-sampling already. So it's a novel technology. It works, and it's been taken up by a number of countries. The final thing I want to say is that in order to create a strong cervical cancer screening prevention program, you need strong governance because it secures the cost-effectiveness of screening and cancer prevention. You need to adapt to your local conditions. You know best what conditions you work under. Don't let somebody like me tell you that just because what we do in Copenhagen works, it works in Tashkent too. That is not a given. You need to do technology choices wisely because fast implementation of evidence-supported technologies will enable you to have high-quality screening. And finally, I can only recommend to you, don't try to reinvent the wheel. Take all of the experiences from across the globe and figure out what works in an Uzbekistan setting. And with those words, thank you for your attention.
Спасибо, Джеспер.
Yes.
Thank you, Jasper. Thank you, Jasper. Dear colleagues, next presentation from Isabel Hurd. She is from a regional WHO from France, and methods of algorithms of sorting of HPV positive women within the screening program. The floor is yours.
I hope you still have enough energy because we need to eat soon. My name is Isabel Hurd. I'm French. I'm consultant in WHO Euro, and I've been coming to Uzbekistan several times, working on the pilot program using HPV tests for cervical cancer screening, which Philip Davis presented to you earlier today. And it's my first time in Bukhara. I must tell you, it's so beautiful, and I thank you so much for inviting me to be here with you. So we've already heard several times, and thanks to Jasper and to Philippe, that HPV infection between HPV infection and cervical cancer, there is decades, and during these decades, the screening can be done to identify women who have precancerous lesions. Many studies now have shown that screening results in decreased incidence and mortality from cervical cancer. And the women who will most benefit of cervical cancer are women aged between 25 and 65. Screening works very well, but we've seen now that in many countries what has been done using cytology for screening is now shifting to HPV testing. Jasper talked to us about that. This is because HPV tests offer a greater protection against cervical cancer and longer interval for screening. Cervical cancer with cytology misses a lot, up to 50% of cervical cancer. This is very important. And this is why, if you do cytology for screening, you have to repeat every 2 to 3 years the test to catch up the cancer you've missed at the previous sampling of the woman. And you see on the right part of the slide that when cervical cancer organized screening was started in many countries, we can see a decrease in the incidence. But for the last 10 to 20 years, you see it's flat, it's a plateau. There is no more decrease, even if it's organized. Maybe this is related to the fact that cytology is not a good test enough, strong enough to detect the precancerous lesion. And this is why the screening community, cervical cancer screening community, with gynecologists as myself, virologists, public health people, started to think that we could maybe, rather than look at the abnormal cells, look at the virus who causes the cancer. If there is no virus, no risk of cancer. And now it has been shown that HPV testing provides greater protection against invasive cancer than cytology. When you have all the existing cancer can be detected when you use HPV. This is a strong argument to use HPV testing rather than cytology because it will allow to detect all the cancer. But there is always a but in the life. We know, as we've just been told, that all of us have been infected with HPV at the beginning, at our sexual life debut, and that almost 10% of the women will be infected with HPV at part of their life during their 30 to 65 years of age. So you'll have about 10% of the women who will have a positive result. What to do with that? That doesn't mean that they have a cancer, but you want to know for these women who are those who will require more clinical investigation to know if they have a precancer and then to offer their appropriate treatment. So this is the triage. I'm going to talk to you about how to triage those 10% of women who are HPV positive. In your country, in the pilot program that has been done, we found out that in Karvon, Pakistan, the rate of positive women was 6.6%. In Churchik, the rate of positive women was 10% higher than in Karvon, Pakistan. And in the studies that have been done by the Institute of Virology, the rate of HPV infection was also around 10%. But the higher proportion of lesions missed with cytology definitely reinforced the HPV test as the better screening methods. So we need, if you are going to install in your country to do HPV testing for primary screening, then you will need to triage the HPV positive women to identify those women who will need diagnosis and treatment. And doing these tests, it also will reduce anxiety to those women who do not need any further investigation. And the issue I want to share, what I want to share with you now is the choice of appropriate triage strategy, because it's very important. It can be done at a country level, but also in different places in the same country. So there is no single approach to triage the women. There is not a single approach, binary, that would say, these women has a lesion, need to be treated, this lesion, no lesion, go back. The issue is always these women who are HPV negative, but HPV positive, but triage negative. There are different ways for triage. Some come from what we have already been doing for years, morphological assessment with cytology, and others now are taking advantage of recent development of molecular technologies. Today, the most commonly used triage method is cytology. Cytology is done on the sample. You've seen the sample. In a vial, there is 2 milliliters are given to the HPV test, and on the same vial, do not require to call back the woman, same vial, take other cells, and do the HPV test just after you've gone the HPV positive test. So it's easy to do, but you have to remember that cytology is not optimal, and you may miss cases with women with high-grade disease, not least in the older women. And the challenge is for these women who will be HPV positive and cytology negative, for these women you'll have to think when to recall them. Here, I just want to show you, this is what's done in the UK. In the UK, they do triage with cytology. Women have an HPV test. If HPV is negative, the women will be recalled in the UK in 3 to 5 years. If the woman is HPV positive, then they will do cytology on the HPV sample. And for those women who are high-risk HPV positive but cytology negative, they decided to record the woman in 1 year. If in your country you want to do cytology for triage, you may decide to record the women 2 to 3 years, depends, every country has to decide what to do. Another possibility of triaging is doing genotyping. In the HPV tests, there are 14 genotypes together. The most oncogenic one are the HPV 16 and 18. These two genotypes are responsible for 70% of the cancers. And it's a possibility when you do the HPV test to separate the women positive for HPV 16 and 18, they are more at risk than women where you find a lower risk HPV type. So for these women who are HPV 16, 18, you may consider to send them immediately to colposcopy because they are high risk of cancer, pre-cancer. And for the other, you may consider to do cytology or maybe to recall them later. Triage using VIA, visual inspection, is mainly used in countries where there is no cytology and where there is no quality assurance. Triage, you have to keep in mind, nevertheless, that triage requires stringent quality assurance to be effective and continuous training of the gynecologists who will do it. Triage VIA is mainly used when you will do at the same time screen and treat, meaning that you do an HPV test, it's positive, so you will record the woman, look at the cervix with visual inspection, and for those who have a small lesion and no cancer, no evidence of cancer, you can treat them using thermoablation, cryotherapy, whatever you have. So the woman's coming back in one visit, and then you will treat her, and then there is no need for further follow-up. And this has been very well demonstrated in the Estampa study, which has been done by our colleagues from IARC in Latin America. Another way of triage is doing colposcopy. And current WHO recommendation, you use highlight colposcopy to be used. So the woman is HPV negative. She will come to 5 to 10 years according to the local program. Women is HPV positive, then she will have a colposcopy. And even also in this Estampa study, it has been shown that colposcopy performs very well for triage of women who need more diagnosis, procedure, and treatment. So we'll just spend a minute because we've heard about self-collected. Self-collected samples cannot be triaged through cytology. So this is an important issue at the moment. The benefit of self-sampling is that, as we've heard, the women do not need to come to you, but to the gynecologist. But when she's positive, she needs to come to you. That undermines the benefit, because the objective is that she's not coming to you. But for this triage of self-collected samples, we will have to wait until molecular reflex tests can be done on the sample and avoid to recall women for cytology and only call women who are HPV positive and molecular reflex test positive, because these women definitely need more investigation. There are other ways of triage. I'm not going deeply through. This is the molecular triaging methods. The community is now working very hard with our colleagues from virology departments to use and to clarify which method could be used, like P16, P77 detection, high-risk HPV viral load might be very interesting in the near future, methylation, and NGS, next-generation sequencing, and viral genomic. I'm not going to say that. Just before I finish, I want very much to emphasize that if you plan to implement an HPV test for screening, you need appropriate educational initiative. I'm not going to go all this slide, it's too much, but you have to think that when a woman will have the result, will be said she is HPV positive, she may think she has a cancer because she has heard that HPV is responsible for cancer. But she also may think she has a sexually transmitted infection. So this creates anxiety. This creates stigmatization. She may think that it's because her husband has been away, so she may fear to talk with him. So all this has to be discussed, and all the healthcare providers need a lot of explanation, discussion, so they can help the woman not fear from cancer nor from having an STI. They have to explain her that HPV test is an enhanced test for cervical cancer prevention and not to show that she has an HPV infection, that she has been somewhere out of the couple. So in conclusion, a specific triage test can counterbalance a higher test positivity of the primary screening test. In the same sample which take the cells from the cervix, you can do a triage test which will improve the prediction of precancerous lesion and offer most precise, efficient, and we didn't talk about that, but cost-effective screening regimes, which is very important for your our deciders, which may be here with us today. Currently, cytology is the most frequently triage used. The implementation of molecular triaging in the very near future may completely change the situation, and maybe we'll stop using cytology, VIA, etc., because we'll have a better test that will allow to identify those women who need more exploration. These important factors play a crucial role in achieving the global goal we have to always to keep in mind, which is to eliminate cervical cancer as a public health problem. And please don't forget that the clinician will play a significant role when you start using HPV testing, and they need to understand how to talk with the women, and this will facilitate the implementation of the HPV test. Thank you.
Спасибо, Изабель.
Thank you very much, Isabel, for such a beautiful presentation. Dear colleagues, now we will have our Druk Ilya Olkov from France, from International Association for HPV Control. The presentation is called Activities of the Agency on the HPV and Prognostic Campaigns all across the globe regarding screening. A very interesting presentation, please.
Вижу доклад здесь на ноутбуке, но не вижу на...
I can see my presentation now. Hello, dear friends. Thank you very much for the invitation to this event. I was thinking in which language to prepare the presentation. I decided to use Russian one. And PVS is the global organization which conducts the expertise and development of different HPV-associated diseases. And accordingly, my report will be focusing on the program activities, and the next on the screening and the validation activities. I will talk about this in my second report, and here I would like to talk about the information, awareness, propaganda program, and several years ago it was mentioned there is some mystic force or power that cannot be defined and that permits everything. I felt it also, I don't see it. It's mainly about propaganda, distribution of information, impacting somebody's activities or strategies or ideas, and this is of course a dialogue, active dialogue for increasing awareness. Why propaganda and increasing awareness is important part on the prevention of the and propaganda for the HPV associated cancer, and why parents shall vaccine their children against the HPV if they do not understand what is it and how it is associated with the cancer. Now let's talk about screening. Professor Margaret Stanley, one of the leading specialists in the IPS, and she is past president, ex-president of the IPVS, member of the board, and she says that the HPV causes cancer, and not only a cervical cancer, but also a whole range of the neoplasms in both men and women. So the virus of the truly have equal opportunities for different types of cancers. And let's talk about the key auditory, the audience, and what is the life, how life can look like without HPV. The dreamers, activities, use, young generation, what we are waiting from them. They need to say that they want to get the vaccine. What is the main goal? Is to eliminate the concerns and fears about the sampling, and they of course have the audience around them who are impacting their mind, like influencers, like school, parents, friends, and so on. They are like goalkeepers, and what is their role? They need to be aware about this information and make real acts, and they need from the other developing and the promoting agencies, they need to conduct awareness campaign for at the different levels, at the government and the district levels and so on, and develop the right strategies. What is the concept of IPVS regarding the World Day for combating the HPVI and being celebrated? First is increasing awareness about the HPV problem, global understanding and knowledge on HPV, because the global research has demonstrated that whenever we ask this question from people walking down the street, only 1 amongst 10 are able to explain what is it and how it is related to the cancer development. Stimulation or like facilitation of the dialogue on the HPVI associated disease and the goal of the destigmatization, like for example increasing awareness of all those diseases amongst the children like 10-15 years, and inspiring people who are already infected. And this year, not this year, it was one less worry concept was developed. Why this concept was developed? The world around us became turbulent, especially after COVID. We have number of political, military, economical events increasing our concerns and beyond our control. And another problem is like HPV associated cancer or diseases, which also create some fears amongst us. And the other campaign 2024 was focusing on positive results, on success stories, recommendations, how people faced these problems, what was their reaction, what was their healing process, how they were able to combat this disease. And this campaign is being disseminated across the world, and different logotypes here you can see on the screen were developed, and I would like to give number of examples how they were implemented. For example, in France, as we have participated in control of different things, in France we have at the highest level by the president, we have conducted a campaign called Macron's Effect. The president has mentioned it will take less than 1 minute to teach people HPV, like 3 letters. That was the main effect called Macron's effect, and the impact of this effect in different parts of the world. So we have estimated, assessed this effect. And there's another problem, that civil society might not received well this message. So the vaccination level before and after, and of course for the effective campaign we need the civil society organizations involvement. There's number of mass media tools in France, like magazine Le Monde says that we can prevent 8,000 cancer cases through the diagnosis of HPV, and the Cancer Advener journal also states that the carriers of this virus are boys like men, and the association of HPV with the cancer, and why it's important to have the vaccine, and what is the role in preventing the cancer, role of the vaccination in preventing the cancer. And this is our activity in the Russian Federation, where we have developed the training program for the doctors and for the women themselves, and with involvement of different experts, like 5-6 international experts. Here we had the workshop of the professors. What we were able to achieve? We have invited oncologists, gynecologists, infectious disease specialists, and other specialties, and we have agreed that in all 85 regions we will conduct these different webinars. We had 85 webinars, 10 offline events, and another program was dedicated to women in both offline and online formats. More than 100 volunteers have supported us. 30,000 leaflets were distributed. It was dedicated to the 8th of March, like International Women's Day, and we were giving the flower and the leaflet with the information on the preventive measures and the basic knowledge on the HPV and the preventive measures. We have developed a special website on HPV dedicated to the information on this disease, recommendations such as communication with parents, friends, or doctors, or the places, the hospitals where people can get screening or diagnosis, and another program for the different spectra of the screening programs based on the independent self-protection from the HPV. The statistical results of the campaign of IPVS, the hashtags we used for promoting these programs, more than 30 million reviews were conducted, and we have number of social mass media channels, likes, reviews, and so on. More than 64 million likes for different publications dedicated to the HPV and prevention of the HPV. More than 200,000 of primary visits, and about 150 different organizations, state and non-state organizations involved in this program. We have a number of success stories in Brazil, Ghana, India, countries of the Eastern Europe. The criteria of success which are being promoted through the webinars of IPVS. And we would like to call the Uzbek colleagues to participate actively in these programs. We are ready for this partnership. And by conclusion, I would like to say that we have many concerns, of course, currently, and as it was discussed with the last president of the ENG, the strategy of WHO on elimination will help to solve one of the problems, but the joint efforts are depending on the country campaigns on increasing awareness with the focus on the validation and elimination of these HPV associated disease. And one more report has left. Steve Conner, floor is yours. Then we will go to the lunch. He is from the Great Britain, director of the World Alliance of Hospice and Palliative Care. Simplification of the serious disease processes with the patients.
Spasiba. Thank you very much. So I'm the last speaker between you and lunch, so I'll try to be efficient and effective in getting through our talk. If I can find the controller. Here it is. Okay, good. First of all, to Marilus's comments, WHPCA nor myself have any commercial interests. We don't accept money from commercial interests, so just to clear the air about that. Right, so I wanted to just put a footnote on my dear friend, whoops, sorry, we go back. Oh, okay, so we're gonna talk about this. We're gonna paint a picture of palliative care globally, and then we're gonna bring it down into Uzbekistan and what the needs are in this country and what some of the problems are and barriers. We're going to talk about the public health model, the new WHO public health model for palliative care. So how do you build palliative care in your country? We're going to talk about, and then wrap up with some, understanding what the barriers are you face and where to go from here. So we've heard from my dear friend Sophia Michelson. Dr. Michelson and I have been colleagues and friends for many years and working collaboratively here to help develop palliative care in this country. She's a remarkable, inspiring woman. Some of you may not know that WHO has a definition of palliative care. It is the approach that improves the quality of life for patients, adults and children who are facing life-limiting illness, life-threatening illness, by preventing and addressing problems that we know are going to happen when you're faced with serious illness. And we do this by addressing person-centered care in its most developed form, which is that we are not just physical beings, but we are psychological human beings with spiritual concerns and social concerns. So we have to address all of those four quadrants in anything we do with patients, and that's one of the secrets of palliative care. Though it is, I think, something that that's just good medical care, quite honestly. Palliative care is not end-of-life care. Let me just explain that. We do, of course, have to help people at the end of life, but palliative care needs begin sometimes years before the end of life. We are part of the UN's Sustainable Development Goals. We're particularly goal number 3, which is good health and well-being. And within that is the universal health coverage goal for all countries to achieve universal health coverage. Uzbekistan actually is doing very well in delivering health care to all its citizens, but we must do that without causing financial distress. And in order to have universal health coverage, you have to have the whole continuum of universal health coverage, which is promotion. So we promote health and wellness. We prevent illness. We treat illness when it's there. And we help people with rehabilitation and palliative care, especially when we don't like people to die prematurely. None of us in palliative care do. But the fact is that the mortality rate stubbornly remains stuck at about 100%. It's just not. We've not been able to improve on that with our healthcare systems. So this is the Global Atlas of Palliative Care, which we publish in cooperation with the World Health Organization, and it paints a picture of palliative care globally. The need for palliative care is based on methods that were developed by the Lancet Commission, which we were part of, which was titled Alleviating the Access Abyss in Palliative Care and Pain Relief, an imperative of universal health coverage. So we do have an access abyss, which is characterized by the fact that there's well over 60 million people now a year who need palliative care. about half, a little less than half of those are at the end, near the end of life, the last year of life. So more than half of them before that, though that varies from country to country. Over 80% of the need for palliative care is in low and middle income countries. We're doing quite well in high income countries. Over half of the need is being met. But in low and middle income countries where over 80% of the need is, it's only about 4%. This is a huge disparity and access abyss. Mostly older persons, but we do care for children in palliative care for different reasons usually than adults. And we are doing not a very good job of managing people's pain when they're seriously ill and near the end of life. Millions of people are dying in pain because of lack of access to simple, essential, not overpriced opioids. And hundreds and millions of people are grieving after death. So we're basically caring for less than 15% of the need for palliative care globally. We went from having around 16,000 services caring for about 3 million patients in 2011, we did this research, to about 25,000 services caring for 7 million patients. We need about 250,000 of these teams globally in order to meet this need. So we're only really 10% of the way there in terms of building services. Over 1 million people die every week in our country, in our world, our little blue planet, mostly now from non-communicable disease. Good news is that death from infectious disease and from childhood conditions and maternal conditions are decreasing substantially in these recent years. And so there's been a shift away from HIV and TB. They're still a major concern, don't get me wrong, but the main reason people the main causes of death are from non-communicable diseases, and many of those are actually preventable or premature mortalities. But the same number of people are dying of injuries. That hasn't changed. As I said, about half and half people needing palliative care, sometimes 2 or more years before death, because they're having serious health-related suffering that we can alleviate and eliminate, or at least treat. Mostly older people, but children, as we said, about 7% at least. We underestimated the number of children who need palliative care. People who need palliative care, we still have a lot of HIV and TB. We'll come to that, but it's mostly non-communicable diseases. In low-income countries, the need for children is in high-income countries, the need for children is actually quite small. It's mainly in low and middle-income countries. These are the diseases. We are at an oncology conference, but only about 30% of the global need for palliative care is for oncology, for cancer and leukemia, malignant neoplasms. The other major conditions that people need palliative care for, that we care for in most countries that have palliative care, are things like heart failure, stroke, liver kidney failure. Dementia is the highest growing category. Well, that's dramatic. Thank you. Lung disease. Dementia is the fastest growing category of need for palliative care, but also other neurologic conditions, various causes of the 20 main causes of illness. Oops, I went back the wrong way. For children, it's a different picture, somewhat different picture. We see a lot of kids needing palliative care who have HIV. They are almost all children in the Afro region. We have a lot of injuries, children who get seriously injured and need palliative care. Children with prematurity and birth trauma, and particularly congenital malformations. Cancer is only about it's about 5% of the need, but it's significant. These are the symptoms, the most common symptoms in palliative care, and we're talking about serious health-related suffering. So we're talking about pain, in particular, moderate to severe pain, but also many other non-pain conditions we treat, including nausea, vomiting, weakness, GI problems, bleeding, but also mental health conditions, anxiety, depression, delirium. Those are commonly occurring symptoms in palliative care. So what's the need for palliative care in your country? You have a population of now well over 36 million people. You have a mortality rate overall from WHO of about well over 170,000 deaths per year. You have about 17,000 cancer deaths per year in the country, according to WHO. The need for palliative care is about almost 120,000 people a year needing palliative care, and only a tiny proportion of those, probably a few hundred, are getting palliative care presently. Most of those are people who are going to die the year that they need palliative care, about 65%. You need about almost 8,500 children needing palliative care. About 550 or 500 or so of those are cancer patients, and they're being cared for in the children's hospice now, thank goodness that you have. Some of them are. And about 25,000 people with cancer needing palliative care. So WHO has a new public health model. It's built to look like a house. It starts with empowered communities. This is one of the unique things about palliative care is it's a healthcare service, but it's embedded in the community. We built palliative care and hospice care because the community rose up and said we have to have it because we don't like the way people are being cared for in our healthcare system, and people are dying. This is from this document here. We also think that people with lived experience need to help inform how we deliver palliative care. So we take that seriously. We listen to people with cancer and with other conditions. They teach us. We learned everything we needed to know about palliative care from patients. They taught us what was needed. We like using volunteers. We need to do a lot of community sensitization and involve. One of our secrets is we train the families to care for their loved ones. That's what we do that because otherwise they'll be helpless and they won't know how to care for their loved ones. So in policy and some of the work that's been proposed that we do together with you are to help, first of all, do a proper in-depth needs assessment for what the needs are in the country, develop standards for how you operate programs and how you treat patients. Make sure that palliative care is recognized as part of the healthcare system. It's been recognized by WHO since 1990. We will ultimately lead to developing a national strategy for implementing palliative care to meet the large need you have. And fortunately, we have, I think, political support and government support to help with funding, though a lot of the things we do may require community support as well. We need research. We have indicators that the country can use to measure palliative care development. We really are measuring the impact that palliative care has on the healthcare system using patient-reported outcome measures, but qualitative and quantitative research, feedback from customers, but big data, as much data as we can get. We need to build, every physician who graduates from medical school in this country, in any country, should have at least received some basic training in palliative care. And same for nurses and mental health professionals. That needs to be done for medical students as well as residents and specialists and in continuing medical education. We need national training centers. Fortunately, there's a new hospice that was mentioned by the director that'll be opening sometime in the next year, which will be a great teaching center. We also need to educate the community. We implement home-based care is what palliative care is really about. It's not about building hospitals or buildings. It's about teams of people that go and care and train and support families at home. That's the critical part of it, but also outpatient. And we need some inpatient beds for severe symptom management, and we need funding. Opioids are the gold standard for treating moderate to severe pain in cancer. WHO has new guidelines on that. We need a lot of other medicines, antiemetics, anti-seizures, medicines, antidepressants, steroids, sedative hypnotics, and such. And this is the consumption of medicines in the country. That red line is globally about 5 milligrams of morphine are consumed annually per year per capita. This is your consumption. It is 0.2% for morphine. That's 25 times difference between the global average, which is an average that includes a lot of, I mean, it's a relatively low number. So I want you to take that quite seriously. This is a patient in your next door neighbor, Kyrgyzstan, who was being discharged from the hospital that day without, had his pain controlled in the palliative care unit, but he was going home and unable to receive opioids at home. So he went home and about 6 weeks later died in pain. He was paraplegic, he had bone cancer. This lady is the only woman in the unit that was actually told what her diagnosis and prognosis were because she insisted on them telling her. But the withholding of that information is more of a psychological issue than anything else. Finally, last slide, things that we need to do. We need to fund palliative care as part of universal health coverage. We need palliative care education in all professions. We spend all our money on acute care, but most of our patients have chronic conditions. We need both, but we need to do more about community chronic care. We need more capacity to deliver home care. We need more medicine for these patients. We need compassionate communities to help support the neighbors around a family that's facing a serious illness need to be supported by their loved ones, the friends and family. We need better research. We need to build more service capacity. And since palliative care is person-centered care, we think it's almost a kind of model for how our healthcare systems should be implemented in the future. Thank you very much today for your kind regards. Oh, and I have a gift for the director.
Whoa. Книга по паллиативной помощи.
The book on palliative care. Thank you very much, dear colleagues. We have reviewed so many reports. Let's continue our disputes, our questions during the lunchtime. The bus should be there at 12. Dear colleagues, we all have buses prepared for us at the ground floor. We will be driving to the restaurant and then driving back after the lunchtime. Thank you very much.
Является важной задачей, стоящей перед нашей медициной. В реализации этой благородной цели большую роль играет обмен мнениями и опытом между сотрудниками сферы. 17-18 мая нынешнего года в древнем и современном городе Бухара пройдет 20-я конференция онкологов и радиологов Узбекистана на тему «Женское здоровье, скрининг и профилактика рака молочной железы и шейки матки». В этом престижном мероприятии, проводимом Министерством здравоохранения и Республиканским специализированным научно-практическим медицинским центром онкологии и радиологии, планируется участие более 300 международных делегатов, среди которых ведущие эксперты из более чем 10 стран, в том числе США, Великобритании, Франции, Дании, Российской Федерации, Турции и Индии. Эта крупная международная конференция особенно значима, поскольку она проводится в период, когда планируется сдать в эксплуатацию уникальный мегапроект в узбекской медицине – новое современное здание Республиканского центра онкологии и радиологии. Также на мероприятии состоится обмен мнениями по вопросам внедрения в сферу самых современных методов диагностики и лечения, охраны здоровья населения и дальнейшего усиления профилактики онкологических заболеваний. Мы будем рады приветствовать всех медицинских работников на этой престижной конференции, которая пройдет 17-18 мая в прекрасном и древнем городе Бухара. Онкология – одна из наиболее сложных направлений специализированной медицины. Дальнейшее развитие этой важной области, определяющей жизнь и качество жизни человека, является важной задачей, стоящей перед нашей медициной. В реализации этой благородной цели большую роль играет обмен мнениями и опытом между сотрудниками сферы. 17-18 мая нынешнего года в древнем и современном городе Бухара пройдет 20-я конференция онкологов и радиологов Узбекистана на тему «Женское здоровье, скрининг и профилактика рака молочной железы и шейки матки». В этом престижном мероприятии, проводимом Министерством здравоохранения и Республиканским специализированным научно-практическим медицинским центром онкологии и радиологии, планируется участие более 300 международных делегатов, среди которых ведущие эксперты из более чем 10 стран, в том числе США, Великобритании, Франции, Дании, Российской Федерации, Турции и Индии. Эта крупная международная конференция особенно значима, поскольку она проводится в период, когда планируется сдать в эксплуатацию уникальный мегапроект в узбекской медицине – новое современное здание Республиканского центра онкологии и радиологии. Также на мероприятии состоится обмен мнениями по вопросам внедрения в сферу самых современных методов диагностики и лечения, охраны здоровья населения и дальнейшего усиления профилактики онкологических заболеваний. Мы будем рады приветствовать всех медицинских работников на этой престижной конференции, которая пройдет 17-18 мая в прекрасном и древнем городе Бухара. Онкология – одна из наиболее...
Да.
второй доклад, да?
Да, вот сейчас.
Вы не тот день смотрите, вот он.
Очки у меня.
Вот они. Джеспер Хансен.
Давайте это на русском. Как где это?
У вас есть на русском?
Ну, здесь в программе должно быть.
Да, вот он.
Угу. Откройте, я без очков не вижу, покажите мне.
Вот оно, значение типирования ВПЧ, скрининги рака шейки матки, Джеспер Хансен.
Уважаемые коллеги,
Dear colleagues, I hope you are okay after lunch. Could you please close the door? And those who are outside, let them sit inside. Now we are starting our session dedicated to the cervical cancer. And I would like to present Professor Bartabasun. He is the professor in early detection of infectious diseases on the cancer studies. He's onco-gynecologist, specialist on colposcopy. And tomorrow, for our gynecologists, we are arranging a masterclass, a course for the colposcopists, and thermoablation at invasive pre-cancer diseases of cervical cancer here at the Bukhara Medical Institute. The platform is ready, so I would like to go to the program. We have slight changes since our next speaker, Dr. Parthabasu Andre Karvon, will be reporting on the global strategy of WHO. We will be going to the second presentation. I kindly invite Dr. Jesper Hansen-Bond with his very interesting presentation dedicated to the genotyping, importance of genotyping at screening of cervical cancer.
Thank you and good afternoon. So, for those of you who attended this morning's meeting, I will take up where I kind of left it off, and now we'll go a little bit more into detail on how to utilize HPV technologies to make a better screening program. So, assay and technology development favors increased individual reporting of high-risk genotypes. But what is driving this development? Well, this is a, by now, very famous, yet fairly old paper by Sylvia de San Jose that shows the distribution of different genotypes in squamous cell and adenocarcinomas. This is a hint because, as I said previously this morning, we have more than 200 HPV types associated with infection in humans, but only 12 can definitively give cancer, and then we have one which is probably misclassified, 66, and then we have 68, which rarely are associated with cancer. But nevertheless, what we see from this particular figure, redone from the very famous Lancet Oncology paper, is that 16 and 18 are the most dominant in terms of disease. But they're not alone. What you'll also see here, let's see if we can get this to work. No? Ah, never mind. What we also see here is that we have other of the high-risk genotypes contributing to the cancer cases. So this is the first clue that not all HPV genotypes are created equal when it comes to oncogenicity. If we take this one, and this is from a study we did a few years ago where we compiled data from a number of large-scale trials with long follow-up that gives us data over 150 months. And what we saw when we were compiling these studies was that we could subdivide the oncogenic genotypes in the lower. But now something happens. If you look at the risk, now we are approaching the magic 10, and I say the magic line because if you're in the European Union, very often 10% is the accepted information to create very strong algorithms that is focusing attention on those women who needs it the most. So here it's classified in pretty basically similar, the same groups. 45 is a concern to some, quite simply because it causes a part of the adenocarcinomas, and very often it can be difficult, especially on cytology, to see the adenocarcinomas because the lesions are down in the crypts in the tissue and doesn't necessarily show on a cytology. But nevertheless, 45 is an incredibly rare genotype in the population, and question is, should it be given this much? Actually, it's not me doing that. You're out. This was an unforeseen risk. Yes. Well, we can try and just go on. Never start a screening program with no clear follow-up pathway. I could easily say, don't start a presentation without your slides. You have to carefully think through how you're designing your screening algorithms. Because on the other side of the actual screening testing, you have the follow-up. You have the gynecologist who have to do the colposcopy, the pathologist who have to assess the biopsies. You have to get back to the woman and inform her. There is a full pathway coming in a screening program, and that has to be considered. I want to go to the first generation HPV algorithms. Which is somehow not here. Never mind that. It's a 1618 algorithm. Never mind that. We'll go to the second generation algorithms that are being implemented in Northern Europe right now, because we have taken on to utilize genotyping as an integrated part of our screening algorithms in managing women. And these look incredibly complex, but as a matter of fact, the complexity is contained in the laboratory doing the testing. What you see on your left side are the red boxes where we are sorting out those HPV positive with the highest risk genotype, 16, 18, 31, 33, and then those who in triage have evident disease, high cell, AGC, etc. They, of course, go for colposcopy because they have a combined very high risk of underlying disease. But in the middle, you have the yellow one and the green one. Those are the one that we can relatively safely, and I say relative because nothing is fixed, we can safely send them for surveillance. There are no need, even though they have HPV infection, if they have normal cytology in the triage, there is no need for them to go to colposcopy immediately. Instead, save the resources, kind of spread it out over time, and then only on the second testing, if she remains positive for the same genotype, there might be a need to send her for colposcopy. The key to these relatively complex algorithm is that you will screen a lot of women, but only 7 to 9% will be HPV positive. Then you will do your cytology triage, and based upon that, already 5% of the 9% can be shipped for surveillance and retesting, and only around 4%, 3.5 to 4% needs to go to colposcopy. That is preserving resources in colposcopy, and that is allowing us to work also with the concept of viral clearance, because between two tests over 12 months or 18 months or 24 months, 40% or more of the women will have cleared the HPV infection. In other words, no need to send them for colposcopy because their immune function and immune system is taking care of the viral infection, and if there even is an ascus, it is most likely that it will go away eventually too. That is at least what we see. When we compare these algorithms to the previous cytology algorithms in the Danish screening program, we see that we have a gain in CIN-free detection of relative risk 1.35, but we also see a massive improvement in the service of the screening program, because HPV testing compared to cytology means that we can conclude almost 50% of the samples on the same day and send the test results out, and 99% within a full 7 days, including cytology and triage. By the end of this, if you have multiple surveillance periods, we have calculated based on a huge national program now that over 24 months, almost half of the women with HPV infection and normal cytology in the screening sample will have cleared the infection without any evidence of disease. That means let nature take its turn and do its job. No need to follow up these women, no need to bother them with colposcopy, and especially no need to allocate resources to do it. Denmark and Sweden are not the only one. Norway have just released this algorithm that is going to take place. They're utilizing the same concept. We'll have the highest risk genotypes, we'll have a medium group, and we'll have a low risk of oncogenic genotypes. And then we'll utilize the cytology triaging in order to help stratify the risk. The key is you need less cytology for doing this because you're already pre-selecting, deselecting everybody who is HPV negative. And on top of that, you can focus your attention on those with the highest risk group. So you get a very efficient utilization of your resources. It's not a coincidence that the advanced screening programs of Northern European countries are switching now to risk-driven algorithms. It is actually science, it's evidence-based, it's very cost-focused, and the political will to terminate and eliminate cervical cancer. And with that, ladies and gentlemen, I want to thank you for your attention, and I look forward to this session. Thank you.
We would like to thank you for your presentation, Mr. Jesper, and the next presentation by Ilya Olkov. The statements for the IPVS policy for the nuclear acid testing procedures. I don't see my presentation yet here. countries of the world. So if we colleagues would use not validated test, the figure would be about 30%, 3 times higher. So we will have the false positive results. And within the provision of the gynecological care and services, we can see that we have lost some cases for the secondary observation and screening. We shall always consider the repeated visit by the patients and the results for dysplasia, which were identified. We can see that C1, C2, and C3 are very important moments. So we have used cernation. Depending on the clinical picture, we used to have the suspicious cytological results were 6.5%, and abnormal variants of the colposcopic picture was 5.7%, which were compared in the risk group. The next program covered about 100,000 women. The range of the age was higher, as you can see, and those are the intermediate results which were obtained, and we have the percentage of 9.5% of the positive results of the HPV test, and the real situation based on the histological research of HPV, and 34% of the cancer in situ. And once again, if we look if we look at the use of the not verified HPV, we would have 10,000. And what we would say them, the patients, those who were not proven cancer diagnosis, and how we would overload the system of the healthcare in our country. So the other important thing I would like to draw your attention, and I think it was very well solved in your republic, the coverage, how we attract women to the HPV screening. We have attracted the bloggers. 70% of the entire work was organized not for the coverage of the screening, but the coverage by information campaign, like increasing awareness, calling for invitations to go for the free screening, the website launching, which was indicating the addresses where we have organized this free screening. We have invited volunteers. We have conducted the conference for the doctors. We have paid special attention to the interpretation to the local languages, so it can be accessible and available in remote areas, Russian, Tatar, Bashkir languages. And the period when we have started and continued this work in Kaliningrad, it was COVID time, and how to distribute the inflow of patients coming for screening, and for those who are coming for screening of a PCR test for COVID. So through the phone number, we were monitoring the attachment of the patients to the specific departments of the polyclinics and hospitals in order to separate them from the patients coming for COVID PCR tests. So, and then the data was validated. And as a conclusion, I would like to mention the IPVS policy statement regarding nuclein testing, HPV acids. We can see, and Isabel has mentioned today, that we have the shift from the cytological to the HPV testing. This number of available analysis of the nuclear testing acid-based HPV test, and we shall use only validated tests in order to ensure the specific and precise diagnosis and the validation of the methodologies, platforms, infrastructure, the system of internal and external control. What shall be done further with the patients? Conduct the regular monitoring, accreditation of the participants of the screening program to cover and to ensure the coverage at least 70%, and the harvest of the samples to validate these measures. And according to the international data, many samples were received independently by the patients. Some of them were received by together manually with doctors, and increased awareness amongst the doctors and population about the HPV disease and destigmatization. The last slide, dear colleagues, here I would like to mention that we have concerns, like personal concerns, and we know that the implementation of the strategy of WHO will eliminate at least one problem, and we will be able to combat the cervical cancer. Thank you very much.
Thank you very much. The next is Barta Basu, the head of early detection and prevention of diseases, Department Meyer, France. The topic is HPV detection and at cervical cancer screening, opportunities and challenges for low to middle income countries. Please.
At the outset, I thank Professor Mirza Ghalib and colleagues for inviting me to deliver this talk here. As you know, in 2021, the WHO very strongly recommended to shift to HPV detection-based cervical cancer screening. And for the low and middle income country perspective, there are three clear advantages. Number one, because of the high sensitivity of the HPV test and high negative predictive value, the screening interval can be extended to 5 years or even 10 years. So no more screening every 2 years or 3 years. Number two advantage, it is an objective test. Unlike the subjective tests like cytology, where you need to invest quite a lot in terms of training. Third advantage is the women can themselves provide sample, and that way they can avoid the speculum examination. So because of these three advantages, the HPV detection test is gradually catching up all over the world. So this is a survey that we have just finished. This is the result, a little old, but still what you can see is that Northern Europe, Australia, they have completed rolling out HPV detection-based screening, many of the countries. Some of the countries, especially in the Latin America, Argentina, Peru, Chile, they have introduced the test and gradually now in the process of scaling up across the country. Many of the countries are, like Brazil, they have introduced the test in a pilot mode with the intention to gradually scale up. But then if you look at sub-Saharan African countries, where there is the maximum burden of cervical cancer, most of the countries have not yet been able to introduce even on a pilot mode. So that is a problem, and we know the problem is essentially because of the cost. Cost is the silent elephant in the room when we discuss about HPV tests in low and middle income countries. But still, we need to go ahead. And as we go ahead, we need to think of the test and the program. So when we think about the test, I'm thankful to Dr. Ilya because he very nicely stressed on the fact that we need to select a validated test. There are hundreds of HPV tests coming up, But then it is important to go for the validated tests that are essentially validated with a very nice criteria, which is called Chris-Myers criteria. That means this criteria is essentially telling us that the new test should have a sensitivity that is at least 90% of the sensitivity of a validated test. Number two, it should have the specificity which is at least 98% of the specificity of a validated test, and it should have high reproducibility across the laboratories. So I'm not asking you to go through this chart on the right-hand side, but then the number is gradually increasing. So there is quite a good number of validated tests. You can just have a look at the reference that I have put at the bottom. So you have a large number of tests, and then the program has to select the test. Now here comes the real issue. Which test do you select? Cost is an important issue, but then other than the cost, there are other issues as well. There are tests, HPV DNA tests versus mRNA tests. When we reviewed the evidence for the WHO guideline, we didn't get enough evidence to recommend mRNA tests for self-collection. So if the program is going for a self-collection based screening, you will have to go for a DNA-based test. And more importantly, even among the DNA-based tests, there are different types of technologies. So the technology that you will have to select is a PCR-based test. So depending on how you want to design, plan your program, you will have to select the test. And most important thing is that now almost all the tests are coming up with simultaneous genotyping information. And this information is extremely important, as Dr. Bande has very nicely demonstrated in this particular curve. So those women who are positive on HPV-16 or HPV-18 persistently, as you can see in this large study in Sweden, even if they did not have any disease at baseline, over the next 10 years, about 15 to 20% of them, they developed CIN3 or worse disease. So in an LMIC perspective, particularly, it is important to make sure that HPV-16 and 18 positive women are immediately taken care of. In certain settings, it can be screen and treat, so women are immediately assessed for treatment, and then treatment is provided. In certain settings, there can be colposcopy facilities, that these women should be immediately sent for colposcopy. But then, when you look at the other high-risk types, the risk is substantially lower. So you may go for a triaging test. And in the WHO recommendation, there are several different options that have been looked at. We have looked at triaging with cytology, we have looked at triaging with colposcopy, we have looked at triaging with VIA. Very interestingly, the outcomes remain the same as long as you are using any of these tests. So probably in your setting, this kind of algorithm will be more appropriate. HPV-16, 18 positive women, they directly go for colposcopy. Those who are not positive on HPV-16 and 18, they undergo cytology. And if the cytology is abnormal, then they go for colposcopy. And again, the world is changing. There is a lot of evolution going on. And then some of these algorithms are quite complex. At IARC, we are now working on the new guidelines for cervical cancer screening and management for European unions. So hopefully we'll be able to come up with more specific recommendations within 1 year for Europe. Now, one thing we must keep in mind, there is enough evidence that co-testing does not have any value. Do not go for cytology and HPV testing simultaneously. This is one of the evidences. Germany, they love co-testing. And they did ran a pilot study that was nested in their program. And they looked at what happens with co-testing. You see, in the first round, because you are using a very sensitive test, you detect large number of CIN3 or worse lesions. In the second round, there is substantial reduction. That is expected. But what is most important is, when they followed up the cohort, they found that all the CIN3 cases were detected only in those who were HPV positive. Not a single case was detected among cytology positive, HPV negative. So what is the value of cytology? So co-testing should not be practiced. Again, as you know, there is enough evidence, and this is very interesting. In low and middle income countries, the acceptability of self-collection is quite high. And this is, I don't want you to go through this, but essentially I'm showing you all the studies that have showed that there can be 6 to 10 times higher participation among the women if you use self-collection. But then, as I said, HPV testing is just part of the entire story. You will have to look at the entire process of screening. You'll have to look at how the eligible women will be offered the test. Even for self-collection, there are different methods. In some countries, they are sending the kit to by post. In some countries, they are keeping the kit at a pharmacy and the women are being advised to pick up the kit from there. In some places, the community health workers are going house to house and then providing the kit. And then you'll have to think about the labs setup. What kind of laboratory setup will be good for your country? Will it be one single, highly quality assured lab? In that situation, you'll have to make sure that you have the mechanism of sending all the samples to the lab, and from the lab sending the reports to the women. So when you are thinking about HPV detection test, don't think about the test, think about the entire pathway of care. And that care pathway should be very well organized with good information system, quality assurance. My colleague, Dr. Andre Carvalho, will be talking about it. And at the same time, we'll have to make sure there is adequate investment in training. In this region, Turkey was one of the first countries to introduce HPV detection-based screening. And what kind of strategy they have followed? They have followed the strategy of having a centralized laboratory. So they have 2 laboratories set up in 2 parts of the country. All the samples go there. And what strategy they follow the screen with HPV test. If the HPV test is 16 and 18 positive, the women directly go for colposcopy. If the woman is positive for other types, they go for cytology. So that strategy they follow. And as you can see, in this region, the HPV test positivity may not be that high. So in Turkey, they found that about, using this strategy, about 1.3% of the women required referral to colposcopy. So strategies need to be contextualized. There is no one solution for all. So to summarize, first and foremost thing that there should be a policy document that will very clearly mention which test to be used, how that test is to be used, self-collection, provider collection, how all the pathway of care will be taken care of. And as you know, in the European guideline, there is a very strong stress on running a pilot before introducing new test or new approach to screening. So you should think about the pilot. And then go for the protocol that is most feasible and acceptable, doable in your setting. You have to think about the logistics. There are tests that are available, what is called point of care tests. But then, is it possible to have all those that many number of machines in multiple centers? You'll have to think about it. If you can do that, that has a lot of advantages. Supply chain management is important. Investing in capacity building is important. Having a robust system of data collection is important. What is most important is, it is not testing that will make a change. The impact will come only when the HPV test is delivered through the framework of an organized screening program. Then only our women will be prevented from developing cervical cancer. Thank you so much.
Thank you very much, Dr. Barta. Very good and useful information. Likewise, the previous contributions. Dear colleagues, let me present our next expert from IR. This is Andre Carvalho, who is also working for several years with us. He's our friend. Please, Dr. Carvalho, please.
like to thank the organizers for this kind invitation in name of IARC and my colleague Parta Bazu to be here talk with you about this in this important conference. So I was given a topic now that's about the importance of data collection and assessing quality assurance of screening programs, and I'm going to talk later on quality assurance on breast cancer screenings. So some of the data that I'm going to bring about data are going to be a mix of cervical and breast, because I think it is important. A lot of the quality assurance is linked with quality data. So one thing that I want to emphasize also during my presentation is that this should not be only about data collection. This should be about data collection that's meaningful and has quality and covers all the cancer screening pathway. So Europe, with the EU report, is as a continent collecting from different countries in the same standardized way data, right? That also allows you to monitoring along the time how these performance indicators come. In the second report, in the first report, the only data collected was qualitative, how the programs are organized. In the second report, quantitative data begin to be collected. So that was the first time that Europe tried to collect across the European Union the same standardized indicators. The qualitative information allowed from the first report to the second report to see how much there was an advance in the three cancer screening programs in the European Union, the breast, the cervical, the colorectal. And we hope with the third report to come that we're going to be able to see improvements in the quantitative information, because now that data is being collected as well. As part of the process that's moving to the third report, IARC, with Parta Bazu is the PI, led this, the CanScreen X that was about, organize what will be the performance indicators for the next report. And this all started about refining the performance indicators, right? Saying what we're going to collect. So again, data need to be meaningful when you collect. So understand what indicators are important to measure the performance of your cancer screening program is quite important. But beyond that, you're going to need to have a clear definition for each indicator, right? Which part of that come, right? Are you talking about the risk assessment? Are you talking about the part of the process that's screening triage, further assessment, treatment, the harms, and what are the indicators that you're going to collect in each one? But further on, and this is the essential part when we talk about quality data, is for each performance indicators, what you mean of that. What is the definition of participation rationale to collect that indicator and how you calculate it. So you begin to understand what is the numerator and denominator to make that harmonized performance indicator, right? And how should you stratify that, right? What is the minimum requirement that you should have, how to report participation rate according to race, according to sex, age group, screening test, and type. It's desirable in the future that you put some social determinants of inequalities, right? So it's desirable that you have education, that you have income and others, and go on. Thinking about that, once the second report came, instead of thinking how you go through a 300-page, over 100 tables to understand what's going on in cancer screening around the globe, IARC launched the CanScreen 5 platform, right? Thinking about this lack of available, accurate, and reliable data on screening policy and activities, the difficulty to access existing information, and the need for harmonization across the globe. So this is about, collecting and disseminating information globally, harmonize data collection, and assist countries in organize the health system, information system. We go through the CanScreen 5 in a very, robust data validation process to make sure that the data is has all the quality dimensions covered and is reliable. And then we can present that data in a many, interactive tool, right? And I'm going to show a little bit where we are at this stage with this platform. But I would like to emphasize again, and that have been put, before by presenters and also by Partha, right? That the data that we collect should cover all the screening pathway. Most likely, what we have in most of the countries sometimes is how many women we screen, and eventually, what is the screen test result, and that's it. And that tells you very little about a screening program. We need to understand that the whole process of screening the pathway need to be collected. And that's when, we begin to make more complex algorithms, as had been presented before in this section, right? And for each algorithm, you begin to say, oh, if it's 16, 18, you might go direct for the colposcopy. If you are the other high risks, you might need to have cytology triage. And these begin to complex the logistics of the sample, but also the logistics of the data to be collected. Because, we need to cover all the pathway. And as we can see, one of the weak sides just in the beginning is that even in the European Union, there is no data for the further assessment results, right? Some countries cannot report when a woman was sent to colposcopy, what was the result of the colposcopy, right? And this is a huge gap when we think about, the quality of the data that we have. And this is a study that we did in Latin America with over 20 countries there. And you can see in the dark bars, right, for cervical cancer in the left and breast cancer in the right, is what they thought they would have data in their system. And in the light bar, what they really could retrieve data from. So there is this misperception of the screening programs, right, that they can give you data on the screening population, the screening results. Half of them will say, oh, I can give you in further assessment, in final diagnosis, even in cancer staging and treatment. But when you say, please send me the data, you see this fall down, right? You see that for further assessment to go from over 50% to less than 10%. Even for final diagnosis, right? They have the cancer screening register, but they don't know who are the women that came from the screening that had cancer. Even when they know in the population who had cancer, they cannot do that linkage. And the same thing, for breast. A little bit better for breast if you think about, the proportion of telling I have the data and be able to give the data. This brings also that, data collection is also about how organized is your program, as Dr. Bazou has mentioned. And with this study that we perform at IARC, right, about the depth consensus, what should be the minimum requirement, right, or the essential components for you to call your screening program as highly organized, right, thinking that this covers everything. And again, when we think about, looking at the proportion of the components that countries have, and this study that we did in Latin America, we can see that some countries are in dark colors, meaning that they have over 75% of those components in their screening programs, but the majority of the countries are between 50 or 75 or below that threshold. And that shows you, the lack of highly organized programs. And then we begin to analyze what is the main bottlenecks for you to be highly organized and be able to deal with all the data, right? One is governance and legislation. The other is organization, funding, and staff that's trained for that. But also the data and the IT system that doesn't allow you to collect data throughout the screening pathway. And this is a publication that just came out that we did with our colleagues in Canada, comparing all the provinces they have there about how they are organized in terms of the cancer screening. And as we can see, when we talk about, the leadership, governance, and financing, it's all green. Everything is there for all the provinces. Access to essential services there. But when you begin to say how this is delivered and how good is your quality assurance information system, you begin to see the cracks, even within Canada. And that's because, navigating the complexity of the cancer diagnosis is not easy, and collecting data in all the steps of it is a challenge. And a robust information system is the only way you can deal with that. We still go in a lot of places that you have a paper system. What kind of works, but it's way cumbersome compared to have a proper robust information system. We need to understand that for each part of the screening pathway, and that also occurs when we're just talking about the early diagnosis for the symptomatic person, is that we think that, we're going to come negative and positive tests, but also need to deal with the possibility that, the participant did not show up or never got the result or refused to go to the next step even when the result is positive. So there is a lot of interest of how this data is shared among the IT system, and this need to be further discussed, how all those linkages from all healthcare providers in the screening pathway do that. At IARC, we think that this has to do a lot of capacity building, so we need to not only to have a better organization and a better information system, but we need to train better, for the importance of have a highly organized with good quality data collected in the screening. So where we are now in Cancer Screening 5 in terms of collecting data around the globe. So we have now over 90 countries that have been contributed with data, and that varies from the breast, cervical, and colorectal program, right? We have here about 60 countries that contribute for breast, 75 for cervical, and 51 for countries for colorectal, and these have been published. And now we are moving in the direction, as you can see, still a blank in the Middle East, in the Asia continent, and also in parts of Africa. We are moving to training, capacity building on that regions. And with that, we as part of the capacity building, they need to look at their own data. And that's the data that eventually feed back our platform. Just to show for the breast cancer, we can begin to see difference in the continents, right? About if the policy is a law, that this is not even half of the Europe is true, but goes down to half of that, only 20% in Asia and in America, but none in Africa and Australia. If you provide free screen services, if your test is mammography, this is a given in Europe and America, but not in Asia and nor in Africa, and that goes on, right? And also we begin to benchmark, what is the acceptable level, and try to understand why some countries are performing below that. And that becomes also a learning curve for each country when they benchmark. And that can only be possible if you collect the quality data in a standardized way, so you can tell, how you're performing and what are the reasons that you might not be performing as you wish in your program. Same thing for so many of the performance indicators. But I'd like to finalize, showing that performance indicators are directly correlated to how organized is your program and how much data you can collect in terms of quality. And this is, an exercise that we did with Cancer Screening 5 data, showing that more organized your program is, higher is your examination coverage. We're still limited to do this with the other performance indicators because most of the countries cannot give you much indicators beyond that. I just want to say that, the idea is for us to develop this global network and always start with quality data for cancer screening, quality improvement. Thank you so much.
Thank you very much. Microphone, please. Thank you very much for the interesting presentation. The next speaker is Nargiza Zahirova. She will be talking about the roadmap for the phased implementation of the cervical cancer screening program in Uzbekistan. The head of department. Once again, hello dear colleagues. I think that our conference from the early morning is very fruitful. It looks like our dreams come true, and we have now today in Uzbekistan the leading experts, professionals in the screening and preventing the cervical cancer. Dr. Jesper from Eurogene conference, Marylis is working with us since 2016, Partabasu, Andrei Katois, all of them are our teachers, mentors, and it's a great pleasure and it's a great opportunity to see Ilya Olkov too, and I would like to thank you all for accepting our invitations and sharing with us your expertise. And as today's conference is dedicated to the screening of the cancer diseases, I would like shortly say that, as Mr. Nigmatovich has mentioned, the main idea is currently, of course, we have still this problem as a priority. I will not stop on statistical data. We have talked a lot about this, and I would like to say that regarding the comparison by ages in 2021 and 2022, when we had the peak of disease infection, the disease diagnosis identified at this specific age range, minimum 10 or more years need to pass for these for pre-cancer condition to have the first or second category of cancer. And our state policy, starting from 2017, becoming better and better. And regarding the healthcare, we have more attention, more funds, systemization, and one of the significant regulation is the presidential decree 5130, within which we have developed the onco screening and onco control cabinets in the 217 district polyclinics, and we are implementing the investments of the Islamic Development Bank, as mentioned Mirza Nigmatovich, and one of the main component is the cervical cancer prevention measures and the treatment. And here we have the procurement of the reagents and the equipment for the HPV testing for at least for 500 women, and this project is under developing since 2022-21, and this will not cover all provinces, of course, but we will procure the thermal ablation equipment for the gynecologist at the front line. And in our branches of our oncological centers, we do not have colposcopes available in all of them, and we will procure for those which are missing. We have developed TORs, and we are currently at the stage of the bidding, like tender calls, and the radiotherapy is also undergoing, and we have some gaps in this radiation therapy, but we are planning to eliminate them, and we will conduct the capacity building for the radiation therapy specialists at the front line. And I would like to mention our pilot project. We had a joint project together with WHO with support and UNFPA with support of the Japan government grant. We had a pilot project in Karakalpakstan and Chirchik City in Tashkent region. At the same time, we had another pilot project by our Institute of Virology together with the Karvon Foundation. Our experts, one of the head of this project will talk about this in details later on. I'm just mentioning what kind of activities we had and some ongoing project. Those are results of our pilot projects. What have been done and what were the main purposes, and I would like to highlight that many doctors they have some difficulties in distinguishing screening and the early diagnosis. Why we need screening programs? When we are implementing this kind of program, the disease level is increasing because the identification of diagnosis is being increased, improved, and if we comply with all criteria, quality control, all the requirements, we will be able to decrease the mortality rate as the final goal. The main final goal is decreasing mortality from specific disease through the early identification of the pre-cancer conditions and early cancer diagnosis, and of course early treatment. We have oncologists here. They know that the treatment at the early stage gives better results. And recently we had the decree of the order of the ministry. What test will be selected is under discussion, but the primary screening will be based on HPV testing. It was justified to the government. We have provided and approved this process. Currently, in order to implement this program, we are still waiting the procurement of logistics, the equipment, tests, reagents, and so on. And we are hoping that till the end of the year we will launch this process of procurement. And we have more than 400 colposcopic equipment, and the pilot project in Karakalpakstan has demonstrated that colposcopy is like missing the specialists. There was no high demand for this kind of treatment and care, and now the demand for these specialists is very high. I would say it will be high, and slowly it will be increasing, and we need to prepare our specialists. Our colleagues from Karakalpakstan can prove that there is a significant achievement if we compare with the previous years. And what is the situation right now? Even when we are going for the monitoring, we saw that when we had sent to the oncology like different people, now pre-oncological treatment have more targeted approach. They are assessing the quality of the colposcopy diagnosis in the field.
Это правда на узбекском, потому что не получилось.
And now we can see, unfortunately it is in Uzbek. We couldn't find time to translate into English or Russian. Early detection and improvement of screening programs among population is, so far it says that early detection is applied with colposcopy. As of today, we have colposcope equipment in all of our central polyclinics, and the people are getting training, and we requested our Isabel, our Professor Partabasu, that we need colposcopic training, and we invited for tomorrow gynecologists from the primary healthcare. We asked to enroll in gynecologists who have certificate because they have informational skills. Without any informational skills, they will not be able to acquire the data on the screening. These are recommendations of WHO on cervical cancer screening. We know that we do DNA HVP tests. We'll be using. There was a discussions when we were trying to select. We decided to identify what are the tests, what the interval, what is the target group, how many approximately, how much funds are required from the point of finances. So the method is the most appropriate for us, and we can see that based on this analysis, we came to a conclusion that we can a primary HPV test. This is our roadmap. We are planning to cover 500,000 women per year. 10% will be positive, we expect. So they go to the triage. Triage means sorting or follow-up examination. As a result of triage, either patients go for the treatment or they go to the oncology for a more detailed treatment, follow-up screening and treatment. This algorithm is quite wider, and earlier our expert showed that we have almost the same what our international experts proposed as the algorithm, and I believe that we will be sticking to this algorithm, and we believe that we will be achieving results. This slide has already been shown, but it contains quite a lot of information, but this is quite important information. If you allow me, I will show this slide for our international experts, for them to hear the Russian translation. We propose to unite efforts and propose to the government to develop the national program. First of all, this is to revise the legislation on the treatment program, which is developed for the screening for HPV, establish the coordination center for the screening, establishment of the national clinical guidelines for the screening and treatment of precancer diseases, establish the screening registry of the Ministry of Health of Uzbekistan. We have already talked about this. We will be using existing in the Virology Institute and to expand and elaborate. We already have this platform with including an elaborations from the international experts. Then to implement the quality assurance program, as Dr. Andrei Carvalho mentioned. Indeed, without the quality assurance, if we do not comply with the indicators of quality, we will not achieve the required level of implementation. This is one of the important aspects. Then arrange the systematic control over the vaccination process. Today we had the report from Ms. Umarova. When we started in the year 2021, 22, 23, this is the coverage that we have demonstrated. And now we have former RSS, now it is called the Agency for the Epidemiological Surveillance and Well-being. We don't know what are the control and what are the data there, but that's why we are including here so that this process will not be uncontrolled. It must be controlled and monitored. So these interviews with people, as Dr. Elior said, this must be done on a systematic way. And there should be some committee or some entity which will be controlling this process. HPV tests I've mentioned, and then a target group. Here I would like to tell to our doctors, maybe there's some questions could be, what is the target group? Target group are the women of certain age range who are eligible for the screening on some certain disease. For example, for the cervical cancer, if it is HPV test, then 49 years. This is the recommendation of WHO, and the last recommendation is 45 years of range. We have calculated that that will be 500,000 women, and this will be a targeted group as a triage. Depending on the type of the virus cytology or colposcopy, could be selected. Technical maintenance of equipment for the cervical cancer diagnostics, because equipment could fail, so that the process will not stop. We need to think it in advance. Then forecasting and ensuring funds in the state budget to support the screening. We need to have the funds for the screening, for the testing and treatment of the pre-cancer diseases, and then ensuring our district medical facilities with the equipment for the treatment of pre-cancer diseases. As I said, thermoablation equipment for the half of our central polyclinics has been allocated in terms of funds, but for the rest, other facilities need to have the loop excision. This has been covered in previous presentations. We want to reduce mortality of cervical cancer by 30% up to the year 2030. Thank you very much. Thank you very much for the presentation. The next is Iroda Sharipova from Virology Institute of Uzbekistan. The topic is improvement of studies and diagnosis of cervical cancer in Uzbekistan. Dear colleagues, dear guests, I would like to express my gratitude to organizers of this conference for giving opportunity to get you acquainted with the results of our project, and once again to be in my city of Bukhara, where I was born. I can't see my presentation. Do I need to open it myself? Our pilot project has been implemented together with the Korean fund KOIGA and with the Virology Institute. Our pilot project is called Improvement of Research and Diagnostic of HPV in Uzbekistan during pandemic, and you can ask why the Virology Institute is involved in this topic, because recently we have started to work with the oncoviruses, and we had a project on liver cancer screening and screening of cervical cancer. It is not a secret that there is infection that leads to the oncological diseases. And number one among women is infection of HPV. In men, this is number 4 in the range of diseases. This slide is well known across the world. Cervical cancer in number 4 in women across the world. In Uzbekistan, it is number 2. Here I will not focus on each on this slide. In every presentation we can see this slide. We want to decrease mortality, as the previous speaker said. The chronology of the project, as per the initiative of Virology Institute members of staff, there was a project submitted to the COFIG Korean Fund. The COFIG analyzed this application, and after the analysis, a group of experts arrived to Uzbekistan to study for the fact-finding, and in 2019 this project has been approved. In the year 2020, the MOU has been signed between COFIG Fund and Ministry of Health of Uzbekistan, and the agreement between the COFIG Fund with the Virology Institute. And in the year 2021, this project has been approved in the Committee for Ethics, and the Executive Order number 112 has been signed by the Ministry of Health to implement this project. The aim of this project is to provide screening of women in Uzbekistan in the age range of 30-49 years old, and improvement of indicators of cytological screening, improvement of awareness among population, improvement of capacities of the organization on screening and diagnostics of HPV, and support research and development of strategy for the prevention of cervical cancer in Uzbekistan. I would like also to mention about the project itself. We planned the project to be extended for 4 years, since because of pandemic we had to reduce this project to one year, so that the project is extended for 4 years. As a result, we managed to screen 50,000 women in the age range of 30 to 49 years old. The pilot regions were Tashkent, Andijan, and Samarkand, and financing up to $2 million of US dollars has been provided by COFIG. At the end of 2023, we have screened 44,000 women, and 3 laboratories have been commissioned on turnkey. The PCR laboratories in Tashkent, Samarkand, and one laboratory on liquid cytology with modern equipment. One training center has been established on liquid cytology. The design of the project, selection of participants. We have selected healthy women from 35 to 49 years old in the polyclinics. Polyclinics invited women for the screening. Before the screening, they gave their consent. After giving her consent, the woman proceeded to the next stage, which is the HPV testing. At the positive HPV test, we did liquid cytology. Initially, we planned in one vial to collect PCR and liquid cytology, but since one vial costs $7, and for the PCR test we spent approximately, for the sampling, 1,000 sums. This difference, we had to call a woman for sampling for the HPV, and only positive women, we called women for the liquid cytology, because for the liquid cytology special vial is needed with the transportation medium, which costs $7 approximately. In the design of the project, we did additionally questionnaire survey because because during the pilot project to understand the epidemiological situation, we first did the questionnaire survey, and then we collected sampling, and for the positive PCR analysis we did a follow-up screening. This is also related with some difficulties because not all the women come repeatedly, and this statement that you have positive HPV, many women get scared of that, and certainly not many women came back. And as soon as liquid cytology outputs are received, we referred women either to the gynecologist or to the oncology specialist as a result of liquid cytology. These are the healthcare facilities which were involved in the project in Tashkent, 7 polyclinics in Andijan 3, and in Samarkand 5 outpatient facilities. We have established a single electronic registry. Before me, the presenter said that we need to know the figures, because figures are helpful in order to make conclusion what we have collected as a sample. I'm sorry? It doesn't show here on this display. The single electronic registry has been developed, screening.ssv.uz, where all the data of patient, contact information, epidemiological data, screening data, records of physicians, and the system electronic registry allows elimination of secondary testing and ensures follow-up of women. Advantages of the electronic platform: it is capable of downloading laboratory analysis in the PDF format for the doctors and for the patients. The possibility for downloading the information in the Excel format depending on the sampling parameters. If we want to see the positive results, we can receive only positive results. How many women are positive? Automated updates of the diagrams in a online format. Capability to identify the screening process for every woman, and the platform does not allow one to move to the next level until the previous level is not completed, and the button correct if there was some typo or mistake in the records. As a result, we had 8% of HPV positive. And here you can see the information by region, the highest indications in Tashkent, but as a result we had 8.2 total. The positive 3,600 women who had to have liquid cytology, but unfortunately not all women showed up. We covered 70% of positive HPV positive women who had the liquid cytology. And here what we have, I will move several slides forward. Liquid cytology for the 2,500 women without any pathology, and I would like to show you here the the data, the global data, 70% are related with the 16-17 HPV genotype, and in our interim research, the indication was 82%. And here you visually see that a 16 type is predominant, and since we have vaccination, and in the composition of vaccine, these are type 16 and 18, we can, at the appropriate coverage, we can protect women from cervical cancer. As per the detected cervical cancer based on the cervical liquid cytology, we have identified 8 cases of cancer, and these women were referred to the oncogynecologists at the district level, at the regional and the Republican levels. And out of those examined women, 8 cases were identified at the stage of at the cancer stage, at the cervical cancer stage. I didn't do any conclusion. I just want on this slide to show that we have submitted an application for the second phase of the project for the 500,000 women to be screened. And during the pilot project, we have identified that the awareness is lacking among population about cervical cancer, about the reasons for its development, and we have planned to provide trainings or learning of population. Together with the COFIC Fund, we are planning to arrange a one-year project for lecturing GPs and population on the importance of the cervical cancer screening, because many GPs, as it has been mentioned, do not know the reasons that the HPV can cause cervical cancer, because this is not their specialty, or maybe they are very much loaded with work, and GPs collect for us women. They are responsible for collecting the target population of women for the screening of cervical cancer. Thank you very much for your attention. Thank you, Iroda Pulatovna. A very good project. We are certainly aware, and our international experts gained more detailed information about that. The next presentation, we talk a lot about the capacity building. This is one of the major criteria for the efficiency of screening programs in our country. I would like to give the floor to Dr. Partha Basu, the tools for building capacity in early detection of cervical cancer, please.
One of the key mandates of the International Agency for Research on Cancer is to build capacity, especially in cancer prevention and early detection. And understanding the need as the cervical cancer elimination initiative is scaled up across the countries, we came up with different types of resources and learning programs. So we have some of the resources that are online learning. We have some digital manuals. We have some competency-based courses. And also now with the WHO Academy, which is a new WHO institution trying to centralize all the training programs of WHO. With the WHO Academy now, we are working on developing a massive online and on-site training for cervical cancer prevention. So I'll just briefly describe these. So as I understand, there are many gynecological oncologists or colposcopists in the room, and also you have plans to expand colposcopy. This is one resource, which is a digital atlas on colposcopy. This we have available in Russian version thanks to the help and support from the WHO Euro colleagues. So you can see on the left-hand side there is a menu. So there it describes everything related to colposcopy, starting right from the anatomy and physiology, and then how to do the colposcopy procedure, how to interpret findings. So you'll see all these, there are lots of images. So these are all the images I collected during my 10 years of colposcopy practice, and most of these images are based on HPV positive women. So so you can see this is just a description of transformation zone, and then with everything has been described with images. And then we have followed the IFCPC, a system of nomenclature, which is we are trying to standardize across the globe, the nomenclature that is used by the colposcopy. So International Federation of Colposcopy, they use this kind of scoring, grade 1, grade 2. So everything is showing, say for example, this is showing the pictures of some of the grade 2 findings. You can see the dense acetocyte lesions, and then some of the findings like we have ridge sign and others. But what is more important is that you click on any of the images and you can enlarge them. And every image can be downloaded freely. We don't charge. At IARC, we don't charge you for downloading freely. Our idea is people should be using this freely for their presentations, for their training programs. So there are a lot of images. And it's just not on colposcopy diagnosis, but then you can see the loop excision, which is again very important. As you go with the HPV detection-based screening, you will detect very good a good number of high-grade lesions that will require loop excision. So you can see the step-by-step description of loop excision is there. And we also have several videos. So these are again videos for loop excision of simple type, different difficult types. So all these are freely available. So you just, if you go to our, I have provided the link to the Atlas. So you can go there and then you can access the Atlas freely. So all these things are there. And then there are more than 500 cases. So you can select. If you want to look at high-grade lesions, you just click there and then about 50 high-grade lesions will come up. You click on, you want to see normal cases, you can get. So all kinds of lesions are there. And at the end, there is also a quiz. So you can self-assess yourself. The images keep coming randomly. So this, I hope, will be very useful as you think about scaling up colposcopy. We also have a similar digital atlas on HPV detection-based screening. This is primarily maybe for your GPs to understand what is HPV detection-based screening, how to manage the HPV-positive women. So the WHO algorithms and other things are there. All these atlases are updated with the latest WHO guideline. So this is, again, another resource that you can use in your training. So as I said, these are the links. So the colposcopy atlas is there. We also have a VIA atlas, but then I believe the VIA is not much practiced in this region, as I understand. But then the VIA atlas also describes the thermal ablation, cryotherapy. We have also a breast atlas. Maybe I'll show you some picture in my next talk. Then going to some kind of digital, more digital resources, cytology. Still, you'll have to practice cytology. So this is, again, a massive digital resource for cytologists. So they can go into this and then see all the different categories of lesions, and then also freely download all the images, magnify them. Now, coming to the distance learning courses, with IFCPC and in this region particularly, we have tied up with the UNFPA to do this training program. Essentially, this training program is a certified training program. So we have identified a few master trainers. So any gynecologist or anybody interested in colposcopy can register. So they will get access to 30 lectures, and then they have to go to one of the accredited colposcopy centers. There are centers, if you send us a mail, we can send you the list of people who are already accredited trainers. And then they have to do 30 directly supervised cases. Then the trainee has to go back to his or her practice and do 70 unsupervised cases, but maintain a logbook. And then there is an OSCE exam, which is like you don't have to come there. We can do it online. So it's a very structured training course, and at the end of the training course, those successful trainees, they get a certificate of completion. Finally, this is the new WHO Academy that is also coming up next to IARC in Lyon. It's already almost there. So, and then one of the very first courses that they took up was on this comprehensive learning program on screening, diagnosis, management of cervical cancer. You can see it is covering all the entire range of cervical cancer screening related services, starting from one for the health workers, nurses to do screening, then one is for colposcopies, but more importantly, we have one on program management, quality assurance, one on laboratory technology, on HPV detection tests. So that's also coming up, and one is also focusing on community mobilization and support. So this is, we are working on it. It's almost, 3 modules are almost ready. So the trainee, they register, they complete the online self-paced learning. Then there is a simulated skill development section. So we are working on this nice multimedia or 3-dimensional simulation practices. Then they go to one of the on-site centers and then practice there, and then they get the certification. And finally, as my colleague Dr. Andre has already shown this to you, CanScreen 5 has a very strong component of training, but then this training is particularly focusing on program managers, program coordinators, for them to understand what is quality, what is the value of quality, how do you ensure quality assurance in a program. And there we go by regions. Maybe at some point of time we will also focus on this region. We are already having discussion with the European Commission to have what we call third screening report, which will be focusing on Europe, but then also we are discussing with them if we can keep some of these Central Asian countries. And this is just a picture of one of the programs we did in English-speaking African countries. So this is again a very good example of how the capacity building of the core persons in a program can gradually help, help in the research project, which is our CanScreen 5, but at the same time it is providing support to the countries in improving their cancer screening programs. Thank you very much.
Спасибо большое, доктор Парта.
Thank you very much, Dr. Parta. I would like to say that we were happy to participate in the CanScreen project with our data from pilot project, and our data have been analyzed almost 2 days ago. We had 2 workshops in Brussels, and a couple of days ago we have received that our data has been analyzed and we're accepted. I believe that we will continue our work, and the last speaker of our session will be talking in the online format, Dr. Sushil Berival, the supervisor and researcher in the Oncology Institute from Washington, the United States. Dr. Sushil Berival, are you online? Can you hear us?
To share screen. It's not letting me.
Пожалуйста, включить. Ага. Видите?
Can you see us? We can see your presentation.
Вам слово.
Thank you. The floor is yours.
Can you see my presentation?
Yes, yes.
Да, мы видим. Yes, мы видим. Yes.
Okay. Good afternoon, everyone. I'm going to talk about 3D brachytherapy for cervical cancer. As we know that brachytherapy is an important component of managing advanced cervical cancer, I'll talk about recent advancement and the techniques. So 3D MRI-based brachytherapy has become standard of care for cervical cancer. Intracavity brachytherapy is the commonest technique, but sometimes intracavity by itself is not sufficient, either to cover the target or reduce the dose to organ at rest. So in those situations, a hybrid brachytherapy applicator or some freehand needle are an option to improve dosimetry and outcome. We all know the advantages image-based brachytherapy. I don't know what is happening. So what is the advantage of image-based brachytherapy? It confirms adequate placement, it improves the target coverage, it reduces dose to critical organ, and all these things can lead to better local control and less morbidity. And we can customize the applicator based on the geometry, which is another advantage of image-based brachytherapy. So for doing image-based brachytherapy, we normally use ultrasound for confirmation of placement of applicator. It could be transabdominal or transvaginal or transrectal. Now, the importance is if without the use of ultrasound, the false track could happen 15 to 20% of the time. And with the ultrasound, we can reduce the false track significantly. After the placement of the applicator, you use CT or MRI, depending on the technique available for planning. You contour based on the guideline, contour HRCTV and organ at risk, and then do 3D planning with volumetric dose constraints. So what are those constraints? So based on the published data, if you keep rectal D2CC dose less than 65 gray, the risk of grade 2 and above complication is less. But once a dose goes above 75 gray, then the risk of fistula is almost 12%. Similarly, for the bladder, we try to keep D2CC bladder less than 80 gray, and rectovaginal point, which predicts the risk of vaginal stenosis, we try to keep it less than 65 gray. This is a graph showing the risk of rectal complication as the D2CC dose goes up. You can see it's a continuous curve where at a cutoff of 65 gray, the risk is less than 5%, but when it goes to 75 and above, the risk goes up significantly. Now, what dose schedule to use for HRCTV? And that has evolved over a period of time. Initially, when ABS guideline came up, it says 80 to 90 gray. But the most recent Embrace 2 study, which has completed, aims for more than 85 gray, aims for more than 90 gray, but the lower limit is 85 and above, and sometimes aim for higher dose for adenocarcinoma. Now, this is the OER dose constraint, and as you can see, from 2012 to now, the numbers have decreased. The D2CC of rectum has gone down from 75 gray to less than 65 gray. The sigmoid has gone down from 75 gray to less than 70 gray. And the bladder, importantly, when ABS guidelines were published, there was no dose constraint. But now the goal is to keep it less than 80 gray. So D2CC rectum less than 65, sigmoid less than 70, and bladder less than 80. Now, this is a simple intracavity applicator. You can see it has got tandem and ovoids, which is MR compatible or MR conditional. So when you do the application, you could do CT scan based planning or MR based planning. This is an example of CT scan based planning. You can see the applicator is in place, and this red volume is the HRCTV, which basically covers the cervix and extend to the lower uterine segment. And this is the area which you try to cover with your prescription dose. You also contour recto, sigmoid, bladder, and small bowel. But about 20 to 25% of the patients, or even more, are not suitable sometimes for intracavity brachytherapy. So they benefit from hybrid brachytherapy. And depending on what series you look at, the use of hybrid brachytherapy may vary from 20 to 50%, and in some center it may be even close to 100%. When you use hybrid applicator, depending on whether you use straight or oblique needle, you can extend the isodose line laterally by 1 to 2 centimeters. So if there is medial or lateral parameter involvement, you can cover these medial or lateral parameter involvement by using straight or oblique needles. And that's the advantage of hybrid applicator. It can extend the isodose line laterally. It can extend the isodose line inferiorly, which can sometimes be needed for vaginal involvement. So when do we need hybrid applicator? We need for bulky central disease. One of the definitions of bulky central disease is HRCT more than 30 cc. When there is a residual disease in median and lateral parametrium, if the regression of the disease is eccentric, if you use intracavity alone, you give higher dose to OER. or this middle or lower vaginal involvement. And these are the situation where you end up using more than intracavitary brachytherapy to cover the disease and maintain acceptable dose to organ at risk. So in the largest prospective study for intracavitary brachytherapy, the EMBRACE-1, among more than 1,000 patients, about 43% had hybrid, and the D90 was about 90 gray, and the HRCT volume was about 28 cc. And you can see the local control in the EMBRACE was 92%, and the grade 3 and above complication, depending on GU, GI, was between 7 to 19%. So what it showed that in patients who got hybrid applicator, the D90 was higher than intracavitary. Like you can see, it went up from 83 gray to 92 gray, which is about 10 to 15% increase. And the local control for women who were HRCT was more than 30 cc was 10% better with hybrid when compared to intracavitary. So showing that when you have bulky residual disease, intracavitary by itself is not sufficient. So these are the example of hybrid applicator. Aru's applicator is like a vaginal template. It has got straight and oblique needles, so it can help you cover medial and lateral parameter disease. Interstitial cylinder, where it helps you cover mid and lower vaginal disease. The cylinder can help the needles and the central tandem to help you cover middle and lower vaginal disease. Plus a Kelowna applicator, which is a template, which can help you cover any aspect of disease, whether it is medial parameter, lateral parameter, eccentric, or vaginal disease. So this applicator is versatile and can help you cover any aspect of the disease for cervical cancer. So Aru's applicator is a new generation applicator. It has no ring channel. It has got straight and oblique needle, which can extend the isodolized median and laterally. When I use Aru's applicator, I end up using 4 to 6 needles to help cover both either medial or lateral parameter. So we do pre-treatment MRI, sometimes to figure out what applicator is suitable. The procedure is done under anesthesia. You use a transrectal or transabdominal ultrasound, and we do T2 sequence MRI and CT scan for confirmation of placement and planning. So this is an example of how the needle looked like in the Aru's applicator, but I'll show some case-based example. So this patient, you can see, has residual disease in the medial parametrium, and there is some disease in the lateral parametrium. So this patient has Aru's applicator insert. You can see 2 needles on the right, 3 on the left, 2 straight and 1 oblique. So to cover both medial and lateral parametrium. So you can use this needle to extend your isodose line laterally. If you did not use the needle and only use a tandem, to cover this disease, you have to increase the weighting, which will increase the dose to the bladder in this situation. Another example, you can see the needle placement helps you cover posterior lateral disease. So you are not only covering the central cervix, but also posterior lateral expansion. This is an example of, again, eccentric disease with lateral spread more than the superior anterior posterior spread. So by placing the needle, you can cover this shape of the tumor. Because if you use only tandem to cover it, your bladder dose will be very high. Another example of eccentric disease, you can see the disease more posterior and less anterior. So if you use tandem and load to cover the posterior, the anterior gets more dose. So you put needles posteriorly and posterior obliquely. So this is lateral parametrium, this is medial parametrium. You can see you can cover the disease both from medial parametrium and lateral parametrium by offsetting the tandem and using the needle weighting to help you out. Now, this is what the T2 MRI sequence looked like, and you can see the blue one is the GTV, the red one is HRCTV. So you try to give prescription dose to HRCTV, but when you do MRI, we also make sure that D98, that means dose to 98% of the GTV, is 95 and above, because that is one other important dosimetric parameter. So you not only cover the HRCTV, but also make sure that the hotspot are in the GTV, with your D98 being total dose of 95 and above. So, and IRCTV is for the follow-up dose. You're trying to make sure that the pre-treatment involvement gets close to 65 and above. In routine practice, I don't contour IRCTV, I contour GTV and HRCTV, and make sure the D90 for HRCTV is 85 and above, and D98 for GTV is 95 and above. Now, this is an example. You can see there's disease going into the mid and almost lower vagina. So this would not be covered with Aarhus applicator, because Aarhus applicator doesn't have vaginal template which can extend the isodose line beyond upper vagina. So in this patient, I would use interstitial cylinder. The advantage of interstitial cylinder is I can cover the mid and lower vagina, and the oblique needle of interstitial cylinder helps me cover this. So this is the GTV. The red volume is the GTV, and you can extend the isodose line clearly with the interstitial cylinder. Now, last but not the least example is the Kilona applicator. You can see you need more than 2 rows in this patient to cover disease, and so you can use a template-based planning, and you can use transrectal ultrasound to guide the needle placement, and you can see that you can cover the disease much more adequately. So I showed the example of 3 types of hybrid applicator: the Aarhus applicator, which can cover medial and lateral parametrial disease; the interstitial cylinder, which can help you cover mid and lower vagina disease along with the cervix; and the Kilona applicator, which is much more invasive procedure, but it can cover, along with the cylinder, it can cover vaginal disease and lateral parametrial disease. So in my practice, most commonly I use Aarhus because it's simpler and it can do job 80 to 85% of the time. But if there is vaginal involvement, then I use interstitial cylinder. But if there is significant residual disease, then I use Kilona. So depending on the clinical scenario, you can cover all aspects of cervical anatomy after external beam for brachytherapy. So this is another example of like vaginal infiltration. You can see the red is the HRCTV, thick disease. The green is the IRCTV, which is pre-treatment involvement. The right side is the normal vagina, which you try to avoid and treat. And then you create clinical goals in your treatment planning system to reach a dose of 85 and above. So I prescribe using 7 times 4. So for getting 85 and above, the D90 was 7.92. You can see for getting 95 and above, the D98 to the GTV is 8.4 and above. The bladder D2CC to get less than 80 is 5.47. So this is for one fraction, but it is projecting as if these will be the number for the next 4 fraction. So you can see your rectum is getting less than 65, bladder is getting less than 80, GTV is getting more than 95 gray, and the higher CTV is getting more than 85 gray. So, but when you do a hybrid applicator, there is some risk of complication. The vaginal bleeding can happen with the removal of the needles. It can happen 5 to 20% time. Most of the time it is self-limiting. Sometimes you need gauze packing. In cases with persistent bleeding, you may need suture placement or surgical intervention. It happens infrequently, but it can happen. There is some risk of injuring OAR when you put the needle. So it is important that you do the imaging and ensure that you don't load the needle when it is close to the OAR. And if there is puncture of the organ, you can consider prophylactic antibiotic. So in conclusion, 3D volumetric brachytherapy helps to cover target and reduce dose to OARs. Intracavity brachytherapy alone cannot achieve acceptable coverage or OAR constant for all cases. The hybrid applicator improves therapeutic ratio by increasing D90 while facilitating lower dose to the organ at risk, including rectum, bladder, sigmoid. It requires careful planning prior to the implant. The applicators which are available now are versatile and flexible, which you can customize based on the need. And brachytherapy should be trained on the practical aspect of doing this hybrid applicator. And the learning curve is shorter because they're less invasive, but they do the job in terms of excellent target coverage and reducing dose to OAR, which can lead to better outcome. With this, I conclude. Thank you.
Спасибо большое.
Thank you very much, Dr. Sushil. Indeed, apart from the screening and early detection, there is a treatment, and radiotherapy is one of the methods of treatment of cervical cancer. And thank you very much, and all the success. Thank you very much for beautiful presentation. Dear colleagues, with this, let me complete our session dedicated to the cervical cancer. I believe that you agree it was very fruitful, productive, a lot of useful and interesting presentations, and I believe that we will have more opportunities to improve situation in our country on cervical cancer. Thank you very much to you all, to the speakers, to the participants who managed to stay with us until the end, and certainly to our colleagues in Bukhara, thank you very much for such a wonderful organization of the conference. Certainly there were some technical issues, but they were resolved very quickly. Thank you very much to you all.
Sorry, сейчас coffee break, пожалуйста.
Now this is a coffee break. First one was not attended, but now we need to go to the coffee break now.
Assalomu alaykum. Yana bir marta hurmatli kengash ishtirokchilari. Обычно во второй половине
Usually continuing or conducting this kind of plenary sessions after lunch is very difficult because people are tired, people are leaving, but thanks God we have our participants with us. And the other thing is that in the second half of the day people are trying to finish early, but we will continue our work from the bottom of our heart. And today in our agenda we have the breast cancer, screening of the breast cancer and the importance for our population, for our republic. I think it's obvious, and as our section was here scheduled after lunch, I think according to the priorities, the most important, the most problematic issue. And I would like to start our meeting, and I would like to give a floor to our next speaker according to our agenda. Recommendations of WHO for identification of the cancer, breast cancer. Marilis Corbex, European Bureau of WHO, Denmark.
звук, микрофон. Включите микрофон.
Okay, I will speak to you about WHO.
Я буду говорить о рекомендациях и руководстве ВОЗ для определения рака молочной железы. Здесь у нас в Узбекистане у нас шансы развития рака молочной железы 3%, в моей стране 10%. То есть каждая 10-я или 11-я женщина имеет риск развития или страдает от рака молочной железы. Когда мы говорим о раннем определении или с ранней диагностики, нужно два аспекта учитывать. Это скрининг, прежде чем появляются симптомы. Это ранняя диагностика, она может быть осуществлена на основе клиники или через маммографию. И ранняя диагностика, которая позволяет увидеть самые первые симптомы проявления болезни. Относительно рака молочной железы при правильном лечении на ранних стадиях есть высокие риски, высокая вероятность восстановления и излечения. Давайте поговорим о затратах, как финансовых, так и человеческих. Слева у нас очень много женщин. Вот здесь прошли скрининг для определения риска рака молочной железы. И справа ранняя диагностика с ранних симптомов, то есть на основе ранних симптомов. Так как рак молочной железы здесь, в данном регионе, намного меньше проявлен, чем на Западе. Здесь скрининг также более дорогой. ВОЗ предоставляет рекомендации по скринингу маммографии для разных категорий женщин. Женщины в возрасте от 40 до 49 и 50-69.
It's not recommended for countries.
И женщины в возрасте маммография рекомендуется для женщин в возрасте 50, от 50 до 69, в странах, где очень сильная система здравоохранения, хорошие ресурсы. Для женщин от 40 лет маммография не рекомендуется, только если в стране есть очень много хорошие скрининговые программы и есть хорошие обученные специалисты по маммографии. Потому что ранняя диагностика не дает таких больших результатов. И давайте поговорим о пользе и вреде скрининга рака. И позволяет сократить интенсивность лечения, смертности рака. В моей стране скрининговые программы по маммографии 10%, 9% шансов того, что вы получите положительный, ложноположительный результат, который требует дополнительных процедур, биопсию, повторную маммографию, которые также являются нежелательными процедурами. 10% женщин, которые проходят скрининг, проходят повторную оценку. Это очень большая время затратные процедуры. Вы теряете время, деньги и так далее. И также с ВПЧ-тестами, потому что чувствительность маммографии не 100% и зависит от разных условий, от того, кто читает результаты маммографии. И в нашей стране есть повторное чтение результатов, иногда даже третий человек интерпретирует результаты при необходимости. И также другая проблема – это гипердиагностика. Относительно вопросов рака молочной железы, здесь очень много с этим связанных проблем, которые чрезмерная диагностика рака, которая не лечится или остается неопределенной, может тоже привести к нежелательным результатам. Если вы что-то видите на экране, которое вас озабачивает, назначивает повторное диагностику, но зачастую она не требует, например, то, что вы видите опухоль какой-то, не требует лечения. И в постсоветских странах систематическое лечение любых опухолей, доброкачественных, злокачественных, все, что кажется странным, все подводится под лечение, гормональное лечение, то или иное лечение, то есть это чрезмерное лечение. Вот здесь у нас количество без скрининга и со скринингом относительно определения диагностики. Это Англия, программа Великобритании по скринингу. Здесь мы видим количество без скрининга 58, 75 со скринингом и 16 умирают, несмотря на проведенный скрининг из 75. И сейчас, как вы видите, в последнее время уже категория рака молочной железы перешла от неизлечимой в категорию излечимой. Вот, и здесь мы видим, что 17 были диагностированы и лечатся от рака, который не причинил бы им вреда, если бы не чрезмерный скрининг. Есть агрессивные формы рака, которые находят через маммографию, и после диагностики пациент стремительно умирает, потому что ее начинают трогать, и она стремительно разрастается, приводит к смерти. Если бы вы, может быть, не трогали бы ее, вы бы, может быть, еще жили бы сколько. То есть здесь воздействие маммографии тоже имеет разные воздействия. За последние 20 лет мы можем сказать, что маммография позволила сохранить жизнь 5 женщинам из этих 75 диагностированных, то есть прошедших скрининг. Ввиду скрининга 5 жизней сохраняется, но 17 женщин, которым диагностировали рак груди, умирают ввиду того, что это агрессивная форма или чрезмерное или неправильное лечение. Например, в Великобритании, Франции, Голландии и так далее. Вот эта статистика весьма применима. То есть, конечно, скрининг это хорошо, это очень эффективно для предотвращения рака, но с маммографией и с раком молочной железы ситуация немножко другая. Помните, в Узбекистане показателей намного меньше по сравнению со странами, которые я привожу статистику. Давайте представим распределение рака молочной железы по стадиям. 4 страны здесь, Узбекистан тоже присутствует, стадия 1, стадия 2. И мы здесь, это зеленый цвет, и мы видим, что идея заключается в том, чтобы сократить голубой цвет, да, голубое распространение 4 стадии и оранжевого цвета 3 стадии. Скажите мне, пожалуйста, где проводится маммография и скрининг? Только одна страна здесь осуществляет маммографический скрининг в контексте национальной программы. Скажите, и я вам дам точный ответ. Здесь Грузия, Узбекистан, Молдова, Белоруссия. Единственная страна, где осуществляется программа по маммографическому скринингу, это Грузия. Мы видим, что это не дает правильного, как бы того ожидаемого решения. Здесь ситуация хуже всех. Здесь охват более 50% за последние 10 лет. Они хотели маммографию, они ее получили, но они не смогли управлять ввиду нехватки потенциала, достатка людей для того, чтобы бороться с определенными диагнозами. И давайте посмотрим Узбекистан. Использование метода Белоруссии. Вы можете улучшить свою ситуацию. Есть одна страна, который рассматривает возможность внедрения маммографии в качестве пилотного участка с позиции привлечения разных экспертов, но потом они решили не внедрять ее, но решили внедрить другую программу. Это Молдова. Видите, какие у нее показатели? Я сейчас вам скажу, что они выбрали вместо маммографии скрининга. И здесь, смотрите, по распределению стадий в Узбекистане тоже хорошие показатели. Давайте выберем, поговорим о ранней диагностике. Это сокращение первых 3 стадий продолжительности болезни. То есть это первые симптомы, когда пациент их обнаруживает, он должен обратиться к врачу. Период должен быть сокращен от первых симптомов до первого визита к врачу, должен быть короткий. И от визита к врачу до диагностики еще короче. Если сравнить скрининг, вы можете видеть, что скрининг затягивается на много лет, на несколько лет. И откладывается диагностика. Если есть откладывание диагностики, мы откладываем лечение. Соответственно, риски на то, чтобы вылечиться, сокращаются. Когда женщина приходит к доктору или когда
screening test, she don't get the diagnosis or she don't get the treatment. You saw the data of Aziza this morning. So there are some other problems to solve on the right of this slide before going to screening, and that's early diagnosis. I go back to my 3 delays, and there can be many reasons why, women are diagnosed late, why you see stage 3 and stage 4. You don't need the mammography screening to decrease that to stage 1 and stage 2. In fact, mammography will help you to go from stage 2 to stage 1. But as I said, most of the cancer can be treated. So it has a lot to do with the organization of your health system, the poor performance of the doctors, the financial barrier to get diagnosed, to get treatment, the logistic one of the woman, their psychosocial fears, and of course the waiting list for all these things. So at the WHO, we have an instrument that was developed with IARC, which is called DEDICA study, which is Determinant of Diagnosis of Cancer. And we really propose to run it in Uzbekistan to understand first, where you can improve without disbursing a hell lot of money on mammography that will not solve, as I said, the part on the right of this slide, because this problem exists. Otherwise, you would not have the stage we saw. You would have the stage they got in Belarus, because in Belarus they actually solved this part. There are different things that can be done, but I will be short because I don't have a lot of time left. Everything about early diagnosis, so this different method that you can do, which is like education and improving the referral, the pathway, even like the relation to the patient. They are explained in this guide to early diagnosis, which exists also in Russian. We have these two guides in the middle, in blue and in yellow. They exist also in Russian, and they explain to you when it's wise to implement screening and how to implement screening correctly, that it has an effect. Not like in Georgia, because in Georgia they put mammography screening, but you see the effect is not great. And finally, we have this new big book guidance from WHO on breast cancer. There is a summary of 16 pages in Russian, and soon the Russian version of the whole book will be available. And this book is the guide for Moldova to implement also this. The one on the left and the one on the right is what Moldova is using these days to implement their early diagnosis program. And thank you very much.
Госпожа Мерилис, большое.
Ms. Marilis, thank you very much for the informative report and interesting recommendations. I think they will be very useful for the oncologists of our republic. The next speaker will be talking about opportunities for the quality control, importance of quality control in breast cancer program. Andre Karvon, France.
Hello again, it's a pleasure to be here. Thank you for the invitation. I'm going to talk about the quality assurance issues in breast cancer screening programs. I want just also to reinforce what Mariluz said, that a country that don't have a strong early diagnosis program will fail implementing screening, meaning that if you cannot take care of the symptomatic woman, you will not be able to handle the volume that you begin to get when you invite asymptomatic women to your process. So referral pathway is a very important issue on that. So, and on my presentation, I'm going to bring a few things that is also applicable when you have an early diagnosis program instead of a population-based screening program, because you still need mammography in that program, right, to confirm diagnosis and so on, and quality assurance on those mammography services are quite important. You need a strong referral pathway, regardless of talking about the screening or early diagnosis. And again, this is part of your quality assurance. One reference that I would like you to take a look after that, and you can, is this publication from the Joint Research Center in Europe talking about the quality assurance scheme for breast cancer. It's very interesting because it covers the whole breast cancer pathway. So, and they have differentiated there, right? What is the part for the screening when you have that, but also what is the quality assurance that you need to do when you have early diagnosis. So it covers all the breast cancer pathway and covers, you know, three big parts of the whole process. Your outcome, meaning what happens to the patient's health, your process, what is done, and your structure, how is care organized. And for each part of that, you need a different set of tools for the quality assurance, right? For the outcomes, what you mainly need is a lot of data to understand, you know, to measure harms, to measure benefits, to measure, you know, how efficient your program is being. And this brings back to my early presentation about the report, you know, about the differences that we see, you know, in the countries. And knowing that you are performing low and improving and understand why and improving that is part of your quality assurance. The other big part of the quality assurance in the breast cancer, you know, screening or early diagnosis is the issue with the mammography, because at some point, if you start with clinical breast examination, the woman is going to need to have a mammography if she's symptomatic for the diagnosis. So this is still a part. And there you have the issue about the machine, about the participant, you know, the density of the breast and other things, about the radiographers and about the radiologists. So it's the whole complex that goes, you know, when you perform a mammography in a woman. One of the issues that we can begin to discuss is how is the dose you are exposing that woman or the breast of that woman for radiation. And you know that, you know, along the years, machines got better, you know, from analogical to digital, and then the need for radiation to have effective mammography on quality has decreased. But still you have programs that even they have a machine capable of giving the lower dose possible for a high quality image, for issues of calibration, for issues of, you know, the way you position the woman and the time of exposure and so on, the woman is going to be exposed to more radiation than she needs. And that's where one part of the quality assurance is quite important, right? So I'm going to show a few, you know, examples of the publication about, you know, the quality assurance. So let's start, you know, with the unit itself. So this is a publication, you know, looking in 47 services in Mexico, you know, for the quality or the evaluation of the mammography unit. And they took, you know, 14 components, you know, the room temperature, the, you know, mechanical stability, mobility of the freestanding of the mammography unit, comprehension manually release, the thickness of the scale, accuracy, and whatever that quality control is acceptable in the service and not. And I'd like to highlight here, you know, that something that seems to be a little bit, you know, obvious sometimes doesn't happen, right? You want a machine that's, you know, is stable and not mobile, and then, you know, 1 out of the 4 and didn't have that as acceptable. The thickness scale accuracy, you know, was not acceptable or out of tolerance in 40% of the services, right? In contrast, you know, print identification file and display of mammography was unaccepted in 100% of the programs. So the units, you know, the service units, they vary a lot, but you can see that some of the quality control are not in place at all, right? And the other thing also that they measure in this is whatever, you know, the control of the evaluation results of the mammography was there, right? So one thing was the unit, the equipment, and now when you perform the mammography, what are, you know, the comprehensive force, the ABC evaluation, the detection ghosting, and so on. And we can see that the radiation field image receptor coincidence was off in 40% of the services, right? And the image quality, by the number of elements that you observe, that's very important for a proper diagnosis or report from the radiologist, was often almost 20%, almost 1 out of 6 centers, the mammography was not performed enough. So the radiographer were not, taking care about properly exposing the breast for the image. We also can think about the radiologists themselves, right, and say how many mammographers you read per year. And I am highlighting was a survey done in Europe, and I highlight a few, like in Belgium, most of them read 1,000 to almost 5,000 mammographies a year. When you go for Czech Republic, the numbers are more towards the 5,000 plus, right? There was one radiologist in the Czech Republic that reads more than 20,000 cases a year, right? So, and then you begin to see that sometimes this is about, how many hours they work in that country and how many radiologists you have there. If you have enough, you probably can have them read a little bit less, but if you don't have enough, you force them to read more and more. But there is, a sweet spot. Even if you have enough radiologists, there is a minimum of mammography that they need to read per year as part of the quality control. And you cannot survive a program that all your radiologists are reading over 20,000 mammographies a year, because you begin to lose quality as well. Right, so there is a balance. How much time you will spend looking at one mammography and how many mammographies you see, so you are exposed to see all you need. And on that same survey, they ask, do you have been participate in performance tests? Is someone looking to your performance and evaluating that? And what we can see here, that out of the 251 radiologists that answered these, just 1 out of 4 were participating in performance test. So if you don't participate in a performance test, you might not know how you're performing, and you might not understand what you're missing and what you can improve. So, and this is also part of the quality assurance. And finally, right, comes back to what is the quality of the image that you are giving to the radiologists for reading that. As we can see in this study, right, you would like that using quality indicators that only less than 3% of the mammographies would be of poor or inadequate. And we can see this variance, along the years, and this call attention that, you need to monitor those things to see how you're performing. And why this is important, right? This is the same woman, the same breast, but you're exposing more and more of the breast tissue, right? And only in the image named D that you can look at the muscle, the pectoral muscle, behind the breast tissue, right? As that you can find this cancer that was close to the muscle, that was deep. So in A, B, and C would be really hard to make the diagnosis. In A, you would miss the diagnosis completely unless the radiologist say, I will not accept this image because I'm not seeing all the breast tissue that I need. And then the woman would repeat that. But if they accept, this is going to be the diagnosis. Same thing here. This is a woman that has breast surgery, right? And these are breasts that are more difficult to do mammography imaging. But again, in the first to your left, you don't see anything. More you expose for the breast tissue, you begin to see the cancer. And the first one, you see nothing. And the second one, a very trained radiologist might see that there was something there that he cannot do the diagnosis and ask to repeat. But in the third one is when you can appreciate that probably there is a cancer there. So towards the end of my presentation, I'd like to kind of navigate you through that first slide that I put about this European Commission initiative on breast cancer that put together what is a quality assurance for breast cancer pathway, right? The objective is to improve quality of care, to reduce inequality in accessing care for breast cancer across Europe, right? And it applies as it is to population-based organized screening programs. But if you go to the document, you're gonna see a lot of things, right? The full document applies for it, but you can pick and choose what applies for your reality. So, and so I would, you know, incentivize that you look at this document for it. Again, discover all the quality related to all the pathway from screening to diagnose to palliative care, right? So if you have early diagnosis instead of screening, you should start looking for, from the diagnosis onwards, how should I take care? This was made, you know, with participation of 35 countries with 52 experts. This is to take care about over 100 million women that potentially is involved in the screening in the European Union. It has on its 74 evidence-based recommendations, list 86 requirements for you to have in your breast cancer care pathway. Those recommendations are tailored, you know, for the 3 users profile: the healthcare professionals, the policymakers, and the woman. And finally, this is a collection of international guidelines on protocol, follow-up, and palliative care is there as well. Right? This is a comment, so I'm going to go, you know, a little bit on what encompassed inside the document. What you can see is that, you know, definitions of the requirements, measurements of compliance, what is really important, the screening requirements, the breast center requirement for diagnosis, for treatment, for rehabilitation. When we go for the screening, I showed this slide before, you know, tell you what are all the indicators you should have with all the definition on why they are important, how you measure it, and how you calculate it, but bring something else, right? Remember, in one of the first slides, I said, you know, how many mammographies should a radiologist read per year, right? And that brings that a radiologist should read between 3,500 to 11,000. So anything below it, there's no exposure enough. Anything beyond it, you're just looking too fast to a mammography, and you might miss, you know, some lesions. Also tell, you know, for the radiographers, right, that they should perform at least 1,000 mammography examinations per year, and goes on and on. Also tell, you know, how you measure, you know, measurement of compliance with requirements, right? So when you have, you know, you must have histologically confirmed breast cancer before initiate the treatment, right? And these should happen in over 95% of your cases, you know, regardless of if sometimes it's obvious. So it's a very, you know, interesting, and they are now developing, you know, the breast cancer was the one that was published 3-4 years ago. The colorectal cancer is the one that gonna be publishing next year, and for the cervical cancer, you're gonna take another 2 years, and Partha-Basu is the PI leading, you know, the quality assurance in cervical cancer, and I think also this is gonna be a very important document for what have been discussed here in Uzbekistan today. With that, I would like to thank your attention again for.
Professor Andre, thank you very much for such an interesting and very detailed presentation. Any good efforts require quality of implementation, and your report is in line with our aims and objectives. We are very much thankful for you to traveling to Bukhara, finding time and success in your endeavors and works. The next presentation is called Opportunities for Rethinking of Breast Cancer with the Terminal Tumors BRC2 and BRC3 Optimal Therapy. The report is provided by our long friend who provided us to our country a lot of good recommendations. For many years he is cooperating with us, and we are very much thankful to him. He travels here a lot to Uzbekistan and providing methodological and advisory support. This is Dr. Dinesh from our friend country India. Please, Dr. Dinesh. Thank you very much. I would like to discuss today the role of olaparib and importance of mutation at the breast cancer and ovarian cancer. A large amount of cancer, both breast cancer and ovarian cancer, is caused by mutation of genes of BRCA1 and 2. Not only breast cancer, but ovarian and prostate cancer is also has also the same mutations, because this information could help us in treatment of these patients. We know that that this types of cancer causes by the same mutations, and there's a BRCA mutation as well. BRCA agent functions the same way as it is a controller of DNA. When there is a BRCA mutation, the pathway is violated and the disease is caused. There is a group of enzymes which is called a PARP. Inhibit PARP are enzymes when it interferes DNA, it will be correct this problem, this issue, and when we control or inhibit PARP, then BRCA works through the pathway, and if we work through the PARP pathway, we can achieve a certain success in treatment or control of treatment. And also there is a special type of breast cancer which we need to look at very carefully, especially the breast cancer with more than 4 lymph nodes. The breast cancer with, when we have completed treatment and neoadjuvant chemotherapy, after the treatment there are still residual disease in the preparation. This is the second type of patients, and the third type are the tertiary negative cancer, where the residual disease remains. This is high risk of breast cancer. This is a special group which is very hardly to treat and can recover again, can appear again. At the high risk, we carefully need to do a BRCA analysis in patients. There are 3 clinical studies that prove the role of olaparib medicines, inhibitors of breast cancer. These studies were in the neoadjuvant and in the adjuvant situation and in metastatic breast cancer cases. In principle, we have 3 situations how we look at the patients. Olympia is a clinical study of patients with BRCA mutation. We have completed treatment, chemotherapy, surgery, and radiation. So we have completed both chemotherapy and radiation and radiotherapy, and we completed to the treatment. And one group used Olympia and olaparib and placebo. What we have found, the risk of invasive disease has decreased. That is, decreased substantially. And if we look at the survivability, the same 3% of survivability goes for the olaparib. If we take metastatic breast cancer, another layout, Similarly, the patients were randomized on the olaparib and placebo. We had patients with mutation, and we can see a median development of median survivability of post-recidive was 7 months and 42 months, and with speed it is higher. The same is survivability was not that high, but without progressing was indeed higher. So if we look at the efficiency of olaparib with the BRCA mutation at the early stage and in the metastatic cancer, olaparib helped us a lot. If we take cancer, ovarian cancer, we know why we have included ovarian cancer in this presentation, because ovarian cancer and breast cancer is controlled by BRCA mutation. Oftenly, these types of these types of cancer is mixed. The same patient has breast cancer, and in several years we can detect ovarian cancer in the same patient, and this is BRCA mutation. And we know that the largest challenge with ovarian cancer is that survivability in the median survivability, whatever we do remains small, from 10 to 18 months, and more than 70% with ovarian cancer relapse. And there we need to do something apart from what we do. We do surgical operation, we do placenta, and we do ovasumab and others. After that, still the majority of patients relapse, and we need to find something else for the treatment of such patients. This is a usual layout for the ovarian cancer. Patient relapses, we use the same, the other scheme, symptoms, and relapse again, and that repeats several times while the patient passes away. This is the same scheme with the ovarian cancer patients, and this is the disease when we need to find something new, and any medicine will be better. The BRCA mutation, as I said, is one mutation. There is a notion which is called hormonal deficiency cancers. BRCA mutation is only one mutation. Apart from that, there are a group of genes which, if there are mutations in those genes which respond the same, and the disease develops in the same way as at BRCA mutation. These mutations are CLK12, ROD1, P10, TPP53. So all these mutations, if available in the patients, then this disease will behave badly, severely. At the ovarian cancer, the breast cancer, we need to do BRCA analysis. BRCA analysis can be done in two ways. Either blood sampling, this is a germinal, and we can do on the tissue of the tumor, somatic. There could be a mutation in both, and there could be mutation in the tumor itself. In any case, in both cases, the patient behaves with a commutation if it is germinal and somatic, and indications depend on the mutation independently on where it takes place. And other mutations, if they are positive, especially at the ovarian cancer, they will behave, and PARP inhibitors will be operational even if there is no BRCA mutation and other mutations exist. How can we evaluate that? We can do mutation on the BRCA mutation only, and we can make analysis, as it is called, hormonal deficiency score. And so this is a scoring of all genes taken together. This is a program, and as per the program, the companies give the scoring. In the US, it is only one Myriad that provides analysis. That's why it costs a lot. It is expensive, and they use not only BRCA, but they use different genes, and they will tell if there's deficiency or not. There's a scoring. If it is higher than 40%, it is deficiency. That means the PARP inhibitor will be working. If deficiency is low, it will not be working. There are two more methods that is used in India. That score costs 50%. If the deficiency is higher than 50%, then BRCA inhibitor will be working. So when we want to use BRCA inhibitors, it is better to use this analysis in hands. Where we need to do BRCA analysis? So recommendations NCCN and ASCO. It is in principle recommended BRCA analysis to do in all the ovarian cancer patients. There is a small difference. NCCN says that we need to do all, and ASCO says that that we can do only germline analysis. If germline analysis is negative, then we can do somatic, so on tissues of tumor. In principle, it should be done if you want to use PARP inhibitors. This analysis, we can clinically tell that a certain patient has possibly BRCA mutation. Oftenly, we have to resolve such dilemma. People say, I don't have money, I cannot do BRCA analysis. How can we suspect? This is only suspicion. We can only suspect when in the same family there are several ovarian cancer patients, or breast cancer. A mother has ovarian cancer, a daughter has breast cancer. So highly likely that in this patient she has breast cancer or ovarian cancer, or prostate cancer in the father, and breast cancer in daughter, possibly or highly likely that there is a BRCA mutation. And clinically we can't suspect BRCA mutation if the situation, it is emergency situation and we cannot do analysis. Then we need to use this clinical situation so that we can use drugs. And usually the plitexil-taxine on the tumor decreases. So the tumor decreases. In such situations, BRCA is sensitive. There are a lot of such analyses when BRCA sensitive exists. Olaparib works. With other genes, this sensitivity decreases. The more genes had a mutation on this pathway, the higher efficiency of olaparib. Almost 15% of ovarian cancer has BRCA positive. There were two trials, which is called SOLO-1, where the patients, after the completion of treatment, so the ovary treatment has been completed with the carboplatin courses. If there were cases when small disease remains, there are situations when there is when they are cleared, and the placebo controlled treatment was there, and this is the graph. Together with a placebo and olaparib, we can really see such graphs in the oncology. In the median, the progression of the olaparib has not achieved, and only 13 months remains in the placebo group. And efficiency of olaparib at the ovarian cancer with BRCA mutation. And here we don't have any justification. This is a huge difference. Unfortunately, at the breast cancer we can't see that, but at the ovarian cancer it is always like that. At the ovarian cancer it is more important, because there relapses are observed and there is no treatment. At the breast cancer, there are more options, and that's why at the ovarian cancer, this information we need to cover. Maybe it would be useful for us. 12 months, 24, 36, 48 months, we can continuously say that olaparib is efficient. These are 7-year data of this group. The same median is almost 56%. There were a group of patients who remained with the disease after the chemotherapy, and even in this group, 27% of patients full remission started. Olaparib was effective, and after our primary treatment, the disease remained. We have demonstrated that this is a 7-year survivability, 45.3% of patients with olaparib and placebo. So, in principle, at BRCA mutation and with the efficiency of hormonal deficiency, we can use olaparib. At the ovarian cancer, we cannot use olaparib in the group where we do not do BRCA, we do not do analysis, but if the patient is placebo sensitive and the relapse takes place later than 4 months, so I have completed placebo, and so these patients are called placebo sensitive. In these situations, I don't need to do BRCA, and when I don't need to do pathway HRSS pathway, hormonal recombination pathway, and I can use olaparib without such genetic studies of ovarian cancer. This is one group where without studies we can use olaparib. For the others, it is better to use screening or studies at the cancer.
Спасибо.
Thank you very much for the interesting presentation. We have received a lot of information about gene mutation, and I think this information will be very useful for the oncologists, for ophthalmologists, and we hope that our joint cooperation will be strengthened further, and we will continue our work for the benefit of our people.
Следующий доклад называется «Методы локализации в хирургии рака молочной железы». Читает доклад Фатих Айдаган, медицинский центр, Турция. Пожалуйста, слово вам, доктор Фатих.
Good afternoon. I work as a breast surgeon at Memorial Bahçeli Hospital, which is a comprehensive breast center in Istanbul. I have had a chance to visit Uzbekistan a few times, but not Bukhara. This is my first time. I have so great colleagues and friends from Uzbekistan. I am so happy to be here. First of all, I would like to thank to the organizing committee, Mirza Galebe Tiryashkov and Dr. Lola Alim Hojeyeva for their invitation and friendship. There is no conflict of interest. In the beginning, I'll give a little information about non-palpable breast cancer, and then we will look over localization techniques, including wide-guide localization and the new localization techniques. Non-palpable breast cancer is tiny tumors, and their rate is increasing. Currently, if we perform regular breast screening program for whole population, 1/3 of breast cancers are non-palpable at the diagnosis. It is difficult to identify by physical examination or intraoperatively due to small size or anatomical location. So why do you think non-palpable breast cancer rate is increasing? There are two main factors. First one is widespread implementation of mammography screening programs. The second is raising general public awareness on the breast cancer. You know, Angelina Jolie is not famous actor, also famous among breast surgeons. For example, after Angelina Jolie's surgery announced in New York Times, many women admitted to breast cancer screening. This is mammography screening track from Professor Mirzagaleb Telashkov's speech. So we will see more non-palpable breast cancer after your screening program. By the way, I'd like to congrats to him and the screening committee for their success about breast cancer screening program in Uzbekistan. Anybody can find Eddie in this picture? It is too hard, right? Eddie is a character. Let's think that Eddie is in Bukhara and we have to find in this Ulugberg madrasa. Do you know how many rooms in this madrasa? Anybody can say? If anybody knows number of the rooms, I will give small gift, Turkish delight from Istanbul. Any guess? What? Yeah, you will, I think 160, but 40, yeah. I will give small gift after my speech. Like this picture and madrasa, it is not easy to find non-palpable breast cancer in the surgery. We have to locate correctly, find in the surgery, and excise with safe margins. If any failure occurs, a second operation will be needed for positive margins. So how can we do? Many localization techniques are described. Y-guide localization is standard technique, which is used commonly in the world. ROL, RSL, and intraoperative ultrasound techniques has been used many years. My colleagues and I describe a new localization techniques, which called IFOL. It means indocyanine green fluorescence guided occult lesion localization in 2012. And these new stars are Savis code, Maxit, and RFID. Let's see Y-guided localization firstly. A wire is placed by the radiologist in the morning of the scheduled surgery to be guide for the surgeons. As surgeons, we cannot see the wire tracked under the skin, and the radiologist described the wire localization projection, such as the wire is 3 centimeters above from the nipple. Wire guide localization has some disadvantages. These are delay in operation room schedule, patient discomfort due to wire, additional operation may be required due to positive margins. Rarely, the wire can be displayed, migrated, or transected. One of other techniques has been started. Due to those disadvantages, wire-guide localization may disturb the patients and the surgeons. If, as we surgeons don't feel comfortable, we seek for new techniques. One of other techniques has been started at the European Institute of Oncology, which is located in Italy. I had been at this institute as a visiting surgeon. The radio-guided acute lesion localization, or ROL, which is a preoperative localization technique, was introduced at the European Institute of Oncology. In ROL technique, instead of wire placement, a radiotracer solution is injected into the lesion within 24 hours before the operation. A gamma probe used intraoperatively to detect and excise the non-palpable breast cancer like a detector. After the lesion is removed, the gamma probe is used to check if the lesion is correctly excised and centrally located in the excised breast tissue. After I learned and transferred this technique from European Institute of Oncology, our previous breast group in Istanbul University have performed more than 1,000 surgery using this ROL technique. We published numerous articles about ROL technique in national and international journals. Let's see our and other study results. Results of the studies, including our articles, showed that no discomfort for patients in the contrary of the waveguide localization technique. Duration of localization and surgical excision is shorter. Reoperation later is lower and cosmetic results are better. Roll can be performed on the day before the operation. It means more flexible schedules for surgery at the operation room and the radiology department. Our next goal was to improve the roll technique. We have since improved the technique and have invented innovative new methods called A-roll and MR roll. One of those techniques, which is MR roll, has been awarded by the British Institute of Radiology in London. Roll is a great technique, but has some disadvantages, like nobody is perfect. What will be next step after? The roll is it requires nuclear medicine department. Skin can be contaminated, and intraductal dissemination may occur. What will be next step after roll technique? I was looking for a new technique which is better than roll. My colleagues and I developed a new technique which is called IFOL. We use liquid indocyanine green for this technique instead of the radiotracer. Liquid localization materials can be spreading, such as intraductal, so we need a novel technique which is not used liquid to prevent spreading. The other technique is RSL. Dr. Gray and et al. Reported the technique. RSL can be performed within 1 week before the operation, but it is expensive, radioactivity is higher, and radiation strict safety restriction is needed. I have made interesting localization technique called MEXIT during American Society of Breast meeting in Dallas, year 2016. It was not liquid material, and the technique doesn't need a nuclear medicine department. Whenever the MEXIT comes to Turkey, I tried the technique, and we were happy after the first operation. I'd like to share my observation about the technique. Main advantages of MEXIT are 1 by 5 mm seed is used instead of a liquid. This seed does not spread as intraductal like roll technique, and these seeds can be placed more than a few months prior surgery. Remember, no technique is perfect. Disadvantages are special equipments which is not interfere with the signal are required for MEXIT, and detection performance of the manual magnometer is limited in lesion deeper than 4 centimeters. Finally, I have met radiofrequency identification tag localization, or RFID technique, end of the last year. RFID tags combined with a newly developed handheld reader show tremendous promise and for imaging guided preoperative and intraoperative tumor localization. I tried RFID using a phantom model which we previously described. The RFID probe can assess the distance in millimeters between the tumor and probe, for example, on 10 millimeters from the tumor or 40 millimeters from the tumor. What do you see in this slide? What can we do using those materials? Turkey breast, pea, and Omento olive. Maybe food or meal, dinner for dinner. But we have developed a low-cost training phantom model for localization of occult breast lesion using those materials. This model also helps with the learning curve of techniques. Dr. Lola learned the new techniques using this model when she was working with us. We use this phantom model to compare different techniques such as MEXIT and RFID. These figures show localization with RFID method. The article just published a few months ago. We compared RFID and MEXIT using localization and non-palpable tumor model. This study found similar success rates for MEXIT and RFID for localization of non-palpable breast lesions. Both techniques might be conducted without the need for a nuclear medicine team or radiation safety protocols in clinics. The last technique is Ceviscot. It's a radar localization for breast cancer surgery, but it was not available outside of the United States until this year. I used 6 cases. I don't have enough experience about Ceviscot. Maybe next year I can give more information about this technique. Let me briefly touch on the technical details. Localization can be performed under mammographic guidance as a stereotactic, or it can be performed under ultrasound guidance. You can see the seat easily under ultrasound. The area of maximum radioactivity was used for detecting the site of incision. One of the most important advantages over the virus that you can make incision above the lesion. A specimen radiography demonstrating the seed in the center of the tumor. Lastly, I'd like to mention about neoadjuvant chemotherapy and articles about localization techniques. Recently, we prefer neoadjuvant therapy more than 50% of the patients. Sometimes we see complete response after neoadjuvant chemotherapy, like the first 2 figures. Therefore, we have to localize the tumor using clips or seeds before the neoadjuvant treatment. So we will use seeds or clips more in the future. If we look at the PubMed, we can see that there are some articles, but we need more research articles to decide which technique is better. There are potential take-to-home messages. There are potential advantages of new techniques over wire localization. RFID, Ceviscot, and Mexit can be placed days, weeks, or months prior to surgery. It means more flexible schedules, patient flow, operation room efficiency, and patient convenience. The new techniques can be adapted to neoadjuvant chemotherapy also. The last word is wireless time, and I'd like to all of you invite to Istanbul to see a great place. Thank you so much.
Спасибо, доктор Фатих, за интересные сообщения.
Thank you very much for your interesting presentation. The methodology and methods you are using in your surgery practice is very interesting and require a lot of attention. In USA, it's being widely used. And how widely this methodology is being introduced in your country? Is it like widely used only in your hospital or like widely in the entire Turkey? Is it accessible in other hospitals of Turkey too?
Most of the surgeons use wire-guide localization in Turkey, but some institutions, physicians prefer the new techniques. We have opportunity for all techniques, RFID, Mexit, roll, and the other techniques, but it is needed more cost for the patients. Some physicians prefer these techniques. We firstly used RFID in Turkey, Mexit in Turkey in our hospital.
Спасибо. Ну что ж, мы
Okay, we would like to thank you for your presentation. And next presentation in our agenda is
contemporary algorithms of early cancer horizon of diagnosis. Irina Kalyadina, the Center of Palliative Care, Russia. The presentation will be online. Irina Vladimirovna, the floor is yours, please. Dear colleagues, good afternoon. Allow me to to tell about the the algorithm of the early HER2 plus cancer. Approximately 4 years ago, legendary Dennis Her proved that the HER2 gene amplification is caused by 5 copies. These patients has a progression of this mutation and died because of the brain cancer. The HER2 gene with the anti-HER2 therapy was absolute progress in the treatment of such patients. EPT studies proved that for such patients with the chemotherapy adjuvant treatment is 2 administration of docetaxel for 12 milligrams for 1 year, and we see the numbers of 7-year and 10-year indicators of non-relapsing onco survivability. And microcarcinoma of 5 millimeters. Do we need to administer trastuzumab? In the year 2021, in the St. Gallen conference, the Palian study has been delivered with the positive cancer with the tumors up to 5 millimeters, and it occurred that anti-HER2 therapy with trastuzumab decreases by 85% of the relapse. And if patients did not receive the trastuzumab, then the relapse for the hormone-negative trastuzumab is higher 7 times. And that's why at the conference in Gallen in the year 21, it was made a decision that for the patients with microcarcinoma, also is discussed to prescribe chemotherapy, especially if non-alveolar hormone-independent cancer, breast cancer. On the second stage, if there are lymphatic nodes, we can see the survivability curves, and the idea was of the escalation of the affinity for the patients of the double target blockade with trastuzumab and pertuzumab with the adjuvant mode. The study of large study of 5,000 patients, 2/3 of patients has the lymph node lesion, and 1/3 of patients has hormone negative status, 2/3 hormone positive status. HER2, the 6-year, 7-year studies, the group of lymphatic nodes lesions has double target blockade, pertuzumab and trastuzumab, independently of hormone negative status and hormone positive status, and we can see absolute trastuzumab decrease by 23% of risk. And this does not depend on the number of lymph nodes lesions, 1 or 2 nodes with lesion. We can see a decrease of the risk of relapse by 23% independently if it is 1, 2, on to 1 and 2 and 3. 8 and 4 years of observation, we can see that the curves started to bifurcate. 8% and decreases of the mortality risk minus 23%, and the increase of survivability of 2% for the trastuzumab, and it reminds independently of the number of lymph nodes with lesion and hormone negative, hormone positive status. And in the clinical status, the patients with the lymph nodes lesion, we see at the first stage at the pre-operational treatment, and this is justified. If it is a local stage, we can see inoperable status into the operable status and to do the surgical operation as the second stage. If it is the surgical operation of the tumor, we can have the opportunity to do a reduction of the coronary treatment, and after the post-operation treatment, based on the analysis, histological material response of the tumor to the treatment, we can select the patients with the favorable, those who achieved a positive potomorphosis and unfavorable potomorphosis. For those patients, we can change the further algorithm of treatment and to change their destiny. And no adjuvant was used in the Anderson Center, which was made in 2015. It is planned to include 164 patients, chemotherapy, anthracycline with the following regime: trastuzumab, anthracycline, and chemotherapy without chemotherapy. And after the 42 patients included in the treatment, that the survey it doesn't make sense to continue the treatment, because with trastuzumab the pathomorphosis is 64%, 65%, and those who received only chemotherapy only 26%. And the ethics committee pretermly completed the project with the advantage of the trastuzumab, and then we work out the most optimal layout: 3 consequent combinations of chemotherapy and trastuzumab versus chemotherapy without trastuzumab, double increase of pathomorphosis, which translates to the better survivability. We can see the increase of non-case and survivability of patients with trastuzumab. Then we increase the trastuzumab and trastuzumab neoadjuvant stage that proves that 4 regimes with blockade with trastuzumab and trastuzumab ensures dual increase of survivability of 46 and this number coincides with the surveys with 3 modes of chemotherapy, but in general with trastuzumab. And we know that the full course of chemotherapy, its completeness impacts on the growth of tumor, and regression of growth ensures survivability. What mode can be selected for the double anti-HER blockade without trastuzumab or without these studies? And it proves that the mode is equal to the frequency of pathomorphosis. We can see large numbers, almost 60 and higher % of patients who has the tumor regression at the pre-operation stage, and the survivability rate is the same for the with the anthracycline and without anthracycline mode CCHP. At the same time, the survivability, the cardial, is for the TCHP mode. The same study from Netherlands, which continues this idea and contains 2 modes, tetracycline TCHP and without anthracycline with TCHP. And this mode TCHP is done in a different mode, which we usually do, taxane ondansetron, but in the mode of everyday Paxil administration and carboplatin plus trastuzumab. What we can see in this trial, the same pathomorphosis rate is higher, 68 versus 67, and pathomorphosis translates into the overall survivability and event-free survivability, and better survivability and safety on this tetracycline, 10 times lower frequency and of the febrile neutropenia, and survivability is higher for the long term of observation, 2 times less the relapsing of tumors, and this is first of all acute leukosis and bioaplastic syndromes. Evolution of treatment have driven the evolution of surgical treatment. If 2/3 of tumors can be destructed before the operation, then maybe we do not need to excise the whole breast. The studies show that almost 80%, half of the patients with the stage 3 has conversion, optimal conversion, and we don't need to do mastectomy by conserving the tissue, and the destruction of tumor is special, and the tumor becomes smaller. It does not fragment into small pieces. If really in 2/3 of cases the tumor is destructed in patient, then we can label the tumor. We can we can destruct the patient after the 2 courses of chemotherapy. We can see a response from the tumor only by the label. We can see where the tumor has been located, and by this labeling we can reduce the tumor area, and by marking, by labeling, we can identify where the tumor was, so that we can consequently use the targeted assessment of the tumor tissue to assess the burden. If in the patient we could see such good results, then in lymph nodes we can see the same good response from the tumor. Indeed, we can see a regression of in lymph nodes of tumors in 50% of cases, and there is a new concept. Maybe we don't need to remove the lymph nodes. Maybe we can mark or label these nodes, make the new adjuvant therapy to blockade, and then if there's conversion and the status was clinically 0, all the lymph nodes tumors has been eliminated. Then we remove labeled lymph node, and if this lymph nodes there is no metastasis, then operation is completed. With that, the patient might not be going through the lymph dissection. Why do we need this all? First of all, we need to identify the residual tumor tissue. Then targetedly we remove the spot of tumor, and targetedly do a resection to remove lymph nodes which existed initially with lesion. And if in patient there are residual tumor, to identify that area and to provide non-adjuvant therapy or adjuvant therapy. The tumor burden based on the RCB1 is associated with the increased survivability. The same goes for the RCB2. This is the triple cancer and hormone negative and hormone positive cancer. We can see the decrease of the curves. This is a minus 10% of survivability to the 5-year and 10-year period. And the same goes for the RCB2 and RCB3. That's why the main idea of the study Katrin was after non-adjuvant, neoadjuvant therapy, after the tumor, after the standard trastuzumab, and a change of regime of treatment to the Carsil in the dose of 6 milligrams once per 3 months, and it occurred that non-continuing of the same trastuzumab treatment, if the tumor remains after such treatment, it is and change to the Narcosil allows to decrease the growth of tumor by 50%, and this is the advantage of the survivability without a non-invasive Narcosil. Independently of what type of the regime of chemotherapy is used with antrazim and without antrazim, either it is a new case or a hormone negative or hormone positive status. Almost all groups has the advantage when we move to the CatSeal. Only also in the groups who remained with HER2 status, even this group has a good advantage of therapy to CatSeal. We have 100% survivability if the treatment has changed to CatSeal versus 70% and absolute gap of to 51%. Last year at the conference in San Antonio, we have presented a long-term results, Catherine, and we can see that these are not significant increase of the survivability rate. It increased to 14%, absolute difference of 7-year indicators. We can see the general survivability rate absolutely high for the CatSeal, and versus 74 degrees of mortality, plus 5% for the patients. As of today, the optimal is to provide chemotherapy with a double blockade trastuzumab pertuzumab and to change to the CatSeal. This algorithm goes the maximal figures of survivability as per the Catherine studies. This is 95% of 3-year survivability without a non-invasive treatment. CAT-SEAL must be done in parallel with the radiotherapy if it is appropriate. CAT-SEAL is done together with the hormone therapy if it is indicated, if the patient has luminal cancer, and the therapy of CAT-SEAL is the optimal option of post-adjuvant therapy. We need also to bear in mind CAT-SEAL is the target chemotherapy, and it can cause the hematocytopenia, peripheral polyneuropathy, cardio non-characteristic, and for these we can stop administration, but not to cancel. We can postpone and go to the stage of reduction. It is important to remember that two-stage reduction of dose can be prescribed to maintain the effective treatment to eliminate adverse events. We can postpone treatment to wait for the recovery of the functions of the organism and to reduce the dose. That's how what Catherine trial did. How the algorithm looks in practice. The patient is 56 years old, menopause, the breast cancer of left breast. The tumor is in the 2 lymph nodes. Non-eliminal HER2 cancer of the 3rd stage. Without any eliminate metastase. Certainly a neoadjuvant therapy is provided. TCHP mode is prescribed. We mark the tumor. We do a neoadjuvant therapy, and in one of the nodes of lymph in the breast there is a residual cancer, and this is the pure X-ray response. Can we maintain conserve the tissue? Yes, we can, and this we before the surgery we mark the area. We do the resection, and we can see a good response. That in one node of breast there is a full regression and in the other low metamorphosis. With the drug metamorphosis, with the tumor burden, positive cancer in the patient. What is the algorithm? Certainly conceal in the standard dosage every 3 weeks. Of the 3.6 milligrams per kilogram. Adjuvant radiotherapy was done together with a CAT-SEAL. At now, after 4 years of observation, the patient is without progressing of the disease. We can see good aesthetic results, and certainly results which we are very happy with. The patient with the stage 3 at the beginning, almost 4 years of observation, no relapse of the disease, and we hope that further the patients will be happy. If at the early stage of HER2, it is recommended to provide treatment with surgical operation. The adjuvant therapy is optimal with the trastuzumab. And as to the morphological treatment, it is N+ status. Then chemotherapy is required together with pertuzumab, dual target blockade. With affinity. As I said, this is the optimal algorithm of treatment. If the patient has a uveal cancer, then all the patients starting from the optimal for the patients T2 and higher status without anthracycline therapy. Plus dual target therapy, artuzumab and trastuzumab. If a patient has full chest pathomorphosis, then we continue with trastuzumab plus minus trastuzumab. If status was NPO status, as per the affinity data. If a patient has the residue, then we use CAR-SEAL. That's the best what we can provide to the patient. If the radiotherapy in parallel together with radiotherapy is chemotherapy, if it is luminal in parallel with the hormone therapy. So this is the algorithm of treatment. That's what we use today in our practice. And thanks to this practice algorithm, this is a golden section of treatment which does not change since 5 years, since 2020. As of today, these are the best. Thank you very much for your attention. I wish you good health and success and well-being at good conference. Thank you.
Спасибо, уважаемый.
Thank you, Irina Vladimirovna. You have presented a very good results of treatment. As far as I understand, HER positive is a very difficult, very complicated aspect, but the results are very impressive. Thank you for finding time to connect with you in the online mode and to deliver your presentation at our conference in Bukhara. Good health and success to your research. Thank you very much. The next presentation is efficiency of breast cancer as the screening test data of randomized studies.
С докладом Парта Басу.
Parta Basu, the head of the early diagnosis.
Is it on?
The clinical
In Uzbekistan exception. And if you look at the all incidence for all cancer sites, breast cancer is number one, including both male and female. But what is more important is, if we look at the mortality to incidence ratio, this is a very important indicator to understand the quality of care. So normally we expect the mortality to incidence, you can see in Uzbekistan, the mortality to incidence ratio is nearly 50%. Normally we expect it to be 20%, 25%. So essentially that is showing, number one, most of the breast cancers, they are being detected at a late stage. And number two, many of the patients, they are not having access to appropriate quality of care. So that is reflected in the lower survival as well. At IARC, we evaluated the evidence for mammography-based screening. When we looked at the randomized controlled trial, there is definitely a very strong evidence that mammography screening is effective in reducing breast cancer mortality by 20% in all the randomized population. And when you specifically look at the women between 50 to 69 years of age who actually underwent mammography, the reduction in mortality is 40%. So no doubt, mammography-based screening is effective. And that is why in Europe, most of the countries, they are screening women between 45 to 74 or 69 years of age every 2 to 3 years. Now, outside of Europe, if we go to look at Brazil, Brazil is a country where women have access to mammography screening every 2 years between 50 to 69 years of age. Brazil is a country where there are more mammography machines that are actually required to deliver the screening services. But when you look at the mortality from breast cancer over the decade when there was very strong mammography-based screening, you see there is no reduction. So what is happening in Brazil? So what is happening is the coverage of target population is less than 25%. It's a young population, they are getting mammography screening every year. first suspicion and completion of the diagnosis should not be more than 60 days. So this is essentially talking about strengthening the health system, removing the barriers to early diagnosis. Even in most LMICs, in the district level or secondary level hospitals, it is difficult to get core biopsy done. So there we need to improve the capacity to do biopsy histopathology. And the third GBCI target is 80% of the breast cancer patients should be treated appropriately without treatment abandonment. So these are the three targets. In these three targets, CBE has the role in improving the first target. For the rest, we need to make sure that the health system is responsive enough. At IARC, we have come out with this, again, freely available online atlas. This has a component of training on clinical breast examination. There is a component on training on diagnostic mammography, diagnostic ultrasound, and breast pathology. So again, this, I have provided this link to this. If those who are interested, you can go there. There are a lot of images. It's good material for training the different healthcare providers. So to conclude, mammography screening, yes, it works. It has benefits, but then the screening has to be provided in an organized framework, making sure that there are adequate capacities to provide 2-yearly or 3-yearly mammography screening and making sure that the screen positives are appropriately taken care of. Many countries have included clinical breast examination tests every 2 to 3 years, but it is important to keep a tab on what is happening. It is important to measure the impact of this kind of this screening. But then again, the most important thing for breast cancer, better outcome in breast cancer is making sure that the women have access to good quality diagnostic care, good quality treatment care if they are having symptoms or if they are detected to have breast cancer. Thank you very much.
Спасибо, доктор.
Thank you very much, Dr. Parto Basu, for your report on the randomized research. They are always very informative and evidence-based and transparent. And your report related to the randomized research was very interesting and informative. Thank you very much for finding opportunity to come and to participate in our conference. Thank you very much. And the next speaker will be talking about the international recommendations. Leila Hadjikadjic. Leila Hadjikadjic Gusic will be talking about the international recommendations on the early stages of cancer treatment, breast cancer.
Не слышно вас. Техники наши, посмотрите аппаратуру.
The NSABP then came about in the 1970s with a physician named Dr. Bernie Fisher, who was a surgeon, and his brother was a pathologist, and they established the National Surgical Adjuvant Breast and Bowel Project out of Pittsburgh and started using randomized controlled trials to learn how to treat breast cancer. So the first thing that he did was ask a very bold question at that time, which was, do we really need to do aggressive surgery? Which is very difficult for a breast surgeon, a breast cancer surgeon, to ask of his peers, is the treatment that we have been doing up until now, the only treatment we have known up until now, the actual thing we need to do? So in the early 70s, they randomized women who had clinically negative lymph nodes and who were felt to be operative candidates to in clinically negative versus clinically positive. The clinically negative had the radical mastectomy that we knew, compared to a total mastectomy without axillary resection, compared to total mastectomy plus the addition of adjuvant radiation therapy. There was no chemotherapy at this time. And what I've pointed out here is that in the radical mastectomy, where again all of the lymph nodes were removed, 40% of patients were node positive. you would assume the same thing would then be in the group of the same population of patients who only had a total mastectomy and did not have lymph nodes removed. However, only 18% of those recurred. So again, another starting to think about the fact that perhaps lymph nodes do not carry as much weight in treatment as we thought, and this was the early 70s. We also showed that the groups with the solid lines are on the graph up top. Those were the clinical negative lymph nodes, and the ones on the bottom were the clinically node positive. And he showed that disease-free survival was better for the patients that were clinically node negative. However, none of the surgical groups had any difference in overall survival or disease-free survival. So the question of was more aggressive surgery better was answered in the 1970s, and the answer is no. 25-year follow-up of this also showed the same thing, that the disease-free survival and overall survival in all of the different surgical groups was not changed. And so the concept of the Halsted mastectomy stopped being done at that time because it was shown that more aggressive surgery, even in the 70s, did not lead to an improved overall survival. Then Bernie Fisher took it even further. He asked, can you do even less surgery? Do you have to take the breast off? So this was NSABP B6. That was a randomized controlled trial in the now late 70s into the early 80s, looking at operable breast cancer, again, tumor size under 4 centimeters with either negative or positive axillary lymph nodes, so stage 1 or 2, early stage breast cancer. They were randomized to a total mastectomy and taken out all the lymph nodes. Still not the Halsted mastectomy, but just a total mastectomy and all of the axillary lymph nodes. Lumpectomy, so part of the breast off and still axillary lymph nodes, and a lumpectomy plus adjuvant radiation and removing the axillary lymph nodes. The reason that they kept the axillary lymph node surgery stable is that when you were looking at an equation, for example, you only want to move one variable. You want to keep everything else stable so that we can tell what it was that caused the difference. This is the first concept of the no tumor on ink from the standpoint of margins of a lumpectomy, and radiation was to the breast, not the axilla. This also of note was the introduction of chemotherapy, but certainly not the chemotherapy that we use now. So again, this is just the slide showing the 25-year follow-up from the database showing that if you do a lumpectomy alone, in 10 to 15 years, the chance of a cancer recurring is up to 39%. If you add radiation therapy to that, it drops down to 14%, and some more recent studies suggest that that's even as low as 7%. So radiation therapy reduces the chance of in-breast tumor recurrence in early-stage breast cancer by 2/3. So this is standard of care. Survival was looked at also with all of these different groups and did not change, meaning certainly, can you do breast conservation therapy safely? And the answer was an overwhelming yes. So early 80s, that was a very clear answer with randomized controlled trials that you certainly don't even need to take the breast off to treat early stage breast cancer when you can do breast conservation safely with a lumpectomy and radiation therapy. Kind of going historically along the line of the history of breast cancer, adjuvant hormonal therapy was then introduced from a standpoint of in the 1980s. And so they looked at estrogen positive tumors that was anything greater than estrogen of greater than 10%. So there's some problems with this, but anything was considered estrogen positive. And tamoxifen was shown to have an improvement in overall survival and disease-free survival. So in 1986, tamoxifen was approved for adjuvant therapy for estrogen positive tumors. So clearly another standard of care for early stage breast cancer is anti-hormone therapy in estrogen positive tumors. Neoadjuvant chemotherapy and NSABP 18 then changed the way that we thought about the order of the treatment of breast cancer. So this was now late 80s into the early 90s. Patients, the question was, what should go first? Chemotherapy and surgery, or surgery and chemotherapy? This is where the first concept of the pathologic complete response came out to play. And we found that women who had a pathologic complete response after neoadjuvant chemotherapy had an improved disease-free survival and overall survival. That was the primary endpoint of the study. The secondary endpoint was clinical and pathologic response and converting women to less aggressive surgery such as a lumpectomy, as well as downstaging axillary lymph nodes. So we found that that over almost 80% of women were downstaged from a less aggressive operation. Only 3 of them progressed, and 16% of patients downstage with positive axial lymph nodes. So this was an overwhelmingly positive response that we should consider doing neoadjuvant chemotherapy as much as we can to get a better pathologic response for patients, to then perhaps give them a better oncologic outcome, which is the holy grail in the treatment of any cancer, certainly breast cancer. So all of a sudden, we went from the Halsted mastectomy with a very, very radical resection, no reconstruction, to a woman looking like this with 2 very small incisions on the breast and the axilla. This is essentially getting to the gold standard of what we consider today. I'm going to go through the rest of these a little quicker, but we started to ask the same question on the axilla. Can you do less surgery on the axilla? So this was a trial that basically looked at, can we take patients who basically had a randomized controlled trial that was done in multiple different United States and Canada, that was looking at, for women who had clinically axial lymph nodes, do you have to do an axillary dissection, or can you just do a sentinel node biopsy? This was the original NSABP 32. They showed that a sentinel lymph node could be removed in 97%, that only 1% was outside of level of 1 of 2, which is why an axillary dissection in breast cancer should really remain to the levels 1 and 2 and not go beyond to level 3. And that if you used 2 dyes and took out multiple lymph nodes, the false negative rate dropped. And an acceptable false negative rate of B32 was 9.8%. They essentially showed that in that scenario, if you had negative sentinel nodes, there was no different whether you took a few out or did an axillary dissection. So can we do less surgery on the axilla? Yes, we certainly can. Herceptin then, from a standpoint of treatment, came out in the 2000s, showing that when you added standard combination chemotherapy with Herceptin, there was a 52% decrease in disease recurrence. So obviously for HER2 positive patients, this was a game changer. Taking it even further, we then looked at the Z11 trial, which was a non-inferiority trial looking at patients that were early stage breast cancer, clinical T1 and T2, invasive breast cancers, who had a sentinel node biopsy and had positive lymph nodes. Did you still need to do an axillary dissection or not? So they looked at women who were randomized with positive lymph nodes to taking out all of the lymph nodes versus not, and found that an axillary dissection when there were 2 or less lymph nodes compared to a sentinel node biopsy did not carry any additional benefit. And so based on the Z11 trial, we know that if 3 or more lymph nodes are taken out and positive, those women benefit from an axillary dissection. And it also showed us that then you need at least 3 sentinel nodes to be able to answer that question. So now really we've moved from the 1800s, from taking radical surgeries, mastectomies, to the 1990s, early 2000s, where you do a lumpectomy and you leave positive lymph nodes behind. So Halsted certainly would be changing, moving in his grave. This is an ongoing trial. I apologize. This was the ACOSOG Z1071 trial that was essentially similar to the Z11 trial, but with neoadjuvant chemotherapy, going even one step further, saying if a woman had a positive sentinel node and then had chemotherapy, can you check, if a woman had a clinically positive biopsy-proven lymph node, then had chemotherapy, can you do a sentinel node instead of taking out all the lymph nodes? One of my partners was a part of this trial, and they essentially showed that chemotherapy eradicated nodal spread in 40% of patients. The sentinel node was correctly identified in 92.7%, and you needed, again, 2 or more lymph nodes to drop the false negative rate. And if you took more than 3 lymph nodes and used both dyes, that rate dropped even further. So back to the acceptable 9% risk. A similar trial was done in Europe called the Sentina trial. Both of them showed the same thing. So essentially now we know that if a lymph node is converted negative after chemotherapy from previously being positive, you again do not need to do an axillary dissection. So historically, in the 1800s, the radical mastectomy, this is what women looked like. Bernie Fisher comes about in the 1970s, starts asking questions using randomized controlled trials and evidence-based medicine, showing that you can do chemotherapy and end up doing a lumpectomy and a sentinel node biopsy and have the woman have possibly an improved outcome, but look significantly better cosmetically. Tamoxifen was then approved in the 1980s. The introduction of neoadjuvant chemotherapy was really in the late 1980s. Herceptin then came around. Then we started continuing to go along and show that we can do less axillary surgery. And now even considering not taking out all the lymph nodes when some lymph nodes are positive. So we have come an incredibly long way, where Halstead certainly didn't imagine this to be, understanding that this is not a surgical disease. This is a paradigm change in that the disease biology drives treatment, and it's not just surgery, but the advent of adjuvant treatments such as chemotherapy and radiation therapy that have gotten stronger, that has improved outcomes in breast cancer and truly showed the power of multidisciplinary care. Very briefly, I want to talk about premenopausal women. So young is less than 40, and the questions are, do we treat them the same? Can you give them, do you need to be more aggressive? About 5 to 6% of women are under the age of 40. They do roughly get the same cancers. An overwhelming majority are still estrogen positive, hormone positive, HER2 negative. However, in the young women's group, there are a significantly large proportion of women who have more aggressive cancers such as triple negative or HER2 positive cancers. However, oncotype studies do show that even in this age group, there are some patients that you can see on the right of this forest plot that have low risk disease. So just because you're young does not mean that you need chemotherapy. So we trust the biology. We trust that if an oncotype was done and shows low risk disease, even in young women, we should not be treating them with chemotherapy. Should you give them adjuvant endocrine therapy? Although there are certainly concerns with premenopausal women, there is still significant overall improvement in overall survival, and therefore the answer is yes. Can you perform the same operations? Do you have to do more aggressive operations just because a woman is young? There are several of these meta-analyses, and you can see there is no difference in less aggressive surgery versus more aggressive surgery just because a woman is young. Survival outcomes we do know are lower for younger women across all stages, early stage and advanced stage breast cancer, but this is likely due to the fact that more younger women do potentially fall into a higher representation of those more aggressive tumors such as triple negative or HER2 positive. These last two slides are just on some of the international work that I've done in Bosnia, which is the country where I'm from. Last year, myself, along with a consortium of multidisciplinary specialists in Bosnia and Herzegovina and the United States, but originally from Bosnia, came up to publish the first national guidelines on the breast cancer management in Bosnia, understanding some of the limitations that are there. This is available, and I'm happy to talk to anybody about this. And I do work significantly in that country and would be happy to work with you further. This is just a slide showing, again, pictorially, the advances from what we've gone to with aggressive surgery to now significantly more cosmetically pleasing surgery with an improvement in outcome. Thank you again for allowing me to give a talk. I would be happy to answer any questions online. Thank you again.
Спасибо, доктор Лело.
Thank you, Doctor, for your data. Very interesting data. I think that the results of your studies will help us in our future work, would be useful for Uzbek mammologists and oncologists. Thank you. The next report is called a selection of treatment at early stages of breast cancer. Lola Alimhajayeva is presenting from Tashkent. The floor is yours, please. Dear Chair, dear colleagues, I do understand that we overworked our time, but I will try to be brief to show the main points of my topic. Breast cancer today is not only a main issue of healthcare globally and in Uzbekistan. Every year, as per the Russian healthcare, there are new cases detected, more than 2.5 million, and unfortunately half of the patients pass away. And what is the situation in our country? As of today, breast cancer is the headache of our healthcare system because this disease increases. For the last year, the number of oncology patients was more than 27,000, 40% of those can be identified at the preventative examinations and screenings that we talked today. At the first stage, 11%, at the second stage, 56%, 22% at the third stage, and 9% at the fourth stage. 5-year survivability is 47%, and mortality is 5%. Why the disease is increasing in its number, we all know, because the lifespan is increasing. The more people, women lives, the higher probability to detect breast cancer. The lifespan is 60 years. There are more women have the probability to get the breast cancer detected. First of all, we recommend, as our colleagues recommend, to do screening and to do the primary examinations, because we know that 80% of such approach allows to decrease the early stage detection of the breast cancer. Due to last presidential decree number 5130, more than 13 mobile mammographies have been purchased, 13 stationary, and the first pilot region was Bukhara. Apart from that, we have opened 230 cabinets on Nazaret, starting from April 2024, April 2021 up to 2024. We did mammo screening of healthy women in the 35-65 age women, and 5,000 cases were identified with breast cancer. With identification of such a large number of breast cancer cases, the first stage, we certainly have the opportunity to do oncoplastic and reconstructive plastic aesthetic operations. With such approaches, we, likewise, our international colleagues, have the chances to provide such operations and to deliver those on international conferences. Certainly, we started within the last 2 years, but we have the results that we would like to demonstrate. What is the oncoplastic surgery? This is the combination of two sciences, oncology and aesthetics. Our aim is to achieve optimal treatment result in controlling breast cancer, and with this we need to take into account individual wishes of each woman to achieve the best cosmetic effect with minimal defects. We need to mention that lastly, at early stages of breast cancer, with the conservative operations, we need to take into account oncological situation. We don't need to forget about oncological situation. That means that the stage of the cancer, its severity, neoadjuvant therapy, and having a good effect, full potamorphosis, post-operation X-ray therapy, and to study the margins of resection. If all the data we have, we can certainly provide such type of operation, but we need to bear in mind that in our republic more than 35% are detected at the stage 3 and 4, and majority of cases are young patients. And in this case, we can think about the radical mastectomies that we need to provide without any take into account any cases of aesthetic approach. Reconstructive surgery are symmetry and volume of breast, symmetric of some mammar, and the areal complex and minimal adverse effects. What is the decision of doctor? This is the size of localization of tumor. Today, the size and localization are contraindications for such types of operations. Because we have good schemes and regimes of the treatment, we achieve good effect. At the localization of tumor, we are capable of closing defects and restoring symmetry at any localization of the tumor. So the size and localization is not a contraindication. The form, the size of breast, indication of ptosis are not the contraindication for the on-organ plastic operations. Existing of mutations in BRCA1 and BRCA2, we know that these are very aggressive mutations in genes. Certainly we can provide subcutaneous mastectomy, restoring of breast, and preventive mastectomy and restoration of symmetry of both breasts. Central multifocality can be done at the operations. Multi-centricity multifocality is observed in 10 or 12% of primary patients. After the conservative operations is 60%. But 97% of experts, Sangalan, recommended that at such a type of operations, conservative and multifocal operations. So this type of operations are not contraindicated for such type of operations. What are the main conditions? In what main conditions we need to maintain? These are clear margins of resection. So at reductal carcinoma, no more than 2 millimeters. The invasive carcinoma, no tumors in the colored ducts. The full regression of tumors in order to receive good results, and certainly consent of patients herself. What is the successful reconstruction? How it is possible to reconstruct the breast which was with cancer, and how can we restore the initial breast? First of all, this is a correct cone and a spot and good cutaneous area, areal and symmetry of the both breasts. We should also bear in mind that every woman is individual, and every woman has its own size, its own ptosis, and its own tubularity, and besides, we need to know that every woman has its degree of subcutaneous sizes. The second is the tissues are located closer to the skin. The average width and good. We do the mastectomy with youth expander, and with the second stage we move to the implants. At the second stage, we can. At the first stage, we can at the same time can do a reconstruction of breast. We also have subpectoral facilities. Installing implants under the breast. The implant is fixed; it does not move and does not distort the structure. Another advantage that it fully covers. By fully covering implant, we decrease the skin necrosis. But the disadvantage that 70% who go in for sports at the attention of breast, we observe that we can observe the jumping breast and distortion of the structure of breast. At the prepectoral installation, as I said, we can install the breast tissues. We can use the mesh implants or acistular matrix and dermal matrix. We can use thoracodorsal tissue, and this is a single time operation. We do not damage the breast, and less pain. The only deficiency is that There's one only disadvantage. The two-stage operation is done at small sizes of breast and with low fat in the breast. We develop the expander in the pocket, and we see how the size increases, and we achieve the size which the patient wants, and we replace expander with the implant. What is the advantage of these operations? We can restore the breast which we've seen before, and we can decrease the defect of ischemic of the skin at the one-stage operation, even if at the one operation we can remove the fold and restore the breast. What is the advantage of a one-stage operation? A one-stage operation is, first of all, this is a psychological component. When a woman is proposed to have mastectomy, this is first of all under skin mastectomy, and in one stage the breast is restored. Certainly this is a single stage operation, and many our surgeons, 80% they for the one-stage operation, because as of today many techniques are developed for providing beautiful one-stage operations. Today we want to demonstrate the results of our center, the operations that we provide within the last 2 years. This patient, 44 years, she has breast cancer in the left breast, BRC1 and BRC2 elevated. In this case, we did 8 courses of chemotherapy and subcutaneous mastectomy of the both breasts with the single replacement of with implant, mesh implant like Hinkali we installed. After 1 year of operation, we can see only disadvantage is rippling the folds on the skin, and now the patient needs additional lipofilling, good symmetry, and the patient is happy with the results, with the outcome. A resection of the left breast with the single time thoracodorsal skin pattern. Now foreign international colleagues, use of thoracodorsal is not used, is not good, but our Russian colleagues likes this approach, and we like this pattern because this is the magic operation, because we can conserve 80% of breast, and we can restore this tissue with thoracodorsal approach. And the second advantage, when we remove the complex, we can recover the nipple together with thoracodorsal skin. Here we can see left breast, the patient after 1 year of radical resection with the construction of thoracodorsal skin. We can see a good symmetry. This is the case when we have removed at the left breast. We had to remove a nipple and the areola complex, and we achieved a good symmetry from the additional operation and the tattoos on the nipple. The patient didn't want to have a tattoo of nipple. We started to use oncoplastic resection. This is a radical incision of a tumor within the tumor itself, without and with a lower percentage of relapsing, and with and good cosmetic result with the granular tissue with Z-type incision. The patient 54 years, good output. We did operation on the right breast, and the second the second picture on the identical, we can see a good cosmetic effect, and with time this sign will not be even knowing in 2 years about operation, and will not see the scar. Oncoplastic resection, we covered the medial defect. Oncoplastic resection of left breast on T-type inverse, we have taken the lower glandular part with the excess of skin around the areole, and we improved the form, the quadrant of right breast. The similar operation we've seen in Turkey, the same operation with lymphodissection. Oncoplastic resection of left breast with using master PEC-C techniques round block from the axillary lymphodissection. You cannot see whether the operation was the quadrantectomy, the resection of Fabry adenoma with the periola approach. This method of operation we have started recently. This is our second patient. We used this method. We tried to start this method at the cutting of the breast. We restored the breast with the toracadrazole patches. That's why the use of toracadrazole allowed us to restore the breast. I think this is a quite good result. We have only 2 operations. One of the operations is 2 oncoplastic resections. On the left breast, we did a symmetric operation of the right breast. Thank you very much for your attention. Something like 20 years ago, we didn't ever think that we need to restore symmetry and beauty of women. We just stayed with what we had. We treated patients, we increased their survivability, and by using the contemporary radiotherapy and chemotherapy, the survivability increased, and the patients had the need for restoring a beauty. Breast is very important for women, aesthetic organ. Women want to restore this organ, and we thinking that it is sufficient for us to treat to achieve good results. But the need of women caused that we oncologists, mammologists started to think that we need to restore beauty of women as well. Not knowing myself, 20 years ago, I did the first restoring mammoplastic. This is not what this was. The name was at that time macromasty. That was 20 years ago. One patient came with the claim that the woman cannot carry the breasts of a large size. She had pains in the shoulders, and I reduced the sizes of breast. She was my relative, and she's still alive, and she's very happy. She's grateful for oncologists and the oncoplastic operations. Reconstructive operations are becoming very popular lately, especially within the last 10 years. And many oncomammologists started to provide such operations. We have many oncomammologists in Russia, not talking about the the international colleagues. Now Dr. Lola provided her results of treatment of such patients. What she demonstrated is very demonstrable operations. The size has been restored, and the patients received a psychological relief. The patients who suffered such operations, they are happy and they feel a fully happy women. One element which we call a sexual satisfaction, as we called. This all leads to the fact that women feel a full member of our society. That's why I think these operations must be welcome. And Laura Telmovna, I wish good success to your in your operations. And I would like to add that these results are not only my results. This is the achievement of our department because all our specialists had training in Russia and in many other countries. Thank you very much. We have our last report. These are the results of a 2-year pilot mammographic screening in Uzbekistan. The report from Alexander Soskov from the Republican Oncological Center, please. Dear colleagues, let me present our joint report. Republican Medical Oncology Center Radiology and Bukhara colleagues, we contributed to the mammographic screening not only in our area but across the country. Thanks to our colleagues, I would like to start saying that in our country we have more than 3.5 million women who are a targeted population of mammographic screening. Why we have selected this range of age? Because incidence of breast cancer is higher within 45-65 years. And the average lifespan of women in the Republic is unfortunately 73 years. So there is no need to screen up to 70 years because the aggressive treatment of breast cancer leads to the death of patients rather than its ignoring. We, before starting we had a long years of preparation. As Dr. Mirzagalip Niganovich said, that we started preparation of the mammographic studies since 2016. We studied models of different years, and we decided that the most important factors are high coverage, no less than 70-80%, and strict monitoring of all processes of mammographic screening. That's why, studying different models, we selected centralized control and monitoring and reading on the platform of the information system. And as it has been said in 2019, as per the decree of the President, we started to work in Bukhara region once again together with our Bukhara colleagues. During the COVID times, we started to train personnel, started the construction of facility. IT infrastructure was developed, and by the May 2021 we started full-fledged screening. And then we studied the results, we studied the challenges that might emerge, and as per the presidential decree 5130, the equipment has been purchased. Additionally 14 mobile mammographies has been purchased, and so we established the points of growth in the districts of country. So briefly about equipment, I will not talk about the equipment. All the equipment is uniform with a single technical maintenance, with a single company which in the online mode 24/7 providing maintenance. This is important for such work, for everyday work, when the equipment should not be should be used. Every day 30 women are coming. If the equipment is not operational, this will be a disadvantage for the program. Based on our regional branches and our oncological center, we have established a centralized double and triple reading. First reading is done by our specialists working in the regional centers. These are X-ray specialists who had the training course mammography. They do the primary reading. It is important not only in the mammoth screening process, but it is important for them as the opportunity for the capacity building. As we said, the experts of mammography can be X-ray specialists who reads in a year for no less than 5,000 mammograms. Now in every region we have every month more than 10,000 mammograms. So every X-ray specialist every month reads 10,000 mammograms, and this could be a workload, but this is a normal load, and the specialist could see the norm and could see the deviations from the norm, the cancer. I would like to talk about the architecture of our IT system. We have several modules. These modules are divided into working modules for X-ray laboratory workers. These are the modules for X-ray specialists, and the modules for informing patients, for statistics, GPS monitoring. What are the advantages? So we have a single database and statistics in the online mode. The single database allows us in the real-time mode to receive the previous images. In the Bukhara region, we can see that women, due to a good information, they voluntarily come to the second round and of readings, and since we can compare the previous reading with the current reading, we oftenly see the interval cancers. 2 years, women did not have any changes. In 2 years, there were some microcalcinates, some compactions, or changes in the structure. That gives us, in the future, to detect more cases of breast cancer at the 0 stage or in situ cancer. And the task of such regular screening is to have more identified detected cases at the 0 and the 1st stage, even the 2nd and the 3rd, and not talking about the 4th stage at the regular screening. This is nonsense. This is a disadvantage for the program. And we know that before starting a full-fledged screening, we need to establish opportunities for the follow-up screening in the regions, so that in every district branch there will be a 3D stereotoxic screening of contrast and non-contrast mammography to do a core biopsy. All these must be provided to women, and not for women not to travel to other location. By using this opportunity, we will invite women to Tashkent in order to develop science. But due to this project and also IBR project for equipping our branches, since this year we will be having all these capacities: 3D biopsy, MRI with contrast mammography. So all the combination of what we need at the screening. Our mobile offices are equipped with the GPS monitoring system. That is needed for, first of all, to control the appropriate operation of vehicle, of machine. We can see where the driver can violate the traffic rules, which could lead to the damage to the too expensive machine. We can see where the cabinet is located, not by asking the manager of this office. That gives us an opportunity for the control. Doctors know and the managers know that there is a continuous strict control and account. This makes the personnel disciplined. This is a good factor. call center, an important aspect in the organizing mammographic screening. This is also an achievement. We, first of all, first in the history of our center, established such a call center when women can know and can get registered for the screening.
And in the future, we are planning to conduct SMS information sending. And we have many opportunities. And in this regard, we would like to say that we have many ambitious plans. Shortly about the algorithms of the mama screening, we would like to mention that, as it was mentioned, we have more than 200 cancer control cabinets at the family polyclinics, and we have hybrid clinics and breast examination, palpation, and the manual manual screening and so on, especially in those regions where we have lack of the resources. For example, in Bukhara, we have opportunity to conduct the population screening. In other regions, we do not have this opportunity, but at the same time, in Bukhara, all women are going through the control cabinets, and if there is obvious clinical symptoms, without losing time on the mammography and receiving the results, she is being sent to the mammologist cabinet to the branch of our center. And I would like to mention that we have added in the red model Bharat 6. It's a practice, it's a method. The main goal is to identify the breast cancer and start treatment. The other algorithm of screening was not under control, and the last deadline, according to which now in a screening task we have control for the results of the treatment, the comparative analysis of treatment of those who came from screening, and the other things. So we need to conduct the economical justification. And as per results, we can see that from May by March 2024, within the Republic, we have conducted mammographical screenings for more than 308 women, and 8% is the coverage of the target area. In Bukhara, for this time we have we have conducted screening of more than 195,000 women, and the target group audience coverage, target group coverage is more than 89%, almost 90%. It means that they are coming to the second round and the third and a 10th round, as it is planned. And we are planning to conduct another activities. We have mobile mammographical cabinets, and for 2022 we have identified 898 cases.
Ну, порядка 4000 новых случаев рака молочной железы.
We had many cases of new identified diagnoses, and within the limited resources. And in Bukhara we have a peak during first 2 years, and then we had some slowdown in the coverage, and it is related to the fact that in many regions we have fulfilled the program for the coverage, and we have investigated only women after 45. And by study stages, I would like to specify 11.7 7% in Bukhara. At the first stage, we have identified 22.2%, which is 2 times higher. Next. We have identified diagnosis of the breast cancer. In 2020, we have identified 253. Those are cases identified during the primary investigation and the diagnosis, and we can see that compared to 2018 and in 2023 it was 2 times, like 149, and the number of women participated in the screening maybe the target group is another, like shall be less than 45 or after 45.
Они могут по своему желанию продолжать делать маммографию, но моложе 45, конечно, проводить маммографию малоэффективно, малоинформативно, потому что высокая плотность груди. Дальше. В гистологической структуре вот...
In the histological structure, we have invasive and intergenal carcinoma are the main reasons of the cancer, and here the share of these cells need to be about 40% according to the criteria defined by the international organizations, and we have 87 cases of non-invasive in situ cancer cases. The first results, thanks to Dr. Danish, were presented in a congress in San Antonio, and we hope to each cases have their own problems and the features, and the more problems we have in the future for those who are starting. The results of the pilot program says that it is essential to conduct the further identification and implementation of the early screening for the breast cancer. And the previous speaker has mentioned that the access shall be provided to each woman, even though if it is not, if they are not participating and not covered. Our main task not to equip each district medical hospital or polyclinics with the modern equipment, and based on these technologies, with the use of artificial intelligence and the other technologies, we shall help science to improve the diagnosis at the early stage. Thank you very much, Alexander Vladimirovich, for your presentation. The mammological screening was improved, and we have achieved significant results in a mammoth screening, and I think that we can consider you as a father of mama screening in our republic. I would like to thank you for your commitment and your hard work you are conducting. And now we have opportunity at the high level, this mama screening.
Пожалуйста, кто хочет выступить из наших гостей, пожалуйста.
I'd like to ask a question for your screening program. Firstly, thank you for your great presentation. I know the median or mean age of breast cancer in Uzbekistan, also Kazakhstan, also in Turkey is very young. I would like to ask a question about your screening program. What is the mean breast cancer age according to in screening program detected breast cancer in Bukhara?
Спасибо за вопрос, но в качестве одной из стран, где мы изучали модель мамоскрининга, это была Турция. И мы, не 100%, но масштабировали эту программу, которая проводилась в Турции, у нас в Узбекистане. Есть перевод?
What did you say?
So we studied Turkish model before starting this, and our data is practically same.
Прогноз хороший в том плане, что, опять-таки, как я сказал, что имея центральный архив, мы имеем возможность выявлять рак молочной железы в Бухарской области, поскольку сейчас там оборудование во всех районах есть, и женщины могут приходить регулярно, каждые 2 года, у нас хватает мощностей. Мы будем выявлять рак на нулевой и первой стадии.
Did he mention about the mean age of breast cancer?
Какой был средний возраст выявления рака в этой группе?
Вот спасибо за вопрос. Я хотел сказать, что это обширный материал, и мы можем его изучать. Но я вам скажу, это был средний возраст 50-55 лет. Но есть... Дальше идет возраст 45-50 лет, и уже как бы 4-я группа, 3-я группа, это будет возраст 55-65 лет.
So it may be 50, the first group may come in between 45 to 50, the second between 55 to 60.
Thank you for the answers. And I'd like to comment about second thing for screening programs. Every country has a unique woman, breast shape, culture, and health organization. For example, Korean woman's breast shape or body shape is different compared to our country or Uzbekistan. For example, United States median breast cancer age is 61. In our country, 51, 11 years less. So we should individualize for every breast cancer screening program according to culture and health cost program and other things. Thank you.
Медиана возраста выявления рака в разных странах разная. В Корее она другая. В Америке это обычно медиана 61 год, в Турции 51 год. И поэтому мы должны свои программы по нашим данным как-то контролировать или организовать.
Спасибо.
Я представлял эти данные в Сан-Антонио, в Америке. И, конечно, мы должны понять одну вещь, что такую цифру от нас никто не ожидает. Поэтому будет очень много вопросов. 200 тысяч населения. Самый первый вопрос, как вы вызвали больных на эту организацию? То есть как можно женщин заставлять, чтобы они пришли и прошли этот анализ? Это понимать в других странах очень сложно. в любой стране. Это было бы это Америка или Англия или что-нибудь. Это очень сложный вопрос. Конечно, у меня был ответ на это. То есть я на это просто отвечал очень просто. Это Узбекистан. Это другая страна, это другие люди. Люди слушают друг другу. И тем женщинам, кому звонили, что вам надо приходить, почти они все соглашались на приход. Никто вопросы не спрашивал. Это другая нация с другой менталитетом. И это как раз такой пример, который можно показывать, что люди слушают, если они верят в систему. Другой вопрос был, как можно было их прослеживать. То есть самая главная проблема, вот можно сделать маммографию, сделать скрининг, там нашли что-то неправильное, а что дальше? То есть это во всех странах проблема. Конечно, мы желаем, что если мы нашли заболевание, мы должны ее лечить. И вот на это у меня был очень простой ответ. В Узбекистане существует последовательная система наблюдения больного. То есть как только диагностируется на маммографическая какая-нибудь опухоль, там есть точная возможность прослеживания. Сразу больная идет в районную больницу, там есть возможность полного лечения. И биопсии, и хирургии, и лучевой терапии, и химиотерапии. То есть скрининг и диагностика в Узбекистане это поставлено на высочайшем уровне. То есть мы там не только диагностируем, мы до конца долечиваем. То есть вот это самое главное. То есть это не просто скрининг, и это лечение, которое обеспечивает система. То есть система здравоохранения существует, и поэтому мой ответ был, мы могли сделать такую громоздкую программу скринирования. Спасибо.
Ну что ж, спасибо, доктор Денис, за ваше высказывание. Уважаемые коллеги, мы сегодня с вами прослушали 9 докладов. Все доклады весьма интересные, познавательные, информативные, с глубоким содержанием. Поэтому я не могу выделить из всех этих докладов какой-то один доклад или пару докладов, которые заслуживали бы большего внимания. Они все одинаково интересны, одинаково информативны, они очень хорошо подготовлены, сами докладчики очень доступно доложили нам свой материал. На высоком техническом уровне и методическом уровне подготовлены доклады. Так что я выражаю благодарность всем докладчикам сегодняшним, которые доложили свои результаты исследований. Я думаю, что они будут полезны для нас, для онкологов республики. Несомненно, будут полезными. Я хочу выразить благодарность всем участникам сегодняшней конференции, которые присутствуют у нас здесь. Спасибо, что вытерпели, посидели, послушали все эти доклады. Это, я так думаю, очень большая польза для нас. Я еще хочу поблагодарить организаторов сегодняшней конференции, бухарский филиал онкоцентра, который приложил очень большие усилия в организации данного мероприятия. Практически никаких проколов, вот сегодня первый день уже считается пройденным, никаких проколов организационных не было, и дай Бог, завтра тоже не будет никаких проколов. Все было тщательно продумано и организовано. Выражая всем сотрудникам онкоцентра Бухарского свою личную благодарность и, естественно, благодарность всех нас. Спасибо вам большое. На этом сегодняшнее заседание нашей секции заканчивается. Завтра конференция продолжится. А сейчас я вас всех благодарю. До завтрашнего дня. Спасибо. До свидания. Да, намечается сейчас торжественный ужин. Всем просим